Good morning and welcome to the 6th Annual Free Market Medical Association Annual Conference. My name is James Dunavant. I'm the Executive Director of the Free Market Medical Association. We had planned on having this conference live, as many people had planned their conferences for 2020. We had planned on this conference to be in April of this year in the Dallas-Fort Worth area. Unfortunately, COVID-19 and state and local governments had some other plans for us, so we had to move the conference, the large annual conference, to 2021. I'll talk a little bit more about that a little bit later, but we decided that this topic is so important that we wanted to have a mini conference where we would bring in our keynote speakers for this virtual conference today, and then we have some more speakers live in Oklahoma City tomorrow, and I'll tell you a little bit more about that later. But first of all, just wanted to welcome everyone. I think we have quite a few attendees, more than 200 at least locations, so maybe a lot more than that if we have multiple viewers in each location. So we have quite a few registered. We would love for you to post your comments in the chat box, tell us where you're from, and as we go through our speakers today, you're welcome to ask questions, and we'll have some Q&A time at the end of each session. I want to start out just by recognizing a couple of our sponsors, and in particular, our host sponsor for today, Lean Frontiers, and we have Jim Hunsinger, who is the president and founder of Lean Frontiers, on with us. How are you doing today, Jim?
Good, James. Thank you.
Yeah, we wanted to host this, or have you help us host this, because you guys have been doing this for a long time. You've been doing in-person and online conferences, so you're kind of the master of that. And we've actually partnered with Lean Frontiers a couple of times over the last year to do healthcare-related virtual webinars and conferences that we were able to present to employers to talk about how they can better manage their healthcare plans. So tell us a little bit about Lean Frontiers, what you guys are up to right now, and we'd love to continue to partner with you in the future and refer our members and those watching today to those past webinars that we did with you guys.
All right, yes, and likewise, and thank you, James, and the FMMA for the opportunity to partner with you and serve as host of today's conference. As James said, I'm Jim Hunsinger of Lean Frontiers, and for those of you who are not familiar with Lean Frontiers and what we do, I'll kind of give you a brief overview. At a basic level, Lean Frontiers builds communities within the Lean community. And to accomplish that, for example, we produce and operate summits, conferences, as James said, on a variety of Lean topics in business functions like process development, accounting, product development, management systems, and the like under the Lean umbrella, as well as with other summits on related skills, Lean skills, like in coaching, Toyota Kata, and training within industries, or TWI. We also produce and operate extensive workshops, certificate programs, and online events. Again, online summits like we're doing today, online workshops and webinars on these same topics as well. So you might also be asking, well, what is Lean? Lean is a unique business model pioneered by the Toyota Motor Corporation as they were working to develop their internal production and business practices based on the early Ford Motor Company when Ford was producing the Model T at their famous Highland Park plant. These methods and practices of the Lean business model are the most competitive business model, developed to date. So within these Lean communities, we help to develop, share, and expand the practices of better business systems, primarily, of course, through Lean thinking. So why are we involved with organizations like FMMA? Well, one of the areas where Lean thinking has been having significant impact is healthcare. Just Google Lean healthcare and you'll see what I mean. The problem is that Lean thinking can only be as successful as the larger system in which it works. In this case, economic systems. So we've spent time exploring Lean's connection to the free market economic principles and practices, and we've really appreciated merging the principles of Lean with the free market healthcare practices that you'll hear about in today's sessions. So thanks, James and the FMMA, for the opportunity to work alongside you in bringing you today's conference, and we're pleased to serve as hosts on today's sessions. And as hosts, there's just a couple logistical things I want to point out. Today's session is being recorded, so you'll get a link to view the recordings on demand, post the event. So please share this link with your peers inside and even outside of your organizations. Another important point is asking questions of presenters. You'll find an area on the GoToWebinar toolbar to submit them. So to increase the odds of us getting your questions, please submit them early, as soon as you think of them, and don't wait until the presentation is finished. This will give us time to receive them and process the questions. James, I think that's all from us on our side now. So again, thank you for the opportunity, and I'll hand it back to you.
Thanks so much. We really appreciate you and all you've done for us. Okay, I just wanted to also thank a couple of other sponsors of this event and the FMMA. Our two platinum sponsors are the Surgery Center of Oklahoma, which many of you are familiar with, co-founded by Dr. Keith Smith. Dr. Smith is also a co-founder of the Free Market Medical Association, as well as the Kempton Group, which is a third-party administrator in Oklahoma City that really has pioneered a lot of free market thinking for self-funded employers. And we'd also like to offer some special thanks to Shanks Web Development, who has helped us with marketing and social media for this event. Just to look briefly to give you a heads up on the schedule, you probably have seen that, but I just wanted to give you a little bit of an overview of what we will be talking about today. At 9 o'clock, we will have Dr. Larry Van Horn of Vanderbilt University, who is a pioneer and a leading expert in healthcare economics and policy. He's been at the forefront of the price transparency movement, but he's also a very entrepreneurial thinker, and we'll be sharing some of his thoughts about price transparency and entrepreneurship. Followed at 10 o'clock, we will have a couple of the leading experts in entrepreneurship to give us a foundational approach to what entrepreneurship means in a free market and why the role of the entrepreneur is so important. I think from that discussion, we will see why healthcare is so broken in the United States, because the entrepreneur has been pushed out of the equation in many respects. After Professor Klein and Hunter Hastings give their presentation, we will bring in Dr. Keith Smith, co-founder of the Surgery Center of Oklahoma and the Free Market Medical Association. Start his business at the Surgery Center of Oklahoma. Dr. Smith gave a talk at the last AAPS meeting about the importance of physicians as entrepreneurs, and that really spawned our thinking as to why we should have this presentation today. I might be having some audio issues, I'm told, so I just wanted to see if that is working correctly. Okay, I can hear myself now, I believe. Hold on. Then we'll have a break for lunch, so you can take some time and have a break for lunch. Then we will have Brady Bizarro of the Phia group to talk about entrepreneurship and the concept of entrepreneurship in self-funded employer plans. At 2:30, we will have John Harvey, who is a very free market oriented advisor and consultant. Here. And at 4, we'll have another break, and then at 4 p.m. we will have David Balat of the Texas Public Policy Foundation to have a little discussion about healthcare public policy, and especially as a result of COVID-19 and where we go from here. Also, a bonus that you might want to check out related to this topic is the most recent episode of the Healthcare Americana podcast. Healthcare Americana is the official podcast of the Free Market Medical Association, and it is hosted by Freedom HealthWorks. And their last podcast that they did just this week that was released, I believe on Wednesday, was with David Goldhill, who is the founder of the Game Show Network, a very successful entrepreneur who has launched a new company called Sesame Health. They are a member of the FMMA, and it's a very fascinating discussion on entrepreneurship and innovation in healthcare that I think everyone should check out. For those of you who might not be familiar with the Free Market Medical Association, I wanted to go through a few slides and tell you a little bit about our organization. If you're not already familiar, the Free Market Medical Association was founded in 2014 by Jay Kempton and Dr. Keith Smith based on their mutual desire to change the face of healthcare. Our goal is to bring together buyers and sellers of healthcare goods and services, thus reducing cost and increasing quality. The most fundamental people in the free market transaction, of course, are buyers and sellers, and the more middlemen and regulations and controls that block that direct relationship between buyers and sellers, the more prices are distorted, and we have less of a free market. So the Free Market Medical Association is really committed to bringing buyers and sellers together in a very transparent free market way. So our mission is to unite all the islands of those and show people that there are many organizations, physicians, buyers and sellers, self-funded employers around the country that are doing healthcare in a more open, transparent, free market way. And if we can help facilitate that growth, then we will get to more free market. We unite our organization or our membership really have to be committed to 3 pillars that are very important to transparency in the free market. And these pillars of the Free Market Medical Association are price, value, and equality. When there is a lack of transparency in healthcare, price can become and has become a product. And so people create these contracts and networks that allow people to hide behind that lack of transparency, and they sell that the price or the hidden price, the secret price or the negotiated price as a product. And when that happens, both the physician and the patient are usually going to suffer because of that, and that's why we've seen prices increase. Value is established when the buyer and the seller agree on a fully disclosed price that benefits both the buyer and the seller. We'll hear more about that from Professor Klein and Hunter Hastings a little bit later as they talk about how prices emerge in the free market. But that value is created because each consumer has their own subjective value. And the price is an indicator of what the consumer values and what the seller is willing to accept for their services. And equality. Price equality is the basis of a free market. So cash is king, And for there to be a true free market, then cash needs to be the basis for equality of prices. Our members, anyone can be a member of the Free Market Medical Association, because obviously every individual is a buyer of healthcare goods and services. But we also have buyers that are proxy buyers for those individuals, and that would be self-funded employers. Those are employers that have bypassed the traditional insurance model, and they are essentially cash buyers on behalf of their employees. So self-funded employers and patients who make healthcare purchases and decisions based on cost and quality are willing buyers. Willing sellers are members of the Free Market Medical Association. I would say the majority of our members are sellers of healthcare goods and services. That would include physicians, direct primary care physicians, of which there are more than 2,000 of those practices and growing all over the United States. Physician-owned surgery centers like the Surgery Center of Oklahoma, the Texas Free Market Surgery Center, and many others are now growing around the country that are offering transparent bundled cash pricing. And then also a lot of our seller members would include imaging centers and labs that are offering transparent cash pricing. So in addition to those two essential components of the market transaction, the willing buyers and the willing sellers, we also have value-based vendors and facilitators of those transactions. We are not opposed to middlemen in healthcare, although we often talk about the role that middlemen cause in the current healthcare system to increase the prices of healthcare. In a free market, middlemen can and often do play a valuable role in facilitating a transaction between a buyer and a seller. That middleman just has to be operating in a transparent and voluntary way and subscribing to the pillars of the free market. So we have many of those that are companies that are offering services to the buyer and to the seller. If you think about in the real estate market, a real estate broker or a real estate agent is providing a service to the buyer and seller, and they both agree, the buyer and the seller agree that that service is valuable. So that there's definitely a role for middlemen in a free market, and those people can and are members of the Free Market Medical Association. Our movement is very decentralized. We are a grassroots movement, and we don't feel like there's a one-size-fits-all model. The market is very diverse. If there are 310 million Americans in the United States, then those 310 million individuals have unique desires and unique healthcare needs. So it's really impossible to create a one-size-fits-all healthcare system that meets the needs of buyers of healthcare all across the country. And that's the more centralized we have become, the more convoluted and distorted the market has become. And that's why the healthcare system has become one of the least free market industries in the United States. So our organization follows that concept, and we have local chapters that are starting up all over the country. We now have approximately 30 local chapters around the country that meet at least once or twice a year. Some of these local chapters will meet once a month or every other month. And you can go to our website, FMMA.org, and find your local chapter. But this is a place where the buyers and sellers in a local market can get together and talk to each other and build those relationships that need to happen for direct contracting and a free market more of a free market system to come about. Another thing that the FMMA has done is to create a platform for our members to post their prices online. If you are familiar with the Surgery Center of Oklahoma, they really made a great stride in promoting free market healthcare by posting their prices, their cash prices online a number of years ago. And so what ShopHealth does is it allows our members that we have vetted and made sure that these members are following the pillars of the free market, that they can post their prices online. So ShopHealth is the name of that website. You can get to ShopHealth through the FMMA site, or you can go to shophealth.fmma.org and you can search more than 4,400 procedures that are now available from more than 175 different providers. So that would range from a direct primary care provider to some very complex surgical procedures. You can find the cash price. So even if you don't use those providers, which we would love for you to use our FMMA members as a place where you would get your medical care, at least a consumer can be armed with the information to know the cash price and go to their local hospital or doctor and say, you know, why, if I pay cash, why would I pay more than what this price is that a cash provider is offering? Lastly, I just want to give you a heads up about the 2021 annual conference. We have already scheduled that, the same as this year. That's going to be at the Dallas Hilton in Dallas Plano, April the 29th through May the 1st. We are very much looking forward to that conference, and it should be a great one. We look forward to seeing all of you in person again. As I said, we are going to have a small gathering tomorrow, Saturday, September the 12th, here in Oklahoma City, where we will have some more great speakers. Dr. Tony Dale of Sedera Health, he's the founder of Sedera Health and the Caris Group, a very exceptional entrepreneur who has recently, been recognized by Forbes magazine. Sedera Health has been recognized by Forbes magazine as one of the fastest growing companies in the United States. They are a health or medical sharing organization that is bypassing the current insurance model. Dr. Dale will be talking about his own entrepreneurial journey, along with Dr. Keith Smith and Jay Kempton, the founders of the FMMA. If you have any questions for them, you can post them here in the chat box, and we will make sure that we ask them those questions tomorrow. We're going to have an open Ask Me Anything session with Dr. Smith and Jay Kempton tomorrow, which will not be broadcast live tomorrow, but it will be recorded and put on our YouTube channel in the next couple of weeks. So we look forward to you seeing that. So we want you to submit your questions. If you're not able to attend, submit your questions for them. Tomorrow we will also have Dr. Kyle Rickner of Primary Health Partners, which is a very successful direct primary care practice here in the Oklahoma City area. They are growing, and they are proving that direct primary care is scalable to medium and even large companies. One of the challenges or the possible obstacles that people have presented about direct primary care is, how is it going to be scalable to the masses, and how could a company contract with a small direct primary care practice, or give their employees many options for a direct primary care practice. And Primary Health Partners have really done an amazing job of partnering with some major employers to provide thousands of employees with direct primary care. So that will be another very great discussion that will happen tomorrow that we will be recording and posting on our YouTube channel. So please follow our YouTube channel if you don't already. Follow our Facebook page. We post a lot on Facebook. We also have a LinkedIn page as well as Twitter. Dr. Keith Smith is pretty active on Twitter, so follow him at the Surgery Center of Oklahoma, and others is a great way for you to keep up with what we're doing. Well, with that, I am going to get ready for our first presenter to join us, who is Dr. Larry Van Horn. I will give you his introduction in just a moment when I can make sure that I see him. Larry Van Horn, I see him on the line now, so glad you can join us from beautiful Nashville, Tennessee. I just want to go through Dr. Horn's bio just a little bit so you know the kind of guy that he is. Dr. Horn is a renowned expert and researcher on healthcare management and economics. He's a leading figure at Vanderbilt and the Vanderbilt healthcare community. His research in consumer-driven healthcare markets assisted the White House in the June 24, 2019 executive order requiring price transparency in healthcare markets, and that was signed into law on November 15th, 2019. Dr. Horn also holds many leading positions at the Owen Business School at Vanderbilt in the healthcare community. He's Executive Director of Health Affairs and founder and director of the Center of Healthcare Market Innovation at Vanderbilt. Welcome, Larry Van Horn. Thanks for being with us today.
James, it's a pleasure. It's a pleasure to be here with you today. I always welcome the opportunity to spend time with my friends who are on the right side of healthcare. I'm getting a little feedback here, as I don't know if that's me or somebody on that side.
I hear a little on your side, but I'm not sure where it's coming from.
Okay. Let's see if we're better now, James. Hopefully you can see my slide deck. Yes, as James said, I'm in Nashville, Tennessee, the capital of healthcare delivery, and have a great pleasure of coming to you today from my cattle farm in Leapers Fork. I put together a deck here to kind of lay out some thoughts on the future of healthcare as I see it, and tell you a few stories, if I might. And also set the stage for how I think about entrepreneurship and innovation to start today's kind of agenda. So hopefully we'll have some time at the end for James and I to get involved in a little conversation and back and forth. It's important that I make it clear that everything that I say in no way, shape, or form reflects the opinion of Vanderbilt University, or for that matter, any other organization with which they have the unfortunate reality of being associated with me. This is Larry giving you his perspectives on how he sees the world and things that I think are important for you to think about as it relates to the future of healthcare in this country. And so I'm just going to kind of go through this, tell you some stories, show you some data, and hopefully motivate you to think about healthcare in a somewhat different fashion. And I'm going to really anchor a bunch of my conversation around the role of markets. I mean, this is the Free Market Medical Association, and a really important component of markets is having prices. And my concern for the better part of my career as an academic health economist has been the fact that we don't have prices in healthcare that reflect a market clearing equilibrium, with supply and demand coming together and determining an equilibrium price that exhausts all gains from trade. And that's a problem. And furthermore, the way providers typically succeed in today's market, I don't believe is aligned with consumer value creation. I think there's alternative business models by which providers can do better and at the same time create more value for their patients as consumers. I'm going to show you data that was troublesome to me. It was my analysis over the last year and a half, 2 years working to support the administration's activities, showing tremendous price variation in medical care services for the same exact service. And that level of price variation just cannot be explained by service quality differences. And it's really, to me, evidence of a market failure. And so I view, as James was talking about to start here, the focus on prices, the transparency of those prices, the transactability of healthcare for upfront transparent prices is the first step that's going to move us in a new direction that is going to help right the U.S. healthcare landscape and challenges that we face in the healthcare delivery market. And I think it's going to create wonderful business opportunities here as well, kind of the focus on entrepreneurship that I'll come back around to. So I'm struck by the fact that if you look at price changes, this is 1998 through June of 2020, and you look at the overall inflation rate over that time period around 58%. But the things that the prices that grew the most rapidly, you can see at the top, hospital services, college tuition, medical care. Those prices have risen much faster than the overall rate of inflation. And if you look at things in the blue, in the dark blue at the bottom, those are items where they've actually, on a inflation-adjusted basis, have become less expensive. New cars, household furnishings, computers, toys, TVs, they've all become more affordable and less expensive. And healthcare, generally speaking, has become more and more expensive over the last 20 years. This is against a backdrop of Americans who are in the commercially insured market having to pay a greater share of their healthcare expenditures. And so, if you just look from 2009 up to 2018, over that 10-year time period, we saw, oops, I don't know what I did here. There we go. We see an increase of, 400% in the average deductible that the percentage of the population is facing at least a $2,000 deductible. And the problem here is that Americans are increasingly facing these large deductibles, and they have no ability to know the prices, and they are going to end up having to spend out of their pocket up to the deductible before their insurance even kicks in. The reality is that a significant portion of Americans will never even exhaust their deductible in a given year, and all of their transactions are going to be effectively out of pocket, out of their HSA or out of their HRA, and they have no ability to know what those prices are and whether those prices are sensible or not. So here, this is showing that if you look, this is from the Kaiser Family Foundation, and you can see on the bottom right, the darkest blue, high deductible health plan with a savings option is the primary growing segment of the structure of health insurance for covered workers. And as an economist, this makes complete sense to me because insurance is fundamentally there for high consequence, low probability events. That's why we have insurance. And if we think back to the days when some of us are old enough here to growing up in the late 60s and 70s, we had something called major medical, and 40% of all healthcare was paid out of an individual's wallet. And you didn't have insurance coverage for going to the doctor or prescription drugs or anything, and the prices were affordable, and people purchased medical care. There wasn't friction in the consumption and the transaction structure of U.S. healthcare, and insurance was there when you needed it for high consequence, low probability. I view this move towards high deductible health plans as being a return, if you will, to the true fundamentals of what insurance is there to cover, and is basically right-sizing the structure of health insurance. And I believe that this trend will continue for the next 10 years. Deductibles will increase, the share of premiums paid by individuals will increase, and it makes it all that much more important that all of us in the commercial market, and that's 160 million Americans, can go out and know what the price is going to be to buy healthcare services of any type across the providers we might choose. So I'll show you some examples here that were motivating for me. This is from 3 years ago, 2.5 years ago now, and this shows my EOBs, and I'm a walking hot mess of medical care issues. And this is showing visits of me going to see my doctors, and the office visits, the CPT codes, 99213, how much was billed, the member rate, how much was applied to the deductible, how much I had to pay out of pocket. And in short, this is a physician office visit on 99213 for $170. They negotiated down to $128. I had no idea what that price was going to be, and I had to pay it. It was applied to my deductible, and I had to pay the $128. Here at the bottom here, going to see a 99214, bill $252, member rate $190. And I had no idea that was going to be a $190 physician office visit. I had to pay the entire thing out of pocket, $190. And then you see finally at the top there, 99215, that was an extended office visit, billed $339, paid $257. I had exhausted my deductible at that point in time, so my copay kicks in and my obligation drops. But up to that point, I had no visibility into these prices, and I was having to pay them entirely out of my deductible. And dare I say that if I had known these prices in advance, there's a chance that I might not have gone and consumed this medical care. And that's a problem. Because the essence in a market-based economy is we focus on value increasing transactions. That's where us as consumers buy products or services we value in excess of the cost of production. There's a price. We value the product in excess of the price. The producer that has a cost of delivering it less than the price. They make profits. I get consumer surplus. There are gains from trade. If I'm buying services that I don't value in excess of the cost, those are value destroying transactions. So last year, here's an example. I went and had a set of lab tests from my doc, and these are the lab tests that he ordered. And these are standard lab tests. I'm getting up in age, so they do the PSA and check some other things. So these are the lab tests they ordered for me. But here's the problem. I didn't know what those prices were going to be until after the fact, right? I'm sorry, I just need to move this little window here. Let me get back here. There we go. And so what you see here is that the charges were roughly $800 for labs. Net of payments and adjustments, there's $144 for the lab tests. On top of it, my physician, Richard Hawk, a great doc, said, "Hey, Larry, let's just have you go down and have a chest x-ray just to make sure you don't have a pneumonia. I have a respiratory infection." What do you see there? Charge $387, adjustments make it that the net amount that I have to pay is $192 for a chest x-ray. And I could go to my friend, James was talking about direct primary care. This is from the Atlas MD website from Josh Umbear. Here are the prices for lab tests at Atlas MD. Those, if I sum those up, is $27 for the lab tests that I was going to have to pay $144 for if I was in a direct primary care practice. Furthermore, I can go on MD Save and see that the price for the chest x-ray was $54. If I walked across the street, literally 1 mile, and I could have bought that service for $54 as opposed to $195. So these prices are all wrong. And we don't know them until after the fact. So this is something I've been very exercised about. I've had the good fortune to have spent time with Dr. Keith Smith over the years, and just a massive fan of him and Jay and the efforts of FMMA and Keith's leadership here. But because of this, I said, this has got to change. We've got to get these prices in a much more visible manner nationwide. And that led to me starting conversations with the administration in spring of last year, having conversations with the president on the impact of price transparency in the fact that we have so many Americans who are facing real healthcare exposure, not knowing the prices. And I started doing analysis, looking at the price variation that insurance companies were paying for the same service by market. And I'll show you a little bit of the data that I was analyzing and producing here. So what you see here is a set of services, colonoscopy here, diagnostic with biopsy, by place, by region of the country, and what the average was, but what the range was. So a colonoscopy could range anywhere from $720 up to $7,000. And as a share of CMS's negotiated rates range from 58% of CMS up to 563%. So look at this variance. The price spread in what insurers were paying, not charged, this is the net contract allowed amounts, was massive by the type of service within regions of the country. Continuing here, and down here, vasectomies, this is particularly noteworthy because I broke it out by whether it's done in an office or a hospital setting. And you can see that doing this procedure in an office space was generally 3 times cheaper than doing it in the hospital. So this is the site of service differential. But in reality, these prices are such that somebody's going to have to pay the majority of this if they face a $6,000 family deductible or an $8,000 family deductible. They're going to pay the entire cost of these things and have no idea what the prices are. The other thing I did was I examined how did the insurance prices compare with cash prices. And so what you see here is a set of insurance bundles, and the Q1, Q3 is the interquartile spread. So it's the 25th percentile to the 75th. It's taking out the outliers. You're just focusing on the core of the distribution. And so an MRI of the head or neck ranged from $646 up to $781. Insurance was paying, that middle band was anywhere between $750 and $3,549. And that's the price with a deductible that you would end up having to pay. So the spread in the cash market was $135. The spread in the insurance market was in the core of the distribution was almost $2,800, so 373%. That distribution, that variation is a real problem, because what that is that's risk. That's the risk to a consumer of not knowing the price. And the providers were arguing rather vociferously that let us just put out average prices. But in a world where you have so much underlying variation in price, means and medians are meaningless. We need to know what the real price is. We need to know what the rate is that I'm going to actually walk in and buy services for. It'd be like if you went to fill your car up at the gas pump, and the prices were going to vary anywhere from $2.50 a gallon to $12 a gallon, but you didn't have any idea what that price was going to be until after you filled your car up at the pump. That variation is replete all across U.S. healthcare. And the point here is that in the cash market, the price variation, on average, 21%. Whereas in the insurance markets, average 125%, and it varies massively by the type of service you're getting. So this here is part of the analysis that I was showing to steel the spine of the administration and policymakers to say, we really need to get this price information out in the market and let markets finally work. So some more evidence, looking at the insurance prices compared to Medicare rates in various parts of the country. So the red dots are where insurance prices, commercial insurance prices, were up to 4 times higher than Medicare for outpatient services. The green is where they were the same as Medicare. And what you can see is in California, you see these areas or 4.6, 4.5, 4.7. If you go up to Nevada, 4.5 times what the Medicare price was. And I use the Medicare price because it's wage adjusted, takes into account cost of living. Whereas if you go down to Arizona here, Tucson and whatnot, the price levels aren't nearly as high as they would be, say, in the Fresno area, where the commercial insurance prices were 6 times the rate of Medicare. The central north part of the country, so Minnesota, North Dakota, South Dakota, in general, prices there, commercial insurance prices aren't nearly as high on a relative basis compared to Medicare as they were in the western part of the United States. But here, if you go to Florida, and just take 3 markets in Florida, Miami, Fort Lauderdale, Tampa, and Jacksonville, you see that the price level varies massively within the state, ranging from relatively lower prices in Miami, Fort Lauderdale of 1.7 times Medicare, up to Tampa Bay, where it's 3.7 times Medicare. And this is in the same state. This isn't that far apart. So why is there this massive price difference? And I believe that it has a significant amount to do with the concentration of the providers in the market. So in the Miami, Fort Lauderdale area, 70% of the hospitals were concentrated into 5 systems, whereas if you go to Tampa, you have 84% of the hospitals in 3 systems. So these prices are all the result of negotiations between insurers on one side and providers on the other side. And because of this dynamic, where they're beating each other up over volume, discounting, it's led to a delivery system where providers have gotten bigger and bigger to try to negotiate more aggressively with providers. And when they can do that, they can increase price. I have a hard time seeing other markets in which this is the dominant way in which prices are set. And it certainly isn't the result of many, many transactions, of many, many willing buyers and sellers selling goods and services in a market to reveal what the market clearing price is. It's entirely different. So a final example here, just to show you the problem with how this plays out in insurance. Assume that you're in Washington, D.C., and you have a high deductible plan with a $7,000 deductible and a 20% co-insurance over the top of that. These are the actual prices to have a prostatectomy in Washington, D.C. with insurance, and it ranges anywhere from $18,000 in the minimum up to $60,000 in the Washington, D.C. marketplace. What would be your obligation? Well, with the $7,000 deductible and 20% coinsurance, you would be on the hook for anywhere from $9,000 up to $17,000. But if I just go over to MD Save and plug in having a prostatectomy in Washington, D.C., I can find that I can go and actually transact, buy for $13,968 a prostatectomy from Augusta Health. In which case, if I didn't even use my insurance, as long as I'm not in the top 25% of the distribution, it'd be cheaper for me to never even touch my insurance and just pay cash. Therein lies the problem with the obfuscation and the opacity of pricing in a world of insurance. So in short, I found that what insurers were paying was on average 290% of Medicare. There's massive price variation, and as much as 446% for like services across the country. And then on top of it, cash prices on average for a market basket of services were 40% cheaper. So, and the mechanism by which these prices were determined was not in a market context that we all believe in as being the efficient vehicle determining the allocation of scarce goods and resources. The prices are all wrong. So that led to the executive order on June 24th, outlining a plan for price transparency for providers of medical care in the United States. And the president had me speak at that event. There's pushback from both providers and payers. Providers concerned that, hey, if I make my prices public, I'm going to lose my ability to get a high rate with payers that don't have negotiating leverage. And the flip side of it was payers were opposed and concerned to this price transparency because they felt that, well, if you make my negotiated rates public, I'm not going to be able to negotiate these low rates in the places where I have leverage. And my feeling is that this process of providers and payers negotiating rates is not the role of insurance. It's become that way over 40 years, but that's not why we buy insurance. So on November 15th of last year, the president and the administration announced the final rule mandating price transparency. And this was not well received, but it was a relatively innocuous step forward. It was for only 300 shoppable services, 70 of which CMS defines, and 230 the hospital can choose. That's all this was talking about. And here's an example of the services from the list of services that are going to have to be made public in a machine readable, consumer friendly format on January 1st of 2021. You can see these are the CPT codes. These are E&M services for going to see the physician. Here are things associated with lab tests that I showed you before that I had no idea what my lab tests were going to be. Here's radiology services, common services that are really commodities that we consume all the time. So you have to make these prices public. And then finally, this is a little bit of an eye chart, but some bundles of surgical services that are more common. And so this is the first step to making prices transparent for a set of services across hospitals in the United States. And immediately they're following, the American Hospital Association sued the administration in U.S. District Court. And they sued, interestingly enough, on First Amendment grounds, saying that under the First Amendment, you can't compel us to speak and show our prices. So this was anticipated. It was expected that this would take place. But what was not expected was that the district court judge on June 23rd of this year ruled in summary judgment for the administration and said that the administration was within its bounds to redefine the prices that were put forward, the definition of prices under the ACA to be negotiated rates as opposed to stated charges. And as all of you know, nobody pays stated charges. And this district court judge determined that this was well within their bounds. Now, the AHA has filed an appeal on this matter. And so it's not done, but as it stands today, on January 1st of this year, we are going to see prices across this country in ways that we have heretofore have not had that luxury to observe. I'm very excited about this, and I think this is going to be a massive step forward to benefit Americans in terms of purchasing medical care. A perspective that Keith Smith, a friend of everybody who's here on this call, launched in late 2000s, 2008, 2009, as being on the forefront of putting real prices for medical care out on the Surgery Center of Oklahoma. One point that I want to make is that when I talk to providers about putting forward cash prices, they say, well, we can't do that. We are precluded from doing that legally. We can't post prices that are lower than our Medicare negotiated rates and whatnot. And I had one of my legal postdocs kind of put together a little analysis of this. But in some of the points here and from the U.S. Code, I think are noteworthy. But in short, under HIPAA, a healthcare provider must permit an individual to request that the provider restrict uses or disclosures of protected health information. This is HIPAA PHI, but it also includes, you can see in red, payment. And here's the statute. And if the patient asks the provider to restrict disclosure, the provider must comply. And so under the code, in other words, if a patient pays in full using cash and asks the doctor or hospital or other provider not to involve the patient's insurance company, that doctor, hospital, or other provider is legally prohibited from reporting anything to an insurance company. They can engage in a cash transaction. And I think that's an important point for providers to remember. So the takeaways here, as we think about this as a backdrop, is that prices have not been determined in a market that reveal consumer preferences and the value they place on services. This is really important in a market context if we believe in markets, because it not only doesn't result in an efficient allocation of goods and resources, but in U.S. healthcare, everybody's focused on orthopedics and on cardiology because they make money, and that's where the prices are high. And as a result, we've invested significantly in those areas and all the innovations that have been there. But it's the result of administratively determined prices that actually don't correspond and comport to what people's valuation might be on medical services, on behavioral services, compared to these surgical services. And I believe price transparency is going to be an important part of driving us to a new market equilibrium. So as we use that as a backdrop to highlight some thoughts on innovation and entrepreneurship, which is the focus of today's kind of series of conversations, some trends I think that are important to think about when we're thinking about innovation and entrepreneurship in healthcare is the continued rise of the consumerism generally speaking, and the importance of the patient's financial responsibility. Providers are going to have to increasingly be concerned with not only what is the price of the service that they deliver, but all the other services that they might ask their patient to consume, whether it's lab tests, whether it's radiology tests, whether it's specialist consults. And you're going to have to be mindful of the fact that that patient is probably going to be on the hook for a good share of that price. You know, if you were to take hospitals in the United States, their two biggest payers are typically Medicare and Medicaid. And then you've got all the commercial insurers, United, Humana, Aetna, Cigna, Anthem, all of those. But if you aggregate the patient responsibility across their commercial insurers, patients' out-of-pocket spending is probably the third largest payment source to a hospital. And they're ill-equipped to focus on making that a beneficial transaction for the consumer. That's a real problem. They're going to have to figure out ways to make it easy and reasonable for a patient to buy medical care services from them. So this whole issue of the financial responsibility shifting from insured to patient is an important trend and gives rise to tremendous opportunity, I believe. Second is there's no question about this continued move away from hospitals to an outpatient setting. And that trend is everything from the move to ASCs to hospital at home to moving care to the home as a locus of delivery to the outpatient space. All of that is part and parcel of a trend in healthcare to lower cost delivery settings. And then finally, I think as all of us get more engaged in the fact that we are spending these dollars, we are going to apply a more rigorous lens around, do I really need this? How valuable is this consumption of medical care, period, to me? And we know that probably 25 to 30% of the medical care that's delivered in the United States has dubious clinical benefit whatsoever. And so there's tremendous opportunity for consumers to benefit from making sure that they're only getting medical care when it's going to generate a therapeutic benefit for them and not consuming medical care that's not going to solve a problem. And there's going to be analytics. There's going to be more companies that are going to be focused on judicious use of medical care and the benefits to consumers from making better purchase decisions around medical care. Combined, these are going to give rise to new delivery and financing insurance models with the consumer as being the focus. And so these are the trends for me that I want to watch. So now let's think about this within the context of entrepreneurship in a world of price revelation, and in the world of market context. So a little backdrop, and I like to use this slide because I find it just jarring to me. And I haven't updated this through 2020, and I probably should. But if you look, this is showing where the healthcare dollar goes in America starting in 1970 up through 2010. So this is roughly 40 years, okay? Hospitals have shrunk a little bit, but doctors and other healthcare professionals haven't changed that much. Drugs and medical devices shrunk a little bit. Nursing homes, roughly the same. But I look at this and I am just struck by how little change there is in where the money goes in U.S. healthcare. Over 40 years, we've had massive technological innovation. Massive. But you could not have engineered more stasis if you were in a centrally planned Soviet Union in terms of quelching or squashing innovation than what you observe here. There's a tremendous capture to keep where healthcare is delivered and how it's paid for the same in this industry. And this is, to me, is a testament to how hard it is to innovate and change in a marketplace where you have now $4 trillion approximately of U.S. healthcare economy, all locked up in being somebody's income on one side with a very vested interest of ensuring that it stays that way. And I believe that the time is right now, and we are on the cusp of seeing significant changes in a lot of this. So how to think about innovation and entrepreneurship. So I don't know how many people are out there who are old enough to remember that bag phone on the left. And I remember that growing up as a kid, and that's the 1970s of the time of the bag phone. This phone, by any current standard, was a very poor product. It had very short battery life. You couldn't talk to very many people, and it was incredibly expensive, right? And it was really only purchased by individuals who had a high opportunity cost of time, executives and whatnot who were using these car phones and these bag phones. And we migrated from that bag phone all the way to a world where we live in a world of having phones that are basically guide our lives. Everybody lives with a phone. And my point here is we didn't get to the world of where we are today by saying, how do we cut and untether all of America from landline corded phones in kitchens in America with 25-foot pigtail cords that you could run into the bathroom and have a call with your girlfriend? It wasn't like some centrally planned objective to get to the world of where we are today. What we did is we started by solving a problem for a small set of individuals for whom there was a valuable solution, and then we innovated and diffused it. So, important point. Innovation and entrepreneurship is not about solving the U.S. healthcare industry's total problems. It's about solving a problem in one sector and then learning and diffusing and learning and diffusing and learning and diffusing. And so when people push back and say, well, it doesn't solve this problem, it doesn't solve that problem, it doesn't have to. All it has to do is solve a problem for a particular audience that they find valuable, and then we expand and diffuse and expand and diffuse. All right. I think it's also important to keep in context that healthcare consumption amongst all of us as consumers is against a backdrop of how we consume everything else in our lives. So if we think back, and this is my chopping up time blocks to just create a story here for you, but if you think on the left, I don't know if anybody here is old enough to remember these signs that you see in rural parts of the country that were that said RFD. And RFD stand for Rural Free Delivery. And in the early days of America, Americans consumed and purchased goods through catalogs, Sears and Roebuck, Macy's catalogs, and then rural free delivery ensured that those products would be delivered across the country. And the locus of consumption was through catalogs at home. And then we moved into this period in roughly the 1960s up through the 1990s, where everybody went to a location to consume and make purchases, the mall. And, kids would, in high school, they'd go and hang out in the food court in the mall. Everything was about the mall. And it was emblematic of the fact that we would leave the home to go and consume and make purchase decisions. And now you fast forward to today with the growth of Amazon Prime. And I'm sure many of you are like me in that there's probably not a day that goes by that I don't have a package showing up on my front doorstep that I bought from Amazon. In fact, I want to go and buy everything from Amazon. It's easier for me to buy from Amazon than go to Best Buy or even a big box store. And so the locus of consumption here has increasingly returned to the home. And I think what's happened over the last 6 months just accelerates this all that much more. We're sitting here now consuming work and healthcare on telehealth and teleconferencing platforms, whether it's Zoom, whether it's DoxyMe, whether you name it. And we saw, when I look at the data, a massive rise following March 15th shutdown in America of the growth of telehealth in the United States. And we saw over an 80-fold increase in 2 weeks in the use of telehealth. And that was supported in part by payment changes, payment parity, as well as regulatory changes in the face of a pandemic. And to me, if you need to make regulatory changes and get rid of regulation in the midst of a crisis, I highly question the need for those regulations to have ever been there in the first place. But it massively jump-started the adoption and use of telehealth in the United States. And at the same time, many of us are doing our work via teleplatforms. So I believe one of the biggest changes coming out of this is a reinforcement of our consumption of services at home, consumption of medical care at home through telehealth. Today, we are down 50% from the peak of the kind of April 15th to June 15th timeframe of telehealth use in America, but we're still 40 times higher than we were pre-COVID. And if you ask me, I want to consume a telehealth encounter with my provider all the time. I much prefer it. It's much more efficient, and it fits much better into my life. And so, as I've talked to and I've done some interviewing on what providers believe the go-forward telehealth level is of use in America, they believe it's probably somewhere around 20 to 30% of what historically was done in an outpatient clinic setting is now going to be done in telehealth. That has tremendous implications for healthcare consumption and just the geographic footprint of healthcare. I guess the final point I'd make here is that as we're learning that people don't need to be in an office and can work from home, it's going to actually facilitate people moving and changing where they live. And so I think the follow-on effects from this COVID pandemic and the move to telehealth and telework is going to generate tremendous opportunities for our entrepreneurs in the space of healthcare. So some examples of prices and innovation here, and where I see this going, and some of the things that I'm currently involved in right now is, I'd be remiss talking to FMMA if not talking about where it all started. And this is from Keith's Site Surgery Center of Oklahoma, posting prices since 2009. So Keith has always been on the vanguard of this, has been pushing this model of all-in cash transactions. And, he will speak with you all, and I'm sure you've all had time with him. He's such a beautiful advocate for bringing the relationship back to between the patient and the provider the way it used to be. But we go from a world there to the likes of a healthcare blue book located here in Nashville, founded by Bill Campine and Jeff Rice, who is trying to make healthcare shopping easy, largely through employers for business, showing price variation and quality variation here in the employer space. And you can see right there at the top, what is transparency? And they are working to provide that. Here's an example from their website. I said, if I need a total knee replacement, he's showing what the price variation is in my area, what insurers are paying anywhere up to $54,000 with a fair price of being 34, but also showing that if I can go to Tenova Healthcare in Harton, which is 62 miles away, and get that total knee for $16,382. This is just further evidence of the analysis that I did, showing that providers are willing to offer cash prices that are far below their insurance negotiated rates, and that creates a tremendous opportunity. Why are providers willing to do this? Because it actually is profitable for them to do it. If I can collect cash upfront on the dollar, don't need to engage in revenue cycle. And the revenue cycle industry in the United States probably is $400 billion of expenditures that is just related to the friction of getting money passed around. It doesn't lower the price to us as consumers and doesn't get providers paid more. And if we can make it a simple cash transaction where the provider is better off and consumer is better off, that's the essence of value creation. MD Save, another Nashville-based company, has been working on this for years, basically putting together bundles and allowing consumers to make cash transactions and with real prices and purchase a voucher for those services. So here, Keith is always wonderful about that, and I could go out to Surgery Center of Oklahoma and pay $15,499 for that knee replacement. Similarly, if I can go on MD Save and in Nashville, figure out, okay, with a 250-mile radius, what are my prices? Well, I can go to Poplar Bluff Regional Medical Center in Missouri and get $15,867 for a knee replacement for a cash bundled transaction all in. Or I could spend a little bit more and spend $16,382 to get that cash transaction 65 miles from me from an orthopedic surgeon, Colin Bills. This is part of the trend. Keith was on the forefront. Healthcare Blue Book, MD Save has been on this, pushing this agenda for years. And what we're going to see on a go forward is this is increasingly going to be the expectation. And this is a world that will make providers better off, provider economics better off, and consumers will end up paying less for medical care. So now let's take this in from the provider space into the services space, into the insurance space. So one of my challenges here is that the prices that we see on these websites are basically the result of providers just picking and putting a price out there. And it isn't really the result of a bid-ask market clearing kind of context and equilibrium. I don't have to shop for gasoline. I know the price is going to be competitively determined based off of a lot of individual consumers basically making trade-offs every day for gas or for milk or for real estate. And there's a competitive market where there's lots of transactions going on. And so what we need is we need a marketplace where people are trading and purchasing healthcare services to create a price that's the result of a market clearing equilibrium. And so one of the ideas that I've been working on is if you step back and free your mind, what if we could trade healthcare assets like we traded stocks or commodities? So think about a healthcare service, think about it as a knee replacement being represented by a blockchain technology, a digital health asset, where providers could put on the marketplace a set of digital health assets for, say, a colonoscopy or for a knee replacement or whatever else on a nationwide exchange. And then on the other side, you could have employers or TPAs or health insurers buying them. And they could have different attributes in terms of time use. They could have expiration dates. And here's the important point, is that the provider would get paid immediately on the purchase of those services for redemption at some point in the future. So it would clean up their cash recognition and the uncertainty around revenue. and they would be able to get that money without the uncertainty about what's going to get paid through insurers. And on the other side, employers, TPAs, or health insurers could hold these, allocate them for services to their constituents. And you know what else? If they get halfway through the year and nobody's using medical care, they could put them back on the marketplace and they could sell them. And we create a marketplace here where these things are exchanged and transacted akin to what other exchanges are, whether it's the CBOE or NASDAQ or New York Stock Exchange. If we could get a highly liquid marketplace here, the prices are going to adjust and they're going to reflect the underlying valuation that all of us as consumers put on these goods and services, not what's being negotiated between two parties that don't reflect our preferences. So I'm excited about this idea. It's an idea that I'm just in the process of working on now to actually solve what should the price be. So finally, here another company that I'm excited about is changing the way we go about purchasing insurance, and that is a company called Sidecar Health that I encourage you all to take a look at. And Patrick Quigley founded this company a number of years ago. But in short, this is a solution aimed at the individual small group market that allows you to go online and get effectively individually underwritten. And you get a credit card. And there are no negotiated rates at all. You basically call up a doctor and ask, what is your discounted self-pay price for your service? And I've got a credit card, and they give you a tool where they show you for the service that you want what other people paid for cash prices in your marketplace. They establish effectively a reference price for that service. You can go wherever you want, but let's say the reference price for physician offices is $150, and you choose to go to a physician that's $100, they'll actually send you a check for $50. You pay the $100, and they'll send you a check for $50. So they sensitize you to the value and the price throughout the continuum. You're free to choose whomever you want, and simply all you do is take the itemized bill and upload it, take a picture of it, and snap it in, and it's all taken care of. And so they help you solve what should be the cash price, and the cash price is lower than the insurance negotiated rates, and the premiums end up being lower than what you would pay for traditional health insurance premiums. So here's a new way of structuring insurance that speaks to the individual small group market in particular, that leverages cash price transparency in ways not only around the consumption of medical care, but the insurance function as well. So here are some examples of things that I'm excited about in terms of where I see the market going in a world of utilizing prices. A final look here is what Walmart's doing. And, you know, Walmart has the potential to do everything at scale. I believe that 90% of the U.S. population lives within 10 minutes of a Walmart. And Walmart is incredibly savvy and thoughtful about how they think about healthcare, generally speaking. And they have they've revised their thought process and created Walmart Health and launching clinics. And they started this in, I believe, Dallas, Georgia is one of their first clinics. But here you can see their prices. Flat fee, $40 for a primary care visit, $50 for an adult to get a dental checkup and cleaning, $45 for an eye appointment, $1 per minute to see a therapist, and lab services and imaging for both primary and dental care available on site with upfront prices. Providers are going to have to respond to this. And this isn't an issue of whether this will or will not happen. This is happening. This is going to happen. It's going to benefit Americans, and the existing bricks and mortar of healthcare are going to have to innovate and evolve their business models to create value at price points when we have these alternatives particularly when the likes of a Walmart is in a position to do this at scale. So here's some examples that make me feel very sanguine about the future. And with that, I figured that maybe James and I would do a little bit of Q&A or discussion back and forth. I just need to figure out how to stop my screen sharing here. There we go. I think we've been taken care of. So here's my opening comments, James. It's always good to chat with you. Where do we go from here?
Well, we have an exceptional group of online viewers today, as we knew we would. A lot of FMMA members, so we have a lot of great questions that hopefully we'll get to most of them. But I just wanted to just thank you again for doing this. I think you hit on some excellent points that tie into our theme very well with entrepreneurship. The fact that uncertainty exists in the reality of uncertainty, and the more the government tries to alleviate this uncertainty, the more uncertainty is created, unfortunately, because we have providers that really are taking on more risk. They need to take on risk as an entrepreneur, not the risk of not knowing if they will be paid for their service. They should be taking on the risk of any other entrepreneur in the marketplace, but knowing that they're going to get paid is something they need to minimize. So let's go back. Let's go to some of our questions online here. We have a couple of things I just want to bring up that someone says, imagine your service provider not agreeing to the insurance contracted rate that is rapidly increasing case and providers stop the contracts. Do you have any comment on that?
So I'm sorry, I'm not clear on the question, James.
Yeah, I'm not, basically just saying that I guess these are, some people that are still in the current insurance model, and if they try to escape from it and offer some cash rates, then they are hindered by their existing contracts.
Well, but they don't need to be. I like to think about it this way. If you're an internal medicine physician in the United States, you're currently billing insurance for office visits, and you might do, say, 3 99214s an hour and bill and get $600 of top line revenue. But the cost of the bureaucracy is so high that the overhead rate in an outpatient setting might be as high as 70%. Most internal medicine physicians I know aren't taking home $600 an hour times 2,000 hours, $1.2 million. They're taking home $250,000 a year. That means you're taking home $100 to $125 an hour. And guess what? If we did just a cash transaction, you could take home more money and the patients would pay much less. All the administrative overhead and bureaucracy has made this so complex and destroyed so much value. And the point is, under HIPAA, you have the ability to do a cash transaction as long as nobody's billing insurance and be done with it. And so rather than billing insurance $190 for a visit, and the alternative could be get rid of your overhead. You alluded to DPC. Get rid of the overhead, do a simple cash transaction, and you'll be better off as a result.
Yeah, and just with the telehealth as an example, only in a government managed economy would people even think about telehealth as being some breakthrough innovation. I mean, that's just something that happens, and DPCs have been doing this for a long time. So now all of a sudden people are saying, oh, look, in a healthcare, telehealth is some major innovation. That the government has stifled so much innovation that we think that's a major breakthrough. Let's look at a couple more questions. What are your thoughts on coverage for pre-existing conditions in free market healthcare system? Obviously, you alluded to some opportunities, some entrepreneurial opportunities for there to be some kind of exchange. But I mean, I would say that the market, a DPC doesn't worry about pre-existing conditions, and there are some other market-based solutions for dealing with that. Obviously, with life insurance, people are buying it at a young age that covers them for long before they might find out they have cancer and might die an early death. But what are your thoughts on that?
Well, the pre-existing condition topic, I want to disentangle and put it in two buckets. There's pre-existing conditions that are really the result of genetic predisposition and whatnot, type 1 diabetes, for example. And the reality is those individuals are going to be more expensive, they're going to be more costly, and there's no way around that. And the reality is that we're going to have a society where we take care of those who got a bad draw. We don't want to live in a world where we punish those individuals. The flip side of this is that you can't ignore underlying information that is predictive of risk. This is why the ACA exchanges failed, because they basically said, we are going to constrain in the ACA products the rating band such that you can't charge the highest risk any more than 3 times the lowest risk. And the result of that is that you had to jack the rates on the lowest risk so high that they dropped out of the market because it wasn't rational for them to purchase. So there is this challenge of you have to price the risk. And when we're really talking about just insurance, not the medical care consumption that we're getting day in, we're talking about the big risk. You have to price that risk, and then we probably have to figure out a way to do some redistribution of financial support for those who've had bad draws. Okay, but you have to disentangle the pricing of the risk and how that risk is being funded. Otherwise, you destroy the insurance product, and that's what happened in the public exchanges.
Right. If payers are paying 2.9x Medicare, do we know how much providers are actually collecting above Medicare if you take into account their overhead?
Yes, I mean, this is one of the things I've studied, and when I've talked to a lot of provider organizations across the country, cash payment can be the best payer of all of them, because when you take into account the adjudication process, the submission of 837 transactions, the denials, the 835 remittances, the non-collection on the patient obligation, hospitals frequently only collect 10% of their inflated prices that they're charging to all of us as consumers in the patient obligation. Here's the deal. You charge me $2,000 for an MRI, that's something that should be $200. I'm not going to pay. If you charge me $300, I probably will pay it. And so by bringing the prices down, provider economics actually can improve, and cash prices can be some of the best payers net of all the bureaucracy and rev cycle and early out and collections and all of the other rigmarole that is now part of a $500 billion cost in the U.S. healthcare industry that creates no value for providers and doesn't create lower prices for consumers.
Also, let's see, the next question I want to ask you, are there other industries that have or had problems with price transparency? Is there any similar legislation to create price transparency in other industries?
Well, I mean, the administration is pushing for some price transparency rules, as you've seen, in drug as well as in insurance. The insurance final rule was out for comment. That's due to probably come out in a couple months. The drug price transparency issue has been stalled a bit, and there's been a number of executive orders. A lot of this is going to be subject to what happens in November. It really will.
Yeah, and I always say that transparency is absolutely essential, but it's not enough, because we have transparency in some of those other sectors that on the graph that you showed with the inflation costs going up. In higher education, we have transparency in higher education, but it's the payment system and the fact that people get subsidized with lots of student loans that are driving up the prices. The same in healthcare. We can have transparency, but we also need to fix the payment system.
Well, yes, James. And as we move to increasing to a world where you and I are going to be paying for this ourselves out of pocket, we get we get much closer to all those other markets where you didn't have the price growth. Because I will tell you, no provider, when any provider sits across the table from an insurer, there is no price that's too high they're going to try to negotiate for. But if that transaction is between me and the provider directly, they're not going to try to charge me these exorbitant prices. They won't do it because I have a budget constraint. And so they're going to charge much lower prices. So as more of this falls under our purview, and the example of sidecar, you call your doctor, you ask what a cash price is that they would charge you. That price is going to be entirely different than what the prices are going through the insurance apparatus.
Yeah, I think we also feel from the standpoint of the Free Market Medical Association that a lot of this can be done on a voluntary basis, that we don't necessarily have to have a lot of compulsory mandates if we get to that critical mass of customers, consumers who have sticker shock and make people aware of the cash providers out there. We get to that point even without, the government mandating that price transparency. Well, we appreciate you joining us today. Unfortunately, we're out of time. We need to move on. We have some more questions that we'll try to get answered. I'll send you the questions that our attendees have presented that we weren't able to get to, and maybe we can get those questions answered at a later time. But thanks for joining us today, Dr. Van Horn, and look forward to talking to you some more in the future.
Always glad to be with you, James. Thank you for your time.
Thank you. Okay, well, I really appreciated that presentation from Dr. Van Horn. He's always a great, compelling speaker, and we're fortunate to have him as part of our movement. Next on our agenda is going to be Professor Peter Klein and Hunter Hastings are going to give us a very good overview of how entrepreneurship and the role of entrepreneurs affect and drive change in a true market economy. And I think as we go through this, we'll see very clearly, will become apparent why healthcare is not following a lot of this market-based entrepreneurship model that we're talking about today. Professor Klein is the Carl Minger Research Fellow at the Mises Institute and the W.W. Carruth Chair and Professor of Entrepreneurship at Baylor University's School of Business, the Hankamer School of Business. He's also a Senior Research Fellow at Baylor's Bow Center of the Baugh Center of Entrepreneurship and Free Enterprise. His research focuses on economics of entrepreneurship, business organization with applications to innovation, regulation, and economic growth. He's been a regular publisher of academic articles and books on entrepreneurship, and we are very pleased to have Professor Klein join us today, along with Hunter Hastings, who will also be helping him and to discuss this topic. Hunter had a very successful career in marketing with Procter & Gamble and JBS. He also is the founder of several entrepreneurial consulting companies, including EMM Group and BHC Consulting. He was also the CEO of Imperative and Procter & Gamble funding marketing software. That's what that was. He's also currently managing partner of the Biala Venture Partners, which is a seed stage venture capital firm with over 20 investments. He holds a bachelor's and master's degree in economics from Cambridge University in the UK. And he also hosts the Economics for Entrepreneurs podcast with the Mises Institute. And our last episode featured none other than Dr. Keith Smith at the Surgery Center of Oklahoma. So you should check out his podcast. Welcome, Professor Klein and Hunter.
Hi, James. Great to be with
you. How are
today.
You?
Excellent.
Well, we're looking forward to your presentation. I know Dr. Smith thinks very highly of you guys, and he will join us at the end of your presentation to talk about how he applied these ideas to the Surgery Center of Oklahoma.
Great. Thank you, James. Are you able to see my slides?
Yes.
Okay, fantastic. I really enjoyed the previous session, and what we're going to do now is sort of take it up to more of a bird's eye view, talk a little bit about some basic ideas about the free market system, the role of entrepreneurs in that system, and how these ideas might apply to medicine. So this is a much more general kind of conversation, but I think it will help to set the stage for some of the discussions that we can have later in the day. Let me start just by reminding us, what as individuals, as families, as members of communities, societies, economies, what do we want in life? What are we looking for, right? We all are searching for
Professor Klein?
Yes.
Hi, this is Dwayne, running the admin side of things. Your slides are getting cut off for some reason.
Okay.
I'm not sure exactly how to correct that.
Sure.
But if we can't figure it out, you might want to just leave the slideshow mode.
Let me, I tell you what, give me just 1 second and let me try another option.
Just want to make sure we can see. Just want to make sure we can see as much as possible. Yep, there it is. Perfect.
How does that? Do you see the entire screen now?
We do. Thank you.
Fantastic. Well, I don't want to cut off the little dog and the sort of at the bottom of the
exactly. That's important.
The picture. Okay, great. Thank you for that clarification, and please jump in if you have any other, if anything else like that happens. So
will do. Thank you.
Obviously this graphic was prepared in the time before COVID, but with or without social distancing, right? We all want some version of the good life with health and wealth and happiness and so forth. The remarkable thing, if you think about human societies and human economies, and we look back in human history, is the fact that through most of our existence on this planet, this was not the kind of life that we led. Right? Through most of human history, people have lived barely at the subsistence level. Even in many parts of the world today, we have people living in abject poverty. That's sort of the historical norm. So the puzzle, the mystery that economists and historians try to explain is, how did we ever get out of this and into the modern sort of civilized societies and cultures that we have today? Sometimes it can happen very rapidly. You've probably seen these before and after pictures in places like Hong Kong, right, which went from a small shipping center to being one of the world's great global financial capitals, obviously under tremendous political stress today. Or look in the Middle East, look at the Dubai of today versus the Dubai of even just a couple of decades earlier. What explains the differences between societies that are just barely getting by versus societies that are growing and thriving and prospering? Sometimes we can see stark differences at a given moment in time, not just looking over time. You've probably seen this famous illustration, this satellite photo of the Korean peninsula at night. What do you notice? South of the 43rd parallel, we see activity, we see lights, we see cities, we see electricity, and of course, north of that parallel, we see almost nothing. Well, it's pretty obvious what is the major difference between the northern and the southern parts of the Korean peninsula. It's not language, it's not culture, it's not ethnicity, it's not history, except for recent history, it's the political system, right? You have capitalism and a market-based economy to the south. You have communism and a state-based economy to the north. So it's not hard to know where to look to find these differences, right? So what is it that got us to where we are today from where we might have been in the past, right? I would claim, and most of you would agree, and our speakers would agree, that what keeps us out of living in a primitive kind of set of circumstances is private property, markets, capitalism. You can see this, of course, in history. Environmental scientists talk about the hockey stick diagrams related to climate change, but the most impressive hockey stick diagram you will ever see, and maybe you've seen it before, is one like this, right? As we try to estimate what was the standard of living like going as far back in time as we can. Some famous economic historians, Angus Madison in particular, have attempted to estimate something like GDP per capita going back to, in this diagram, the birth of Christ. And what we see is that throughout most of human history, GDP per capita has been just barely above zero. It's almost completely flat for 1,000 years, for 1,500 years. And then in the late medieval period, you begin to see a slight uptick, right? And then by the time we get to the 18th and 19th centuries, you see this dramatic upward trend, right? What explains how we lived most of our life just barely getting by, and then all of a sudden we had rapid economic growth, we had an almost a near end of starvation, we had cities and buildings and technology and prosperity and leisure and wealth. Well, it's not hard to understand the reason why. It's dramatic changes that occurred in our social, cultural, and political systems. The agricultural revolution, the commercial revolution, and of course the industrial revolution. In other words, what lies behind prosperity? It's markets, it's capitalism, and it's entrepreneurship. And it's easy to take these things for granted when we live in a market-based society. But it's important to remember that we should not take these things for granted. We can easily lose the benefits of this prosperity if we give up on markets, if we give up on capitalism, if we replace it with socialism or something else, and if we hinder, stymie, or even eliminate the creative role of the entrepreneur in our society. So really what I want to do in the next 5 to 10 minutes is talk a little bit about entrepreneurship. What is it that entrepreneurs do in a very general sense? And then I'm going to hand the stage over to Hunter, who's going to discuss the role of the entrepreneur at a more individual or personal level. And then we're going to have some great discussion on how these ideas apply specifically to the provision of medical care, health services, and so on. Everybody talks about entrepreneurship. Entrepreneurship is a hot topic. You know, entrepreneurs are on magazine covers. Everybody knows who Bill Gates and Steve Jobs are. I used to joke with my students, I would show them a picture and say, when I was in high school, when I was a teenager, everybody wanted to be Jimmy Page. And some of you old timers will know who Jimmy Page is, the guitarist for Led Zeppelin. You know, nowadays kids want to be Larry Page, co-founder of Google. It's funny visual because you've got a rock star from the 70s and a nerd, but I won't bore you with the visual just now. But what do we mean when we talk about entrepreneurs? What do we think entrepreneurship is? Well, in a lot of our discussions, both professional and popular, we think of entrepreneurship as a kind of an outcome or a phenomenon, meaning some behaviors that we can observe, we can see, we can count. For example, if we define entrepreneurship as running a small business or establishing a small business, then we can label as entrepreneurs those who create these small companies or who run these companies. So by that definition, someone running a small firm or a family firm or a startup would be an entrepreneur, but someone running Apple or Google would not be an entrepreneur because that firm has long since gone from being a small business to, you know, a gigantic firm, and its leader is a titan of industry. So maybe we restrict the term entrepreneurship to high-tech companies or high-growth companies. Maybe we think so much not about the company, but what the company does. So we might think of entrepreneurship as the introduction of new products and new services into an economy or into our society. And those are all perfectly fine ways to understand the entrepreneur. However, if you think about how we use the language of entrepreneurship, how we use the term entrepreneur in everyday discourse, we often mean something broader and more general than simply creating a small business or running a small business or starting a tech company. We also might think of, you know, entrepreneurship as more of a personality type. We might say that Dr. Smith or Keith Dunavant or Hunter Hastings these are very entrepreneurial people. Why? Because they've set up new ventures. They've created the Free Market Medical Association. They have bold and creative ideas. So we often refer to an entrepreneurial person as a person who is highly creative, who has a lot of boldness or imagination, someone who exercises a lot of initiative, even if that is not necessarily reflected in starting a company or running a small business, right? It might be an intellectual entrepreneur or a creative entrepreneur in the arts, or even within an established organization, someone can be creative and imaginative. And of course, I'm not suggesting that these different definitions of entrepreneurship are in conflict with each other, only that we don't always use the language in a consistent way. And it may be that sometimes we want to encourage entrepreneurship in this broader sense without necessarily that being manifest in more small companies relative to large companies, or more tech companies relative to doctors' offices, right? Even low tech ventures can be entrepreneurial in terms of creativity and boldness, imagination, and initiative. Now, I'm a college professor. I teach classes in entrepreneurship and economics, and I won't bore you the way I bore my students with a lengthy disquisition on the history of the concept of entrepreneurship in economics, but I will remind you that some of the great thinkers in all of social science have conceived of the entrepreneur in different ways, in terms of a very sort of abstract function or role that the entrepreneur might play in society. A famous Austrian economist named Israel Kirzner described entrepreneurship as the act of being alert to opportunities for gain, opportunities for profit, recognizing an unmet gap in the market and rushing in to fill that gap. Another famous thinker, the great economist Joseph Schumpeter, described the function of the entrepreneur as to introduce something new, to introduce novelty or innovativeness. It could be a new product or service, it could be a new company, but it could also be a new way of doing the things we already do. It could be introducing some activity into a new market, finding a new source of supply for an existing company or to make an existing product. Another way of conceiving the entrepreneurial function. Yet a third way, associated with the American economist Frank Knight, the great Austrian economist Ludwig von Mises, and some much, much lesser thinkers, is one referred to in the previous discussion by James, the idea of organizing activities, and specifically organizing factors of production under uncertainty. So we live in a world of uncertainty, not just probabilistic risk, but a much deeper, more fundamental kind of uncertainty. We don't know exactly what's going to happen tomorrow in the marketplace, with regulators, with technology, around the globe. And we need some actors in our society who are willing to take responsibility for bearing that uncertainty, for doing things under uncertainty. And that's the way that many thinkers, and I myself, have conceived of the entrepreneurial function. Of course, if you want to learn more about what these great thinkers have said and written, there's a lot of literature. I can suggest a couple of books selected completely at random, one called The Capitalist and the Entrepreneur, one called Organizing Entrepreneurial Judgment, which are both available either for free or at a very low price at Mises.org. And you can find everything you would want to know and more about the entrepreneur there. According to Ludwig von Mises, the great 20th century economist who described the challenges of socialism and predicted the failure of socialism, Mises describes entrepreneurship this way. He says, it is impossible to eliminate the entrepreneur from the picture of a market economy. Impossible to think of a market economy without an entrepreneur. Mises goes on, the various complementary factors of production cannot come together spontaneously. They need to be combined by the purposive efforts of men, women, aiming at certain ends and motivated by the urge to improve their state of satisfaction. In eliminating the entrepreneur, one eliminates the driving force of the whole market system. You get that? The entrepreneur is not just a peripheral player in a big industrial economy dominated by managers or technocrats. No, according to Mises, the entrepreneur is the driving force of the whole market system. What does Mises mean by that? Well, let's think about what entrepreneurs in Mises' vision actually do. Well, I think of it this way. Entrepreneurs compete with other entrepreneurs by transforming inputs into outputs, right? The act of production is transforming inputs into outputs. Think about medical care, for example. There are inputs, buildings and tools and equipment, medical equipment, medicines, laboratories. There's labor, skilled labor, the physician, the technician, the laboratory technician, the administrative assistant, the nurse, right? All of these factors of production have to be organized and combined in certain ways to produce medical care or medical R&D or whatever the particular good or service might be. This stuff doesn't happen by itself, right? It requires deliberate action on the part of entrepreneurs. So entrepreneurs purchase or hire these inputs, and they combine them, they transform them into valuable goods and services, outputs that can then be offered in a market system to consumers, right? So we easily know this in the context of, our smart devices, right? So companies, Apple, Samsung, and so forth, right? The entrepreneurs behind these companies, they purchase the equipment, the microchips and the glass and the plastic and the lithium and so forth. They hire labor, skilled labor, unskilled labor. They combine all of these inputs into these devices, and then they offer these devices for sale. And consumers may buy them, consumers may not buy them, right? If a lot of consumers will buy your product or service and will pay a good price for it, you have more money left over, right, than what you spent to bring that thing to market. You've got a profit. If your revenues fall short of the costs that you incurred, you bear losses, right? So entrepreneurs realize profits and losses based on how successful they are at anticipating future conditions when they make their decisions to produce. Remember, production takes time, right? You have to create the device before you know exactly how many people will buy and how much they'll pay. You have to set up the doctor's office or the research lab before you know for sure how valuable the outputs will be. So entrepreneurs act based on expectations, intuitions, beliefs, judgments about the present, what is technologically possible today, what are my capabilities, what kind of resources are available, and their beliefs, their expectations, their judgments about the future. What will consumers want? How much will consumers be willing to pay? Will the economy be in recession? What will my competitors have done during this time? What will government regulators have done? And the point is, and this is something that we try to get across to our students, which is sometimes challenging, is that this is really hard. It's very hard to do this, right? Very smart people like those behind Research in Motion, BlackBerry or Nokia in Finland, thought they were doing it right when their devices dominated the market. It turns out that consumers preferred the devices made by Apple and Samsung and other Android manufacturers, right? A lot of smart people got it wrong in the mobile device industry, and other people got it right. I mean, it's not easy at all to figure out what the future will look like and to take the appropriate actions today. So, what does it mean to be profitable as a firm? What does it mean for an entrepreneur to be successful in earning financial rewards or other kinds of rewards? It means that the entrepreneur was successful in bearing uncertainty. The entrepreneur correctly anticipated better than other entrepreneurs what future market conditions would be. So I think of profit as the reward for successful uncertainty bearing. By the way, that shows some of the fallacies in popular understandings of profit. Some people think profit is just sort of some kind of automatic return to capital. Like if you own capital, you automatically get profit. Like if you own an apple tree, you automatically get a certain number of apples that fall off the tree every year. Well, no, profit is not like that. Profit is not just a markup over costs, right? Now, sometimes accountants think of it this way. Oh, here are all my costs. I'm going to mark it up by 20%, and that's the price I'm going to charge. Fine, you can do that. You're welcome to ask whatever prices you want, but that doesn't mean you can't guarantee to get those prices on the market. Nokia and BlackBerry can mark up their costs all they want, but if people don't want the devices, then those producers are not going to get the returns, and there's not going to be any profit. There's not going to be anything left over. There's only going to be loss. Profit is not the return to having some kind of nefarious market power or exploiting your workers, as in the old, robber baron caricatures of the 19th century. I don't know about you, but it does not bother me whatsoever that Jeff Bezos has however many bazillions of dollars he has, because I don't think Jeff Bezos became wealthy by making other people worse off. In fact, as almost everybody knows, especially during the last 6 months, the ability to get goods and services developed next day to our homes at very reasonable prices has allowed many of us to survive the pandemic and the lockdowns in ways that we otherwise never would have survived them, thanks to the creative genius and the willingness to bear uncertainty of entrepreneurs like Jeff Bezos. So more power to him. It's easy for people to grumble about how wealthy Jeff Bezos is, or how much the boss makes, or some CEOs earn compared to the workers. And yeah, I mean, as human beings, sometimes we don't like large inequalities. Maybe we encourage philanthropy and other mechanisms to help those who are less fortunate. But we have to remember that the profit and loss mechanism and the realization of financial profits and losses, those perform vital social functions in helping us to be prosperous as a society, as an economy, in moving us from that state of poverty to the state of prosperity that we found ourselves in after the hockey stick upward trend, right? What do I mean? Profits and losses provide feedback for the entrepreneur. How do I know if what I am doing is right? How do I know if my business model, if the particular types of goods and services I'm offering to the market are the ones that in fact consumers desire and are willing to pay for? I don't know. Maybe I have to do a little experimentation, and then I learn from those results. Well, if the government says profits and losses are illegal, we're going to tax away all your profits, we're going to subsidize all your losses, well, then I'll never know if the thing that I did is actually the thing that's consistent with what makes other people better off, as reflected by their decisions to buy or not to buy in the market. The profit and loss system helps to allocate resources, including capital, right, to those projects that are creating the most value to society, to consumers. Capital markets direct resources to those entrepreneurs who, if I can use this language, are the most capable stewards of those resources on behalf of society, right? We want people like Jeff Bezos who know how to do it, who are good at doing this, to have the opportunity to do so by having control of the resources necessary to expand, to invest, to scale up. And, if I try my hand at online retail and I'm not very good at it, I don't have the capabilities, well, it's not good for me personally that I lose money, but it's good for us as a society that resources are directed away from me and towards those who are more successful. And of course, it provides each entrepreneur with strong incentives to make the best possible use of the resources, including capital, they have available. Okay, before I turn it over to Hunter, I want to say just a moment about what's probably on some of your minds. Some of you may be thinking, yeah, this is all well and good, and I understand economics, and that's fine for smartphones, that's fine maybe for toothpaste, maybe that's fine for automobiles, but aren't there some certain special goods and services for which the kind of market-based entrepreneurial system you're describing, Professor, don't apply, right? The normal rules don't apply for certain kinds of special goods. I learned from my professor, you might be thinking, that sometimes the market fails, and in the presence of market failure, we need some other mechanism like the nonprofit sector or the government sector to provide these valuable, these special goods and services, like food, clothing, and shelter. Not everybody needs an iPhone 11, but everybody needs food, clothing, and shelter. Can we really rely on markets and entrepreneurs to provide those things? Well, I mean, if you think about that question for even a few minutes, you realize, heck yeah, we want markets providing those things, right? The market system does quite well in providing food to the vast majority of persons on the planet, as well as clothing and shelter. And whenever the government is in charge of the food system, or do we really think government would do a better job providing clothing, especially to the least well-off? Do we want the government in charge of housing? We've seen what a catastrophe the government land use regulations and government public housing efforts have been. A famous quip you might have heard by Milton Friedman once said, if you put the U.S. federal government in charge of the Sahara Desert, within a few months we'd have a shortage of sand. Right? So I say the more important a good or service to society, the more we want it provided by markets and entrepreneurs rather than government. Okay, what about education? What about scientific research? What about healthcare? Right? Aren't these sort of basic human rights, and we should not rely on the market system to provide them? Well, I want to challenge that a little bit. And of course, I've got kind of an easy audience here. If I were speaking to the AMA, it might be a slightly different story. But I just want to remind us that, when we talk about health or healthcare, remember, healthcare is not sort of a homogeneous blob. When we say, oh, we need universal healthcare, every human being should have healthcare. Well, what does that mean? Right? Healthcare is a label, is an abstraction that refers to a whole bunch of very specific things. And those specific things are the ones we actually produce by transforming inputs into outputs, offer for sale in the market, and we have consumers or their insurance companies in our world buying and selling these goods and services. It's very specific things. It's a pill, it's a therapy, it's a treatment, it's a medical device, right? It's a psychological counseling session. It's specific health-related goods and services, information about health, specific kinds of medicines and treatments, and even an insurance contract you can think of as a health-related good or service. So again, what we buy, what we patients and consumers buy in the marketplace is not healthcare in the abstract. It's specific healthcare goods and services, which can be divided up into units, and you can buy one more unit or one fewer unit. I can buy one more pill or one less pill. I can put a Band-Aid over my wound or not. Healthcare is not a 1-0, right? It's a heterogeneous bundle of discrete goods and services. Now, one problem that a lot of people have with this kind of model that I'm describing is that it treats the patient as a consumer. Is that really okay? Right? Okay, yeah, maybe I believe that when people go to acquire shoes, they can look at different shoes and they can try them on and they can decide which shoe they want and they can make an educated, informed decision about what shoe they should wear. But surely we wouldn't say that about healthcare or education. People don't really know what is the appropriate thing that they need, and they don't have information on reasonable prices unless they shop, of course, at the surgery center in Oklahoma City. Well, look, my profession is education. I hear these same arguments in my field. Should we treat the students as consumers of education? And to be fair, there's a lot of criticism of the consumer-based model in education, especially in higher ed. Oh, we're selling degrees to people so they can get ahead in their careers. And don't we professors really know more than our students about whether they need to know Greek or Latin, whether they should read books by Israel Kirzner and Joseph Schumpeter and Peter Klein, or whether they should get to read comic books? I mean, yeah, of course, at some level, the professors do know more about what constitutes a well-rounded education or whatever. But of course, we can't compel students or their parents to consume the things that we produce, right? No, we are competing with other institutions of higher education to offer something, education, skills, knowledge, reputation to our students. And if the thing that we are offering is not of value to the people who want to consume it, we shouldn't be entitled to get their money. Right? I should not be able to live off a cushy government, salary teaching postmodern Marxist literary criticism if nobody in the marketplace actually desires that thing. And I think we can make these same arguments for medicine. But aren't medical markets a unique case of so-called market failure, a salient case of market failure? very famous article by the Nobel Prize-winning economist Kenneth Arrow, 1963, argued that using healthcare as an example, that the amount of asymmetric information, the fact that the patient doesn't know what treatments and medicines will work and the doctor does, means that you cannot exchange medical care on a market. It has to be provided by the government, or the government has to subsidize the cost or provide all the insurance or whatever. I think Arrow is correct that there is a lot of asymmetric information in those markets, but that's true of many, many markets. There's nothing unique to medical care about that. And we have a lot of economics literature and entrepreneurship literature about creative ways that entrepreneurs manage to overcome these information asymmetries, right? I mean, lots of goods and services that we buy on the market. When I buy a new smartphone, I don't know if it's going to be any good. Is it going to be fast? Is it going to lock up and freeze up? Will it reboot all the time? Will it drop calls? Will it be slow? How do I know? Well, I don't know before I've used it. But of course, I don't just buy in and pick a random smartphone from a brand I've never heard of. I either go with a trusted brand, and I know that if that product is really low quality, it will hurt the value of that brand. And I know the seller doesn't want that because that means they'll make less money. Or I study third-party reviews. I go online. I ask my friends. I try to do some research about it. There are third-party information providers who have a financial incentive to do honest and trustworthy reviews and provide that information to potential buyers. Many manufacturers of goods and services where asymmetric information is present offer warranties or guarantees. Hey, I'm so confident that you'll like my product. If you don't like it, you can send it back and I'll give you a refund. There's no reason why these same remedies cannot also work in markets like the market for educational goods and services or the market for healthcare goods and services. Okay, so let me turn it over to Hunter now, just by summarizing some key points. Markets and prices are the best means to allocate scarce, valuable goods and services. And in my judgment, this applies especially to the most valuable ones, including medicine. In a market system, medical providers, whether those are individual proprietors or commercial organizations, hospitals, clinics, they are performing the entrepreneurial function of transforming inputs into valuable outputs under conditions of uncertainty and competing to offer these to buyers, to consumers, to patients. The distinct properties of medical care do not warrant some alternative system like government provision or some kind of special regulation that interferes with the entrepreneurial function on the market. So thank you very much for your time, and I hope I successfully unshared my screen so that Hunter can now jump in.
Unmute. Can you hear me now?
We can hear you. We cannot see your webcam right now. There you are.
Are we good?
Perfect.
Well, thanks, Peter, and thanks, everybody. As James introduced Hastings, I'm not a Ph.D. economist, although I wish I was, like Dr. Klein, but I have conducted a lifetime study of entrepreneurship. I've started entrepreneurial companies. I've managed entrepreneurial companies for other founders. As a co-manager of a venture capital fund, I've invested in a lot of entrepreneurs and coached the CEOs, sometimes successfully, sometimes not. And I've interviewed hundreds of entrepreneurs as part of venture capital activities, interviewing them in pitch deck sessions. Also as part of SCORE, the SBA program to help small businesses succeed, and as the host of a podcast where I get to interview a lot of entrepreneurs. And so I'm going to talk about entrepreneurs very much at the individual and personal level. And it's exciting for me that the FMMA has devoted this conference to the idea of entrepreneurship in healthcare. And I want you to think about it as a noble cause, as opposed to a mission impossible, as you've used in your title. As you'll see, I've made it at least mission possible. And I do want you to think about this essential nobility of the entrepreneur and the entrepreneurial function. And as we answer the fundamental question about what is entrepreneurship, I want to stimulate your thinking about the identity and intent and values of entrepreneurs as people and as individuals. I've got to learn to advance my slides here. There we go. So we're going to talk about how entrepreneurs feel and think and act. So Peter talked about entrepreneurship as driving the free market system, how markets work, the benefits that they bring, and that's obviously fundamentally important. But let's now think about the next level of market operations, and that's the implementation role of the entrepreneur. Because when we say that entrepreneurship is the driver of the free market system, markets are a concept. They're not action. And what the entrepreneur does is act. The markets are an emergent phenomenon, a result of entrepreneurial actions in relation to individual consumers. That's patience in your case, obviously. And just let me make a little side remark here about consumers and customers. We talk technically about consumers. They're the final beneficiary of the service that you're delivering. Customers in the business literature can be the same thing. They might be consumers, but they're entities that pay for a service. And in your industry, the customer is not always the consumer. So we'll use the term consumers throughout and think of them as the end beneficiaries. Just to elevate this idea of entrepreneurship one step further, we can say that entrepreneurship is the driver of civilization. And I say that because entrepreneurs think about the values that their consumers hold most highly, and they try to nurture those values in return for a profit, as Peter explained. But this upholding of values, this elevating of values to the highest level is part of what entrepreneurs do. We talk about the search for highest values, and the search for a healthy life is one of those very highest of values, and that's what entrepreneurs in medical markets are doing. So we're talking about the result of a focus on consumers' values. And another remark that we make is that the consumer is the boss. The entrepreneur listens to them. In fact, we use the term consumer sovereignty. The consumer is not just the boss, they're the king and queen. And their search is for betterment. They want things to be better. I wish things were better is a typical remark that you might get in your research. And it's the genius of the consumer always to be able to understand that things could be better. They're the relentless driver of the entrepreneur in turn. Can be better. There's some way to improve. And the job of the entrepreneur is to interpret this dissatisfaction, to devise solutions to address that dissatisfaction and take it away. And that's what we call innovation, that something better, something improved, something improving the life of the consumer. So we're upholding values, we're chasing betterment, we're interpreting dissatisfaction, and we're bringing innovation. And behind all of this is an ethic. We actually call it the ethic of entrepreneurship. And that ethic is one of service. So we said that the consumer is the boss, the consumer is the sovereign, and the role of the entrepreneur is to serve, to submit to the consumer's decision about what is better. And the idea of profit, as Peter explained, is that you're successful in interpreting that dissatisfaction and in delivering a solution that is better. And Peter mentioned some of the vilification of profit. Profit is a very difficult thing to define in economics. It's not very difficult in accounting, and that's the kind of profit that people often vilify. But there is such a thing as psychic profit. And we find from research that entrepreneurs don't enter into their initiatives in order to become rich and famous, typically. They often enter into it for psychic reasons. It could be a search for meaning and purpose. It could be a willingness to contribute, to, as we've said, make things better, to achieve something, to make something of your life. And so we call that psychic profit. And that's very, very important to the entrepreneur, not just the monetary accounting profit, but the psychic profit of doing something that makes the world better and makes consumers better. The feeling that you're better off because you made other people better off. So let's talk a little bit about the role of the consumer a little bit more. I saw Dr. Smith in one of his videos say that doctors and physicians and medical service executives and practitioners sometimes have a difficult time thinking of their patients as consumers. They just don't use that language when they're thinking about the service that they provide. But healthcare, as Peter said, is a system, just like the economy is a system. And you can think of the consumer as having a role in that system, a particularly important role. And again, I'm very familiar with the arguments that David Goldhill and others have put forward that the third-party payer system has totally distorted the free markets aspects of healthcare. But by focusing on the consumer, we can be reminded of their role in the free market system. So there are 5 points to make here. It's often said that entrepreneurs aim to produce value. And that's a term that you often hear in business school and business books, creating value. Firms or entrepreneurs create value. Well, they don't. The consumer is the one who determines value. We can say that value occurs entirely in the consumer's domain. It's in their head. It's a feeling. And we'll explain it in a little bit more detail later on, but it's what the economists call subjective. It's felt by the consumer. They determine it. And so what the entrepreneur does is facilitate that feeling. And it's a little bit of a humble role. We have to understand how they feel value, and then we have to facilitate that feeling. The context for value is what Peter would call the consumer's choice of ends and means, meaning that they have goals. They have goals in life, they have goals for their family, they have goals for themselves. And having established those goals subjectively, every individual is different, they choose means. So when a healthy life is their goal, the means could be you as a doctor, it could be the clinic, it could be all the various aspects of resources that Peter referred to in the healthcare market. But they choose the ends, and the entrepreneur tries to give them the means to achieve their ends. And in the free market, of course, there's choice. That's how the market works. Consumers are the ones who exercise choice. They do so with their own logic. Now, often they'll be accused of being irrational, of making irrational choices. Consumers never make irrational choices. They use their own logic, their own emotions, their own subjectivity to make those choices, but they're always doing it rationally. We talk about opportunity cost. When they choose one thing, the opportunity cost is they discarded something else. So that if you can provide them with a choice of something that's better, it's an improvement over their opportunity cost. They're always making the right decision. The job of the entrepreneur is to give them the right means to achieve their ends. And then after choice, comes experience. And this is, again, how we think about value. It's an experience. And I'm going to explain exactly how it works in a second. It's a feeling. And there are many, many different elements of it. And the ultimate assessment of whether or not I had a valuable experience is quite complex. So the entrepreneur is trying to interpret that and to make sense of it, to understand the feelings that the consumer has in order to make them better. And the currency, if you like, for that is what I've mentioned before, dissatisfaction. Think of it as a resource. In fact, it's a universal resource. It never goes away. It's entrepreneurs' fuel that you can sense, feel, empathize with consumers' dissatisfaction, and then we have the opportunity to see if we can resolve that dissatisfaction. So it's the raw material, the building block, the fuel for the machine. So then the role of the entrepreneur becomes all of those processes that we just talked about reversed. So we actually talk, I think this is Peter Klein's own wording here, about empathic diagnosis. We actively use the metaphor of the doctor and the patient. And the great skill is empathy, trying to feel what the consumer feels. And it is a diagnosis. The consumer can't tell you what the better solution is. They can only tell you the dissatisfaction. I feel some pain. And a doctor would act, well, where do you feel it? How bad is it? On a scale of 1 to 10, how would you rate it? Is it in the front or the back? And so on. You're asking questions as a part of a diagnosis in order to get the consumer to give you enough information so you can start to identify the solution. The entrepreneur does the same thing for consumer dissatisfaction. So empathy is the skill, getting inside the consumer's head and feeling what they feel, which is a very difficult challenge. It's what the psychologists call a counterfactual. You can't actually feel what they feel, but you try to do that as much as possible. And then the solution is a process of imagination. Again, it's counterfactual. You're trying to imagine what a better future would be. And so that's a creative function, not creative in the sense that some people are more creative than others in drawing pictures or playing music, but in imagining, using your imagination as a tool to identify possible solutions in the future. And imagination can then become creative design. If I can imagine that, how can I design a process or a business model or a new clinic or a new treatment that addresses that dissatisfaction and actually constitutes the solution that I have imagined for the future. So creative design is something that we can learn. It's a process. And then the period of great uncertainty, of greatest risk, if we can use that word, of toil and effort, is the assembly of resources. And Peter referred to this in pulling together all of the people and machines and real estate and so on that you need to start a clinic. And he talked about time, that it takes time to do that. And that's the most dangerous period for the entrepreneur because money is going out, you're expending on these resources, and time is passing and no money is coming in. And so this is one of the periods of bravery and resilience and self-confidence and self-reliance in assembling the resources. And that's one of the reasons why the entrepreneurial role is so important. And then at the end of this, you make a value proposition. So as we said, entrepreneurs can't create value. They can merely humbly propose it to the consumer. I've listened to you. I've understood your dissatisfaction. I've imagined how I can improve it. I've assembled these resources. I would like to invite you to at least examine my proposed solution. So again, this humble role of the value proposition. Now I'm going to show you one chart. And because of where I took it from the inventory of charts, it uses the word customer as opposed to consumer. So just substitute consumer or patient for this. And I just want to give you a sense of how you get inside the consumer's head in understanding their value assessment. It's a learning process for them. So in the bottom left there, you've listened to their preferences and their goals, and maybe they've talked about previous experiences that tell you about their dissatisfaction. You make your design, and then you make your value proposition. What the consumer is going through is a series of value experiences. We call the first one predicted value. Is there anything in it for me? Should I even listen to this person who's making me this proposition? That's an absolute yes, no kind of decision. If they say no, you go back to the drawing board. They then go through a relative value assessment. Well, given what I've got now, is this liable to be better? Is it better than other choices? If I compare it to another proposal, is it better? So qualitatively, they're going through this relative value assessment. Eventually, they'll get to the point where they say, is it worth the money that I'm being asked to expend? So that's the exchange value. But it's not just money, it's an opportunity cost, as we explained. You know, what are all the costs that I have to exchange in order to get this value service that is being proposed to me? They then actually experience the value. Maybe they're in your clinic, maybe they're in your hospital, maybe they've made a visit. There's not much that you can do at this point other than monitor their experience. How does it seem to you that they're dealing with that experience? And then at some point later, they do a value assessment. Well, did it meet my expectations? Was the promise kept? Did they overpromise or underdeliver? Those kinds of value assessments are made by the consumer, and then the wheel can continue. So if they say, oh, that's great, I would definitely go back there. That's their next cycle of predicted value. That doctor was better than anyone I've ever met before. That's a statement of relative value. Worth every penny. That's a statement of exchange value. So the consumer is constantly going through this cycle, and the entrepreneur is trying to make things better at every stage. Communicate predicted value better, compare the alternatives better, make sure that the value in terms of money or opportunity cost is better, the experience is better, so that the consumer will assess it at a higher level. So that's an economic flow chart. What it really represents is life. The consumer is living their life. There's a lot of things going on in their life. Healthcare is obviously a very high priority, and there are times when it's the highest priority, but there's a lot of other things going on in their family and in their business and in all of the things that they do in life. And you're asking to be invited into their life. You recognize all the value scale complications that they're going through. You recognize that while they want a healthy life, they may also be worried about the cost and the impact on their family. You're asking to be part of their life, and if they invite you in, then you try very hard to be a good servant to them in terms of making their life better. So I used these words at the beginning, and I'd like to just emphasize them now. What is your entrepreneurial strategy? And the business school will tell you that this is a giant document or a giant piece of thinking or a plan, but actually it's individual. It's about you. Entrepreneurs are always individuals. They may work together in a team, they may collaborate, they might all come together in a firm at some point. They're certainly in a network. They're certainly in a collaborative group of service providers. But ultimately, entrepreneurial strategy is individual. And it has these components. We call the first one identity, which is, who am I? What kind of an entrepreneur do I want to be? What kind of a consumer improvement do I want to deliver? What's my specialization? Do I really want to be an entrepreneur? Do I want to take that kind of uncertain risk? And so self-assessment, understanding your own identity and the identity of your project and the identity of your undertaking is one of the components here. The second one we might call intent, which is, what am I trying to achieve? After all, some of the profit that you're going to make is the psychic profit of achievement and contribution and helping. So what is my intent? What do I think my achievement could be? You'll never get it right. It'll never be exactly what you intended to be, but you want a pathway. You don't know what the destination is, but you'd like a pathway at least to start out from, and then you'll receive all of the feedbacks from the marketplace, you'll make adjustments and so on like that. But what do you want to achieve? And the purpose and meaning that you can get from being an entrepreneur is part of this intent. And the ethic, as we said, is service. And then context. Every act of entrepreneurship, every innovation, every piece of service is context specific. So what is your speciality? What is your region? What is the hospital that you're working for? What is the consumer base or patient base that you're serving? What is the disease that you're trying to address? Everything is contextual, and therefore everything is custom built. There's no context-free active entrepreneurship. So be aware of the market, be aware, as Peter said, of what's going on around the globe, be aware of what your consumers are thinking, and use that as context for your individual initiative. And then also, as Peter mentioned, all of this, the intent, the identity, the context, the empathy, the imagination, the investment, the assembly of resources, it's all done under uncertainty. And Peter's the world's expert on uncertainty, and so you can ask him questions about the word, but I always think of it as the stuff that gets in the way when you're trying to achieve something. And more technically, it's about knowledge. You can't know everything. In fact, you can't know much. You certainly can't know what's going to happen in the future. You can't know what your entrepreneurial action is going to generate as a reaction. You can't know what other people are going to do. You can't know how regulations are going to change in the future. You just can't know about change. And therefore, Peter calls it, you must bear this uncertainty. You've got to be the kind of person who can embrace it and say, I'm willing to go into that role. I'm willing to take on that uncertainty. But it also means being adaptive, that when uncertain things happen, unlikely things happen, unexpected things happen, you take that in as new information and you adjust and you adapt. So we call it dynamic efficiency. You're always moving, always changing, never stops. And that's the attitude of the entrepreneur, is to be happy in that situation of constant change and constant adaptation. So, as I said at the outset, this is not mission impossible. It's certainly mission possible. I think it's mission noble, and it's mission inevitable. I think if everybody in the Free Market Medical Association, and everybody that you influence, and everybody that follows along, all the new people you recruit, that the impact of entrepreneurship will inevitably improve medical experiences for your consumers, which is most important, and for you as entrepreneurs. So let me wrap up there, and we'll figure out how to take questions and answers. Thank you.
Okay, I'm bringing Dr. Keith Smith, Surgery Center of Oklahoma, co-founder of the Free Market Medical Association, in. I don't see Peter, but I'm sure he is on here somewhere. Dr. Smith is, I think, really very much an innovator and leader of entrepreneurship in the medical field, I think, as we all know. Just wanted to comment on some of the things that you guys talked about. There's certainly, as Dr. Smith can attest to, a lot of dissatisfaction that needs to be alleviated in the healthcare field on both the buyer and the seller side of things. We have record number of physicians who are burned out from the regulations and controls that are put on them either by government insurance regulations or being a hospital employee. And a lot of our members are former hospital employees that have taken the step to do things like Dr. Smith have done or become a direct primary care physician. And as a direct primary care physician, they can focus more on the dissatisfaction that the consumer or customer is experiencing and alleviate those things. And it's growing because to the extent that they have alleviated that dissatisfaction, they are very successful. Although, the difficulty for a lot of physicians is that they haven't been taught any of this about entrepreneurship, and they haven't thought traditionally of themselves as being an entrepreneur. So there is a lot of risk and uncertainty in taking that step because under the current model, if they're an employee of a hospital, it's just a lot easier to have that salary coming in, or if you're part of a big insurance network, you're sort of given a plate of customers, so you don't have to do the marketing and work that is required as an entrepreneur. So just sort of laying that groundwork, I thought I'll let Dr. Smith comment on how he applied these principles in the founding of the Surgery Center of Oklahoma.
Thank you. And I think the audience has just an inkling of why we invited Hunter Hastings and Dr. Peter Klein to join us. I would encourage anyone listening to follow up and get Peter's books. They've really transformed the way that I certainly think about all of these issues. And thank you both for joining us. I'll back up a little bit before we'll talk about Surgery Center of Oklahoma and what we sort of had in mind as entrepreneurs when we launched, and back up a little bit about why I think entrepreneurship in this discussion is so important for physicians. I think that there's a real roadblock and obstacle for physicians in particular to think as entrepreneurs because they tend to use the same risk adversity that they appropriately bring to their medical practice in managing their business affairs. And so that is a leap, I think, for many doctors, and it's not natural to be one who embraces risk and uncertainty and launches their own business venture when every single day you're in the position of trying to guide patients and help them avoid risk and practice in as risk adverse way as possible. I also think that the tyrants know this, and I think that there are many in government, particularly those who run dysfunctional programs like Medicare. I think that they know that physicians are naturally fearful and are naturally inclined to not embrace the role of the entrepreneur. And I think that we're trained that way. And I think that people in charge of these big programs know that. And I think that there have actually been arbitrary decisions that have been made. I knew that when I was accepting federal money, which I'm embarrassed to say I did for 2 years before I decided to stop. When I was accepting federal money, every other week, I would receive a letter from Medicare that would say, "This is what you are worth now." So as an anesthesiologist, we were told what our maximum allowable charge was, and that changed regularly. And God help you if you charged more than that. There were severe penalties and fines and even jail time for people who violated that. It was very arbitrary. It was very capricious. I believe it was deliberately meant to put physicians on their heels and to create fear. I think that the Clinton healthcare plan, when that was first when that was first foisted on everybody as a possible future, that created a lot of fear amongst physicians, and what the uncertainty looked more bleak than optimistic, and it drove a lot of physicians into the arms of the hospitals that were more than willing to hire them. So I think we first have to acknowledge that there is this fear and uncertainty out there, but I think we also have to acknowledge its source, and we have to know that if there are attempts to manipulate us or attempts to drive us away from what we might be considering in doing, launching a venture. There's a reason. There's a reason that people do not want physicians to be entrepreneurial, I would maintain, and the reason for that is that it extracts control from those who profit from the current situation. So I would encourage everyone to be bold, to be mavericks, to realize that the real fear is on the side of those who are exercising this very nefarious attempt to really prevent all of us from thinking as entrepreneurs. And I think that there is so much value in understanding the nuts and bolts and the mechanics and the process and the proper definition of entrepreneurialism. I think that is the beginning step of acknowledging what our role is and assuming our proper, and I love how Hunter said it, our noble place. One of my partners, Dr. Chris Paskowski, has said from the very beginning that he does not believe it is possible for a physician to claim to be their patient's advocate when they are a financial predator. And I think that we need to be not just medical, but also financial advocates for our patients. I also think that the typical response many physicians have had, and everyone probably has heard this, I just want to practice medicine and I want to leave all the business and money stuff to the other folks. That's really a cop-out, and hopefully by now everyone can see that approach means you're abandoning patients to the wolves whose intent is not noble. So when we launched the Surgery Center of Oklahoma, I think we had many of these things in mind. We had really just two missions. One was to deliver the highest quality of care at a reasonable price. The other was to make sure that when patients arrived, that they would know exactly how much they were going to spend. If they had insurance, we told them what we expected from them. If they did not have insurance, we told them what we expected from them, and in a bundled fashion. So a cash out the door price. So that was our mission when we started. We knew that there were gross inefficiencies at the hospitals that should be easily overcome, and we took a risk and walked that path. Many are not aware that the day before we actually bought the operation, the Surgery Center of Oklahoma, the bank pulled our financing on a technicality. They claimed that our guarantees that were signed by the original 12 physicians were no good. And so Dr. Lantier and I had worked hard to create and secure those guarantees. Getting 12 or 13 surgeons together is like herding cats, and that was not an easy thing to do, to secure those guarantees in the first place. And the bank pulled our financing and said, no, these aren't any good. So Steve Lantier and I, the two of us, completely funded and bankrolled the Surgery Center of Oklahoma when we started. It was just the two of us. And we tried to get new guarantees, but by the time we'd created new guarantees, our accounts receivable was large enough, the bank was comfortable attaching to that as collateral for our startup loan. So we were very nervous when we started, We did not know much of what we know now. We just had a feeling that there was dissatisfaction in the market. We just had a feeling that patients were overcharged, and increasingly they were aware that they were overcharged, and that they would appreciate an honest conversation about what they were going to pay, not us sweeping it under the rug. And that turns out to have been a good gamble on our part.
Yeah, one thing I've heard you say, Dr. Smith, about the FMMA and the conferences that we've done is that when you go to an FMMA conference, you see some of the happiest doctors that you've ever seen anywhere in one room. So I think that speaks to something I think Hunter and Peter have hinted at, but maybe we didn't talk specifically about a lot today, is about optimism and the role of optimism in the mindset of an entrepreneur. They have to have some kind of optimistic mindset even to start the venture. So what would be your feelings on what makes you optimistic? What made you optimistic I think you've touched on that, the optimism that you saw there was dissatisfaction that needed to be alleviated, but what has made you more optimistic as you've moved forward about this movement?
Well, I mean, to use Hunter's talk as a spring for that question, I mean, I'm optimistic because the surgeons that I work with and our facility as an entity has been invited into the lives of many consumers. And after the transaction, the golden rule, the mutually beneficial exchange we've insist on has obviously been achieved. I'm also optimistic because I've seen so many others follow our path. I'm also optimistic because I've seen those in the marketplace whose intent is not noble have followed our path. There are many patients that are using the available pricing that is in this growing marketplace to leverage a better deal from their otherwise price gouging local hospital. I'm actually working with hospitals who were sworn enemies in our beginning days, who worked very hard at our state capital to put us out of business. We are now working with them because we receive, fortunately enough, media attention. Patients request procedures to be done at Surgery Center of Oklahoma that can only be performed appropriately on an inpatient basis. So I'm actually sending patients to local hospitals that in our beginning days were completely bent on our destruction. So the market is, as Rothbard says, it is not just beautiful, it's powerful. And so I'm optimistic because I see the power and the beauty of the market at work, not just at our facility where we're having to respond to what our competitors are doing. I mean, we launched this initiative, and now, you know, I heard yesterday there was some outfit in Maryland that was performing inguinal hernia surgery for a fraction of what we charge online, and that gets my attention. That means I've got to sharpen my pencil and look very hard at what is, you know, what are our margins and how am I going to continue to compete with that? Or are we going to provide additional services and leave the prices the same for any given procedure? So the movement is growing. This organization has been a phenomenal success. I think Jay and I pinch each other at the end of every year when we realize that we're not having to bankroll this organization. You know, there's actually a market for the idea that the free market applies in this industry in spite of Kenneth Arrow's work. So yeah, I remain optimistic. I think that for those that say there's a market failure, I reject that. I mean, the only failures are where the market is not allowed to work. I think the market's like gravity. It's always at work, and you're either in sync with it or not. And if you're not in sync with it, then, you know, you bear only the consequences. If you are, then it's a beautiful, wonderful thing, and there's plenty of bounty out there. I'm also optimistic, I think, because this is a huge market and there's plenty of room for the good guys. And I think that the opportunity there, the demand side, is so much more gigantic than the supply, and that's a really good situation for those who are interested in either changing their ways or launching a new venture.
Great. Well, a question for Peter and Hunter, I guess. We talk a lot about, the overregulation of healthcare and how that's hampered the free market from innovating, as Professor Van Horn had talked a little bit earlier. It's almost like we're kind of stuck in the old days of, shopping malls. If we had the government subsidizing and promoting and creating some special cronyism for shopping malls, would there be an Amazon today? So what can we learn from maybe some other industries and markets where deregulation has worked to open those markets, and how, if we do anything from a policy level, pushing more deregulation of healthcare would be a way forward?
Sure. I can speak to that in two ways. I mean, as you said, James, we can look at other industries. We can look at industries that have been less subject to overarching regulation, like consumer electronics, broadband infrastructure, almost anything in the IT sector, right? I mean, no one could have predicted 20, 30, 40 years ago the kind of explosion of technologies, goods and services, information providers that we have today. A more general point, and I think it really applies to this question, is, we never know exactly what entrepreneurs are going to come up with, but we know if we think seriously about what entrepreneurship is, what it means to compete in a free market, to compete to satisfy the customer or the consumer, right? We know that whatever entrepreneurs come up with and whatever is successful in the marketplace will be something that adds value. Murray Rothbard used to give the following illustration. He said, imagine a world in which the government had always been the provider of shoes. So the government had completely nationalized the shoe industry, or maybe you have nominal private owners, but it's very heavily regulated and so forth. And then some crazy radical, free market shoe association comes along and says, I think we could have a free market in shoes. Why not let the market determine how the footwear industry will look? Well, all the pundits and the politicians and the professors, they would say, are you out of your mind? That's completely crazy. We can't trust the free market to provide something as essential as shoes. Oh, and by the way, if you're going to persuade me to let the market handle shoes, well, tell me, what exactly would that look like? How many different kinds of shoes would they be? What colors would they be available in? How many sizes? What materials would they be made out of? How would shoes be advertised? What kind of shoes would poor people have? What kind of shoes would rich people have? I mean, the correct answer would be, well, we don't know. I mean, we need to let the entrepreneurial market process play out. But we could have told you back then, hey, we know that government ownership and heavy regulation has failed in all these other sectors. Let's let that process play out. So the point I'm making is, look, we can see what the Surgery Center of Oklahoma is doing and say, wow, this is a completely different model. This is a much better model. We're starting to see it diffuse, as Dr. Smith has said. But even so, we're operating under a pretty heavily regulated environment with a lot of government intervention. If we were to relax those restrictions, what would the next great innovation in medical service provision look like? Well, I don't know. I mean, I have no idea because I'm not the entrepreneur who would come up with that idea. We can only imagine what these new things would look like. We can't predict them, but we do know from thinking about it theoretically and looking at it historically that a system in which healthcare entrepreneurs can experiment with offering new goods and services will lead to a broader variety and a higher quality than what we have today.
I love that. Hunter, do you have anything to add to that?
Well, it reminds me of a little story. I had a company once that created a recipe for a combination of fruit juice and sparkling water. And this is a long time ago. And we felt like we had pioneered the category. We'd invented something new, and consumers were going to love it, and we wanted to launch it into the marketplace. And so we wanted to call it something new, a sparkler. And we had to go to Washington to the FDA, and I composed a big presentation about the market and consumers and innovation and what this was and the process and everything about it. And I said, we want you to create a new category called sparkler. And we got a one-word answer: no. You got to call it something that's already on the regulatory books. But that didn't stop us from launching the product. And we introduced the product, and we created a whole new category. And now there are thousands, hundreds of thousands probably, of combinations of various amounts of sparkling water and juice, and the consumers love it, and billions of dollars of commerce probably have been created. So I think entrepreneurs are always faster and better and smarter than regulators. And regulators can say no. And the economic terminology for that is the hampered market. They'll hamper you. But entrepreneurs always figure out a way. And if consumers want the service that is offered, if it's better, the consumers will find a way to consume it. And this pricing transparency is an example of that. So it's context. You've got to recognize that the market is highly regulated. The regulators are going to move slower than the entrepreneurs. There are some on the supplier side that have a vested interest of being cronies with the regulators. But entrepreneurs always find a way. And they find a way because consumers say, yes, I want that. Yes, I want that new service. I want that new organization. I want to participate in a different way. So it's just context. It's you've got to get it right. As Dr. Smith said, there are sometimes awful penalties, but you can figure out a way. That's what I always think.
I always use the example of Uber, I guess, because for so long we thought that the taxi cartels had a market on taxi services. And so someone did have the idea to directly connect buyers and sellers for a market in a way, like you said, that the regulators hadn't thought of creating a way to stop it. So once it grew to a critical mass, it was impossible politically to stop it because consumers were so satisfied with that that would be harmful politically to try to shut down Uber. I know some places have successfully done it, but very few, and it's really grown. So I feel like the direct primary care movement has kind of taken that direction. Physicians have found, a free market, innovative way to bypass the existing system and offer more a consumer-centric service. We have yeah, go ahead.
The point, just to build on that, James, it's a great example using Uber because what the regulators are now trying to do is after the fact, and they're too slow, and you won't be able to put the genie back in the bottle.
Right.
They didn't stop it before it happened because entrepreneurs are far more creative. And Professor Van Horn was talking earlier about blockchain. That's a technology that enables entrepreneurial creativity in a way that's going to be hard for people who want to stop it because it's so private, it's so protected, it's so it's a system into itself. So technology is going to help us as well.
Right. You alluded to David Goldhill. I wanted to refer people again to David Goldhill of Sesame Health had a great podcast this week on the Healthcare Americana podcast, and I think you're going to maybe have him on there. But they've created a service for independent physicians to post their cash prices that would dovetail with direct primary care. So not outside of the membership model. If a physician said, well, I'm really slow on Tuesday, so I'll take individual cash payers for set my price, then they can put that information out there. So I think the innovations like that are really going to drive consumers to shop more for at least basic medical care. We can get back to the idea that just basic primary care needs to be for sure a cash system, and then use insurance, a true insurance model for those major medical type things. We have a few questions I want to talk about or bring up on the question board. One I thought was really great. I think we've talked about this, so you guys can elaborate on it. It says, I believe there is a value in educating healthcare leaders how to become entrepreneurs. Is there a program like this and specific for advancing progressive health reforms? If not, would any of you be interested in starting such a program?
Hunter, this question is for you.
So we meaning the Mises Institute, a number of advisors like Dr. Klein, and a number of entrepreneurs around the country are in the process of building we're calling it a platform. We call it Economics for Business. And it has the intent, James, of exactly what your questioner was asking. It's going to take a value-centric approach to educating entrepreneurs about how to start, run, and make a business thrive. And we have a metaphor, which is an entrepreneurial journey. So it's got a starting point and all the various stations that you go through on the journey. It'll be self-learning, so there's a lot of content there. There's a lot of courses and tools that we're doing. It's also a community where hopefully there'll be some mentorship and certainly experience sharing, questions and answers, and so on like that. So its value will be as a community. And it's in the context of how education is changing. So when you say educate, this is not a 4-year college course and an MBA, or even for many doctors, many more years of education. It's continuous learning. It's on demand, getting the information you need. I was looking at a video the other day. I'm trying to remember the guy's name, Dog MD or something like that. And he was talking about how surgeons are now going to the internet, to YouTube specifically, to get videos of the latest techniques for surgery. And other surgeons are posting those videos to help their fellow surgeons with the latest techniques. And this is not some risky fly-by-night kind of thing. It's a serious exchange of high value, high technology information. So we're trying to build a program like that. The technology is just about built, and we'll launch it maybe early next year. And I talked to Dr. Smith and would talk to anybody about creating an FMMA sub-community or specialized community in there. And if we could get some people to help us design that and make it valuable, we'd certainly like to do that. A shared value group or a collaborative group of people who are free market minded in medical care. So if anybody would like to help us do that, we're very open to the help, and we'll certainly do it.
I love that. I think there's definitely room for mentorship as well with the new physicians coming right out of fellowship or medical school to learn these ideas and work hand in hand with people like Dr. Smith and the many direct primary care physicians that have already sort of paved the trail for this to help them as well. Here's a question for Dr. Smith. Does the Surgery Center of Oklahoma provide care for those who can't pay? As a society, we have determined everything gets some level of treatment, whether they can pay or not. I'm all for free market providing health care, but struggle with taking only those who can pay for our level of care. Basically, it leaves the hospitals with caring for non-payers, and then the government has to prop them up. How do we break the vicious cycle?
Yeah, well, I would rephrase the question. Does the Surgery Center of Oklahoma take care of patients who can't pay how much? I mean, it's it's almost a straw man to ask if someone can pay zero. There are very, very few patients out there that do not have a red cent. And so our attitude has been all along that physicians, to the extent that they're able and willing, and physicians as a profession are incredibly, shockingly able and willing to donate their time and their service. What actually costs money, the supplies to perform the case, that is typically an amount that anyone can afford. I'm here to tell you, running a medical facility, that the supplies required to perform almost all of the procedures that we do are just not that expensive. So, that there are very few patients who can pay nothing. And the other answer I would have to that, when someone asks, what about the poor, is to be certain that the discussion revolves around individual circumstances. Whenever you consider the poor in the aggregate, you really lose focus of what is truly going on with an individual, and you beg for a system solution. So I like to think, not to brutalize Bastiat too much, but I like to think about, what do people do with all of the money they don't spend because they had their surgery at my place or any other facility that's an FMMA member. There is a lot of money that is not spent because patients or employers patronize facilities like mine. What is to be done with that money? I mean, what do people do with money that they actually didn't think they were going to still have in their pocket after a purchase? And the American people are very charitable. They tend to be charitable on a local level much more effectively than they do on a national level. So the answer is yes, we take care of patients who can't pay, but I would also remind everyone to keep Dr. Lantier's quote in mind, that at current prices we are all poor. And so what is it that is going to bring prices down and quality up? And it's a free market. It's an active market in this industry. So we're doing our part, we think, by saying, here's what we do and here's how much it is. Willing to provide services, but not supplies, really free. My dad one time said, if anybody ever asks, how much are you going to contribute to this cause, and the answer is, well, you go first. If somebody asks me, do you take care of patients who don't pay? I'll say, well, yeah, I'll provide the service. Will you provide the supplies? Together, let's, lock arms and take care of this. But typically people who ask the question about the poor and do you take care of patients who can't pay are not willing to part with any of their own revenue. So that's my sort of long-winded answer to that question.
Yeah, and I would just add, with my background in philanthropy and fundraising, I'm very aware that there are a lot of generous donors out there that are giving millions and millions of dollars to nonprofit hospitals that are billing their patients 10 times what you're billing your patients. So there's a desire, like you said, the American people are very charitable, and I'm just afraid that a lot of that charity is being directed in the wrong areas. And so, like you said, if the prices are reduced, I forget what the statistic is, but the number of money and campaigns that are raised every year on GoFundMe for healthcare. I mean, people are trying to raise $30,000 for a hernia when they should be out there very easily from their friends and family. A lot of people would be able to raise $3,000 to provide for that. So, like you said, the cost. If the cost is what the free market provided, then I think there's more than enough charity to go around to cover those. Plus, just the charitable nature of physicians, as you mentioned. Another question for Dr. Smith. Do you plan on listing your surgery center services on David Goldhill's platform? I know you've had some conversation with him and very respect what he's done, and his company is a member of the Free Market Medical Association. Do you want to just add some comment on that?
Yes, he received a spreadsheet with all of our pricing, I believe within a few minutes of leaving after our first meeting. So all of the prices, not just for Surgery Center of Oklahoma, but I believe also for a clearinghouse that I run called Atlas Billing that includes inpatient procedures. All of those prices will be listed at Sesame.
Excellent. We have a student here, I believe. It's really great. Says, I was writing a dissertation currently on the moral failures of single payer is what they mean here, single tier healthcare. I'm curious, as a philosopher, what are some of the major moral failures that strike the speakers as economists, businessmen, and practicing surgeons? I have a feeling it will be different than what bothers the philosophers. So I don't know. Are there some moral? I think you've addressed sort of the moral issues, or are there moral failures with single payer that you find? Dr. Smith, or you want to comment on that?
Not for me. I mean, Peter could probably answer that better. I mean, there's just not the feedback and the accountability to those providing the care. I mean, it's the DMV, where they're going to get the business, even if they're awful and murderous. So that feedback and accountability it's just not there.
Yeah, if we want improvements in quality and reductions in cost over time, the only way to achieve that is with this model of individual and group initiative among entrepreneurs, the ability to experiment on the market, and so forth. You eliminate all of that when you have a single payer or single owner kind of a system. There are no incentives for improvements. There's no way to know if what's being offered is valuable or not. No way to direct resources towards the highest valued uses. Going back also to the previous question about philanthropy and about providing services for those with the least ability to pay. Besides the fact that a market-based system has the tendency to drive down costs to where this is much less of a problem than it would be under the system we have today. You also have to keep in mind that, innovation, technological innovation, particularly in healthcare, is expensive, right? Developing new drugs, new therapies, new equipment is expensive. Of course, part of that is an artificial byproduct of FDA rules and so forth. But even in a pure free market, technological innovation costs money. Where is that money going to come from? Many people think, these greedy business people and others who are earning high profits, they're just using that profits, they're spending it on yachts and, expensive vacations and luxury vehicles and so forth. The vast majority of profits in a free market system are reinvested into R&D and business expansion and development and scaling and so forth. So we need some source of value that can be invested in developing new and better things. And in a system where profits are capped, or where those who earn high revenues are crony capitalists who are, in bed with the regulators and so forth, then we don't have a system where resources can be channeled into their highest value uses, including R&D, investment, saving, planning for the future.
Great.
Yeah, I think, James, we certainly, Peter and I know you and Dr. Smith, believe in the fundamental morality of the entrepreneurial market system. It's the most moral system. What is entrepreneurial can't be unjust, and what is unjust can't be entrepreneurial. And the reason for that is the willing buyer, willing seller duality that Dr. Smith talks about, that if the goal of the entrepreneur is to serve other people, is to do the right thing by those other people, to learn the signals that they're sending and respond to them in the right way. That's the morality. And anything that gets in the way of that is less moral and perhaps immoral. But the market itself is the standard of morality. And the other thing economists think about in morality is thinking in the long term. And doctors are always doing that. They're acting now for their patients, but their goal is long-term improvement. And entrepreneurs think the same way, that what I'm doing now has long-term implication. Things are going to be better in the future. And the morality of long-term thinking is part of markets. So anything that is protective of vested interests in the short term at the expense of the long-term benefit of the patient and the individual, that would tend towards immorality. So maybe the single payer system can be classified like that. But the underlying element is the fundamental morality of the market.
Definitely. It's that voluntary exchange that we like to talk about.
Mm-hmm.
I think we have time for one last question. Dr. Smith, this is kind of a difficult one maybe, but if you were going to give advice to someone who was fresh out of fellowship, the question is, like, if there's an orthopedic surgeon who is fresh out of fellowship, what type of advice or help would you give him to build his practice from a public relations point of view?
Well, the first advice I give any medical student or resident or fellow when they come out is never, under any circumstances, to go to work for a hospital. The dilemma, the moral dilemma, will present itself much sooner than you would think, where what's best for the patient and what does my employer want me to do are not the same thing. So I would advise someone to avoid that common mistake, and that's go to work for a hospital system. I think that there are a lot of independent primary care doctors that are still in practice in the United States. The direct primary care movement is growing. I would encourage a fellow in that position to look on the DPC Frontier website, see maybe where in the United States there is the greatest concentration of free market-minded folks who would refer him patients, who would actually rather refer to someone who's working for the patient rather than towing the line of their hospital employer, and locate somewhere where there's actually a market for providing services to individuals on a free market basis. So that's probably what I would do. There's some parts of the United States that are more friendly to these ideas than others. There's some parts of the United States that are completely hostile to these ideas. And if somebody locates there that's very free market minded, they're going to burn through a lot of capital before they find some success, even if they do.
Excellent. Well, I think that's a good stopping point. If you have any final thoughts, we could go around very quickly before we break for lunch, but we want to thank Hunter and Peter for joining us today. We think the work you guys are doing is great. We look forward to the prospect of a platform that we could bring more entrepreneurial thinking and mindset to the physicians and members of the FMMA. Do you have any parting thoughts?
I'll just say I'm so excited to see what this community is doing. And I view what I do as studying the great entrepreneurs of the present and the past and trying to understand them better, not telling entrepreneurs what to do. So I feel very privileged to have kind of a front row seat to see how entrepreneurial innovation, where permitted, is starting to have an impact and maybe in our lifetimes can revolutionize the medical care industry.
Yeah, I agree with Peter. It's a privilege to participate, and we both feel like we're kind of cheering from the sidelines, but if there's anything that we can do in any way to support the goals of the Free Market Medical Association, we're eager to do that. And I was asking for any guidance that anybody might like to offer as we build our economics for business platform and maybe carve out a section or an aspect of it for the work that the FMMA is doing and see how we can help. So cheering from the sidelines, and would love to get help.
Dr. Smith, any?
My only comment, I'm thrilled to be partnered with intellectual giants like the other folks on the screen, Hunter and Peter. Thank you guys so much. I know my phone has lit up with text messages and emails from people that are listening, and their minds are racing. So your contribution to our movement, I think, is perhaps far more intense and greater than even you might know. Thank you again.
Yes, I think that the great maybe analogy to what we're doing here, to what you guys have talked about with entrepreneurship already, is that these things are not necessarily designed to provide a solution that, hey, here's the answer we're coming up with, but we're generating ideas, getting people to thinking about these things, and just let the market of ideas work itself out. So thanks again for coming. We will answer some of the other questions. I think there was one last question about the book you had referenced. Bastiat was the person that we had mentioned. So we will, Bastiat, Frederick Bastiat. So if you're interested in looking up some of his work, we encourage you to do so. Come back and join us after lunch at 1:30. We'll have Brady Bizarro with the Phia group joining us to talk about self-funded health plans. So we look forward to seeing you guys in about an hour and a half. Thanks. Good afternoon. I'd love to welcome everyone back to the afternoon sessions of our mini online conference. I hope you enjoyed our first group of speakers. I think you're going to really enjoy our afternoon lineup as we talk in a little bit more detail about self-funded health plans and how they can be better designed in an entrepreneurial way to benefit employers and their employees. Our first guest speaker this afternoon is Brady Bizarro with the Phia Group. Brady is the Director of Legal Compliance and Regulatory Affairs at the Phia Group. He joined the Phia Group as a healthcare attorney in early 2016. He specializes in regulatory, transactional, and compliance affairs related to healthcare and employee benefits law. He provides general consulting services to clients, including employers, third-party administrators, brokers, and vendors associated with health benefit plans on matters related to the health insurance industry. Brady earned his law degree from Boston University School of Law and concentrating in health law, so he is very knowledgeable of this subject. We are very happy that the Phia Group has been a longtime supporter and ally of the Free Market Medical Association. Adam Russo, who heads the Phia Group, has been a frequent guest at our past conferences, and so we'd love to welcome Brady Bizarro to join our afternoon session. Brady, how are you?
I'm doing great, James. How are you?
Great. Good to have you here today. We look forward to talking to you about some of the new things you guys are working on related to self-funded employer plans, and we'll have some time for question and answer at the end. So
Awesome.
Welcome.
Yeah, thanks so much. Thanks to FMMA and to Kempton for inviting me to this virtual conference to talk about a really important topic, and that is, of course, entrepreneurship and what it means to be an entrepreneur for self-funded plans, and to look at some of the examples of things that we've seen from our corner of the industry in terms of what plans have been successful with doing and what we think they should be doing as we move forward in really a trying time for the industry and all of healthcare. So what I want to cover in this session, in the time that we have, is a number of things on this agenda. I want to talk about some of the current trends that we're seeing in healthcare and in the self-funded industry in particular. I want to talk about why and how self-funding is not a silver bullet and how that's become more obvious in throughout this pandemic. And I want to talk about what it means to embrace entrepreneurship from a self-funded plan perspective. And then we'll look at some examples and some different strategies that self-funded plans are using to really change their plan design, to change how their plans are administered, to partner with various vendors in our industry to achieve cost containment and realize some serious savings with their plan. And then we'll look at the new normal that we're in now. And again, with an eye toward entrepreneurship, we'll look at how a successful self-funded plan will anticipate the changes that are coming. They will identify opportunities based on the changes that have already happened, some of which are regulatory in nature, some of which are the result of litigation. And then I want to close by talking about three of the biggest areas where I think we've seen a lot of movement and a lot of potential changes for self-funded plans. And those areas are mental health, telehealth, and direct primary care. So those are the things I hope to cover. I know we only have an hour and I want to save some time for questions. But let's dive in to talk about some of the trends that we're seeing. So the first thing we know, right, is that coverage is more expensive every year. So from Kaiser Health here, they're telling us that premiums are going up across the nation. It's not keeping up, or wage growth is not keeping up with the increases in premiums, both for family coverage and individual contributions. So we know that's a trend. We've seen it repeatedly year after year. Another trend that we've seen, which at first glance may seem to be a good thing, but it's not, is a dramatic drop in non-critical procedures. So basically, a number of studies, one from here, community health plans, noting the number of consumers that have delayed healthcare services. They feel uncomfortable going to the hospital. They intend to delay future treatment. I referenced some stats here from the Boston area where Phia is based, and you can see here that the major hospitals are reporting significant decreases in major surgeries, in routine screenings. And the concern there, by the way, is for health plans is that if your plan participants are not undergoing screenings, if they're foregoing important procedures now, that could lead to more complicated outcomes down the path and more expensive surgeries or procedures might be required. So it's not all roses when you think, oh, great, people aren't using all the services they could, it's saving me money. Well, it turns out that it might not. But the glimmer of hope here is that to recognize that there are more tools in our arsenal now than before to deal with this crisis. And some of the tools have gotten bigger. And one example, of course, is telehealth. In the industry at large, what have we seen? Well, we still have a pretty high unemployment number with layoffs sort of mounting nationwide in certain sectors in particular. One study here from Health Management Associates, they claim to forecast about 12 to 35 million people, depending on how many people lose their jobs, might lose their employer-sponsored coverage. That would be obviously a big problem for the industry, and we'll wait and see what that actual number ends up being. But it's a trend in the wrong direction, of course. And when you combine it with the fact that costs are expected to go up, and for self-funded plans, according to the same study, they could see a 7% increase in cost, driven in part by COVID-related treatments and issues surrounding that. So what this means here is the trends are concerning. And to be honest, or we have to be honest with ourselves, that self-funding is not a silver bullet. There's no magic potion about self-funding if you just sort of have a self-funded plan and don't pay attention to it. In fact, some of the studies recently are showing that self-funded plans don't do any better than fully insured plans on cost control, which is surprising. And the reason that that's the case is because a lot of self-funded plans sort of just set it and forget it. They use the same carrier that they were previously with in the fully insured model. They stay with the same PPO network and the same extreme pricing that they see and the same rules. And the point here is that self-funding is really only the first step, that you need to think like an entrepreneur. You need to identify the tools, the partners, the methodologies that you could now use, which is the whole point of being self-funded in many ways, right? To achieve the kind of results that you want to see in your health plan. And so again, the good news is that employers want to offer these robust benefits to their employees and they want to reduce the costs. The bad news is that you can't just set it and forget it. You really got to be paying attention more so now than ever before. And the kind of thinking where you set it and forget it is just not going to work anymore. You have to, in other words, embrace entrepreneurship. The days are gone where you tell an employee, hey, you know, look, we're going to give you a $10,000 raise if you complete your annual review and you know you're doing a good job for the company, and that employee goes out and gets a $100,000 surgery that maybe could have been gotten cheaper somewhere else. Then, you know, is that so good for the employer or the plan or the employee? No, it's definitely not. And so the thinking you have to embrace, and that we've seen the plans that are doing the best embrace, are those that an entrepreneur have, those qualities that make one successful. And those are, some of them, by the way, can't be taught, but some of them can be. So obviously having a motivation and passion for your work, and in this case for the plan and for cost containment, staying informed and anticipating market shifts. This is a huge area here, and we'll talk more about some of the things that I think you should be aware of that are happening in the industry at large. And these are things, of course, again, that you can learn and make decisions based on anticipating what you think the market will do and where the trends are leading us. Innovative and creative thinking, that's where you've got to think outside the box, and in consulting with your partners, with industry associations like FMMA and others, to identify new ways, new strategies to control costs and to sort of free yourself from the burden of what you were facing when you were fully insured, right? Where you have these networks that are controlling everything, where you have very rigid conditions to operate under. And you also want to be able to take risks when you can. That's a key here, that sometimes, you know, you might have to engage in a change in your plan that you're not sure how it'll work out in the end, right? But that's what entrepreneurs do. They take risks, and they're also persistent. So if at first one strategy that you implement doesn't work, try another one. If one vendor lets you down or isn't producing the way you think, well, then be persistent. Find another one. Discuss the problem from a different perspective and see if you can come up with ways to fix the problem in another way. And so again, looking at where the market's going, one of the good things an entrepreneur does is anticipate market changes. What we're seeing, I think everyone here probably knows this, is that we're seeing a drive toward more consumer-driven health plans, these CDHPs, where there's less dependency on traditional PPO plans in that model. We're seeing more HDHPs coupled with health savings accounts. We're seeing the experimentation with other pricing methodologies. So RBP obviously includes a number of different metrics. There's a whole, discussion about whether RBP is successful or not. Many providers pushing back across the country in the courts on this topic here. And then when faced with high deductibles or narrow networks, which will your participants prefer? That's a question that remains to be seen the answer to, but I think we'll learn more about it as we see models like DPC and other things sort of take off as they have done lately. But we can expect, right, health insurance will cost more, and that employers need to be careful about how much they're spending. They can't overspend if you're self-funded. You don't want to get stuck in a situation where you can't foot the bill. We know the cost of care isn't getting cheaper, and we know the cost is being shifted more onto employees. And so, what do you do about that? If you're a plan, what's the best way, the best methodology to really tackle costs? And for us, what we've seen at Phia and what we think is the answer is that it starts with the people. Is that really price transparency, which you've heard a lot about today, and we'll hear about a little bit more later on, isn't by itself enough. Look at the study here from Deloitte, where they asked consumers if they've used an online service to check healthcare costs, or are they likely to do so in the future, and 27% said yes. About half say they're likely to. Have you investigated the provider's quality report card? Only 23% said that they did, and about half said that they would. But when you ask the question and you swap in television for healthcare, the numbers go way up, right? So almost 75%, in some cases 100% did, and they're definitely all likely to do so when they're asked. And of course, they investigated the quality of the television set they were going to buy, because it's a consumer purchase that's expensive, and they care a lot about it. And again, they should care a lot about their health care. And we know that oftentimes consumers don't, because they're not the ones, or they don't think that they're the ones that are footing the bill. Another example here from Payless Shoes. There was a study run where they placed $20 shoes in a boutique setting and gave them a really high sticker price, and people still bought them because they thought that the expensive price tag meant obviously they had to be high quality, right? But again, there weren't any quality metrics. The consumers just saw the price tag, they reached for the brand name, and that's sort of the herd mentality that exists in a lot of the healthcare industry. And so what we're talking about really here is health consumerism, where we need plan members to be provided with a price transparency, to be given the quality metrics, and incentivized to care about the cost and the quality of care. It's not enough to have one without the other. You really need to take, if you're a plan and an employer running that plan, you've got to take the time to invest in educating and empowering your employees so that they know what the best option is for them, what the best cost option is for them, and to let them know that in most cases, you don't have to actually sacrifice quality in order to get the best price. And one of the best ways to do that, by the way, is through employee incentive programs, which many of you probably heard about many of these programs, but here's a list of programs that we use at the Phia Group and that we've consulted on with various of our partners in the industry here. And basically, it's about rewarding your employees, right? When they pick the best doctors, when they pick the best prices and the best quality. And here are some of the programs you can use to do that. Of course, direct primary care is one that's almost always a cheaper option for plan members when it's available. Preemptive consultation for medical procedures. We get asked a lot about this one. Essentially here, this is where you're using data that's provided by third parties like Leapfrog and others to provide to your employees about provider ratings, right? You're not telling your employees what they should or what they must do. Your HR department's not saying, hey, you have to go to this hospital, or I really think you should use Dr. So-and-so. You need to be careful not to be influencing their decision, of course. It's their medical decision on their own. But by giving them information, by having them consult with HR, in some models, you pay the employee just to sit down with HR, $50, $100, sit down for 30 minutes, depending on what kind of procedure that they need, and explain to them the different options in the area. Oftentimes, you'll find that employees aren't even aware of the number of hospitals that could provide, the same procedure that they need that have, if in some cases, a better rating than the big hospital, right? Especially here around Boston, a lot of the teaching hospitals are very expensive, and a lot of the smaller regional hospitals are a lot less costly. But for routine procedures, maybe you don't need to go to that, MGH or Brigham and Women's. Maybe you could be fine going to South Shore Hospital on the coast or somewhere else that's a lot cheaper. Another very popular and important method here is using price negotiated providers. Again, that's making sure that you're, whenever you can, using direct contracts, that you're sort of freeing yourself from the traditional PPO model, using price quality shopping tools. A lot of this is informed, by the way, by the price transparency rule, which, as you heard about before this morning, will be going into effect January 1st, 2021, where providers will be required to post in a machine-readable format their prices. And so I think we'll get a lot more information, and I think that rule is really going to bolster these incentive programs that have to do with price transparency and with providing education to your employees about which providers they should choose. The diapers and wipes program, I'm sure many of you have heard about. You probably heard Adam Russo talk about that here at Phia over and over again, but it's really worth saying again because, especially if you have a younger population, you can expect you're going to have many pregnancies, and they're expensive. Delivering a baby is not cheap, as most of you know. And again, this is an example where, the way Adam would say it, the same baby comes out no matter where you have it delivered, right? And so going to HR, consulting with HR about what are the options available to you, offering the employee an incentive here, free wipes for a year, or whether it's something else, something that's going to be enough because wipes can be very expensive. Again, look into the tax implications of doing that. There are compliance concerns with each of these programs, but they're doable. They're worth doing. They save the plan a tremendous amount of money, depending on the population metrics of your employee group here. And then another one here, the claim review audit program, where you're providing the employee with 20% of savings that they identify from billing mistakes. And these happen more often than you may think. I know, for young people in particular, they're not thinking about their medical bills and aren't reading through and seeing what was charged. But I've got an example coming up in a few slides that you'll see where one of our employees actually found an error and it resulted in some big savings for them. And so it's worth having a program like this in place. Prescription drugs, the biggest one, right? One of the biggest areas, probably the most expensive area of healthcare right now, only going up. And so anytime you can have an employee consult with HR about their options for using specialty drugs if there's a generic available and their doctor prescribes that or recommends that there's no difference between that and the brand name, having the employee go with the generic drug. Implementing a way to do that in your plan document and your employee handbook is really important to steer people toward these generic drugs. And you can, by the way, work with vendors that are out there in the industry who will scrub your data and help you identify alternatives to these expensive brand drugs. Here's a case study real quick based on a very popular treatment here for asthma, which millions of people have in this country, including some 6 million children. So an example here for Symbicort, which is the brand name version of inhaler here for $328 per fill. Look at the cost of 12 fills versus here the generic, the fluticasone or the salmeterol, which is a generic version here, a lot cheaper per fill. So 12 fills of each medication, you'll see that the plan here in this case would save $2,846. Again, this is for an employee with asthma whose doctor told them, hey, there's no difference in this case for you if you use the generic version. And so how many employees that have asthma wouldn't even know to ask this question to their doctor? How many plans out there would think, oh, it's an inhaler, you know, how many different inhalers could there possibly be? Well, it turns out there's a significant difference in the price. And this is just the tip of the iceberg in terms of other drugs and types of injectables and other devices that employees may need to manage their chronic conditions, where you can really realize some serious savings. Another example I mentioned a second ago here about the claim audit review program. Here's a case where an employee gets the bill here from the hospital for an overnight stay. If you look carefully here, it's a little hard to see on the slide, I know, but you'll see that there's actually 2 beds being charged. The employee got charged for one night. They got charged for an emergency room overnight with bed, and then a private room of $14,000. I'm sure they didn't enjoy any luxury suite experience in the hospital. We know they didn't because they came to us and said, hey, we didn't have a private room. This never happened. And so when we went back to the hospital and said, hey, this is an error in the bill, the charge was removed. And it saved the plan $14,695. And for us, you know, paying the employee about $3,000 is actually worth doing in this case because it's still a net savings for the plan. And it's something that, again, without this program, without the incentive, it's very likely that most employees wouldn't even bother looking at the bill because, again, they're not paying. Well, once they hit their out of pocket, you know, what do they care? But when you really give some examples like this, and if you can explain to your employees, look, here's the kind of stuff you may see, here are the kind of savings you might realize, you're going to get buy-in from them. And again, as long as you're in compliance with tax rules and making sure that you're not interfering with your other existing contracts, a lot of these programs, these employee incentive programs, are one of the best ways to realize cost savings for the plan. And they're, again, what I would call entrepreneurial self-funded plans. They're doing this left and right. Okay, now moving on to the new normal that we're in. This is another area where, again, an entrepreneur is looking around and saying, what is the current status of healthcare? What trends have we seen? What information can I gather now to inform my decision about how I'm going to run my plan? Knowing about ongoing litigation, knowing about regulatory changes that have occurred or will occur ahead of time and planning for them is very important because it lets you change your process, change your strategy, and in some cases, change your plan language in reaction. And so what we're talking about here, of course, is more so the healthcare changes. Obviously, every employer has a workplace to worry about. That's a different session, right, about COVID and how to prepare. But in terms of healthcare, there are some serious impacts we've seen both really outside of COVID and inside of COVID in terms of the impact to our industry. And those three we'll talk about at the end of the presentation here. But how do you navigate the new normal? What are the things that you want to be aware of that'll make you a smarter self-funded plan, that'll make you a more innovative self-funded plan? And here are those things. Understand your obligations, right, related to COVID-19 and frankly to all federal and state laws that apply to you. Review your policies after being informed of these new changes. Make sure your policies say what you want them to say. Make sure you're in compliance with what the law requires, but also that you're making changes to your plan, to your policies, to add things like incentive programs, to make sure you have the right leaves of absence that you need to have. Make sure you don't have any gaps with these documents. Make sure that you don't inadvertently cause yourself to not get a stop loss reimbursement, which we're seeing more and more of lately. Update your plan language accordingly. Review your claims. Not just those that employees get that may have billing errors, but make sure that you're actually, for these high dollar claims, are you doing medical reviews? Is the plan sponsor actually being attentive to these complicated cases where there's high dollar claims? We see tons of them come our way in terms of having to review them to make sure that they're getting the answer right. As we're saying, again, there is an uptake that we've noticed in the industry in what I would call these costly stop loss mistakes, where a lot of mistakes are being made in part due to changes in regulations because of COVID, where deadlines have been extended and people are messing up enrollment, things like that. Don't find yourself as a plan making the easy mistakes, right? Again, a good entrepreneur is already going to have graduated from the school of not making easy mistakes, and they're onto more sophisticated things. But don't lose sight of these issues that you already know can be a problem. Don't make mistakes on eligibility. Don't make mistakes on medical necessity and applying plain language properly. And then finally, review your service contracts. Every few years, you should be doing this anyway, but make sure that you're getting the right savings that you were promised or that you think is reasonable, right, through your PBM, through other partners that service the plan. Make sure that you're getting your money's worth, because at the end of the day, that's the ultimate goal here. And again, in terms of opportunities, which is what I would transform every topic that we cover here that's about a regulatory change or a litigation update, think of it as an opportunity now in which you don't have to wait for Congress, because the truth is not much is going to happen between now and the end of the year on a lot of these important issues I've listed here, where because they failed to pass a new relief package, these issues are not being addressed directly by Congress. So surprise billing, price transparency, we know the president's acted on that, but not Congress. The telehealth policy extension, not happening at the moment. More money for testing, provider relief, COBRA subsidies, which is something that would be a really big help for our industry. We can't rely on those things to happen by Congress right now. And so you really got to pay attention to what already has happened, right? And look to see what you think will happen and to act now. And if you do that, you'll be ahead of the game and you'll be able to make changes now. And you'll be ahead of other plans that don't make these changes. One of the biggest things, by the way, to be aware of that could change the industry really inside out is this case involving the individual mandate, which you probably heard about before, but is now at the point where there'll be an oral argument this November. And the question will be whether the Affordable Care Act itself has to fall, whether because the end of the individual mandate was upheld by a lower court, does that mean that the Affordable Care Act itself has to be removed? If it does, then that'll be a huge change required, obviously, for self-funded plans and in terms of what their plans must cover. The employer mandate itself could go away. So that's the ultimate sort of million-dollar question to have answered later this fall. And I would say don't worry too much about that if you're a self-funded plan, because the truth is there's not much you can do until the Supreme Court hears this case. There are, however, things that have happened and that you should be aware of and that should inform your practice now and keep you on your toes. I mentioned before these costly stop-loss mistakes. Those stem in part from this final rule here published by the DOL and the IRS, which has extended certain deadlines because of the outbreak period that they've defined under this pandemic, where essentially 60 days after the emergency period ends is when many of these deadlines will now run up to. And so the emergency period is still in effect, by the way, until the end of this year. And it could be even pushed further out. We'll see what Congress does. But keep in mind, pay attention to COBRA, timely payment of premiums, when coverage must be elected, when you must provide notice. Don't get these things messed up, because if you do, you're going to find that stop-loss carriers are on top of this stuff, and it could cost the plan a lot of money. And so what smart self-funded plans are doing now is they're shoring up their processes and their procedures. They're making sure they have enough people, or that their TPA does, to make sure that they are aware of these changes and they don't want to get caught flat-footed. Another big one here is appealing an adverse benefit determination. Again, being aware that plan members now have an extended period of time to file an appeal. And so everything kind of gets backed up here. The external review request deadline has been pushed out. And so that may cause issues with your stop-loss policy. Right now, it might have to be extended, your benefit period. And you might want to talk to your carrier and say, hey, how will you handle the claims that may get pushed into, the next policy year? Is there a run-out provision that we need to talk about? Can you add one on? How will the carrier handle this sort of massive disruption in what are normally very rigid deadlines? And that's one of the biggest things to be aware of on that front. One other big area here I want to talk about is a new federal rule on copay assistance programs. This is a huge area where a lot of plans have been very, very innovative in trying to deal with the cost of specialty drugs. They've been using, many of them, these certain copay accumulator programs very creatively. The point here is that there were regulations in place earlier that seemed to indicate that you could not apply a assistance amount from a manufacturer to a patient's out-of-pocket maximum. But, and there was disagreement there, but this new rule that was proposed makes it absolutely clear. It leaves it up to the employer what they want to do. It allows employers to count the full amount of manufacturer assistance to the patient's out-of-pocket maximum. So if a patient is choosing a brand name drug because the brand name, the brand is promising them, $500 or $1,000 in copay assistance, that's typically a problem in the industry because in many cases it's incentivizing people to choose the more expensive drug, right? Because, oh, we're going to help you with your payments, so come and choose our more expensive drug, even though there may be a generic drug that does the same thing that's cheaper. And now a self-funded plan is allowed to say, okay, well, if you're going to do that, then we're going to calculate toward your out-of-pocket max, or sorry, we're not going to calculate toward your out-of-pocket max the cost of this assistance, because what's happening is that the assistance would be calculated toward the out-of-pocket max, the patient would hit that out-of-pocket max quickly, and the plan was left on the hook for the whole amount of money. So this new rule provides much more flexibility. It allows the use of copay accumulator programs. And there are literally dozens of them that we've seen in terms of their variation and how they're calculated. And again, that's achieved through your plan language. So look at your internal practices, decide, are you using copay accumulator programs? Should you use them? Again, many employers do because they believe that it is the only way they have, or one of the only ways they have to fight back against what they consider a sort of oppressive steerage toward brand name prescription drugs when there is a generic alternative available in many cases. Okay, moving on to something else here that's important to talk about as well. Another case that you need to be aware of from the Supreme Court, where you had guidance from an agency, HHS, back in June on the rules related to Section 1557 of the ACA, which are rules that are mostly about gender dysphoria and having to cover certain services for those who identify as a different gender. The rule from HHS here in June really narrowed the scope of Section 1557. It narrowed the scope of who was covered, and it eliminated the provision that allowed people to sue if their plan was not covering services for gender dysphoria. What happened later, a few weeks after that, was a Supreme Court case that made national headlines because it was about employment discrimination, but it left open the question about what this means for the earlier rule from HHS, because the Supreme Court in this case here, Bostock, concluded that the Civil Rights Act prohibits discrimination against LGBT people in this area, and it left open the question about what happened with respect to their health insurance. And so the impact on Section 1557 is not entirely clear, and there's going to be more litigation in this area. What it means for you, for those running a self-funded plan, is one, determine if you are affected by Section 1557, and if you are, make sure your plan language is in compliance, and weigh the pros and cons here, right? The pros and cons of not adding benefits or adding exclusions for those who require gender dysphoria treatment, because if you are excluding it, relying on this HHS rule, then you could face a lawsuit based on this later in time Supreme Court case. But if you cover it, and you may not have to cover it, it's an added expense. And so this comes down to, again, weighing the risk, but knowing this information ahead of time, being aware of the issues and of the risks involved will help you, will help the plan sponsor make decisions about how it wants to run its plan and what its level of risk tolerance is. In certain cases here, again, the election might matter, might inform how some of these things ultimately end up. And so I think I would advise probably just waiting, taking a wait and see position for a few months. In fact, on many of these issues related to the ACA, until the Supreme Court case is resolved, it may be safest to do nothing. But again, some plans have a higher risk tolerance level, and in all cases, you should at least be aware of these cases here. One more case I want to talk about that's actually a very clear decision with a direct impact on self-funded plans here is the case about the contraceptive mandate. Again, was a case that was really in three parts, going back to the Hobby Lobby case, where there were various challenges brought to the contraceptive mandate under the ACA. and employers saying that they did not want to provide this coverage, that in some cases it violated their religious freedom. And what the Trump administration has done is they've passed a rule expanding the exemption here. For now, employers with religious or moral objections don't have to provide this coverage for contraceptives. And there was an existing accommodations process whereby the employer didn't have to actually provide it. In some cases, the TPA had to provide it. In any case, this case has made its way up to the Supreme Court, where a number of states challenged the administration's policy, which expanded the exemption. And the court came down on the side of the employers here in a 7-2 ruling, which gives the administration the broad authority to grant exceptions here. And so it's overruling the lower court. And what it's basically saying is if you're an employer who can demonstrate a religious or moral objection, you don't have to provide contraceptive coverage for your employees. And so again, if that's something as an employer that is important to you, and it's one way obviously to reduce cost, if you have the ability based on the Supreme Court ruling now to not cover this service if you feel that you have an objection to providing it. And so we've had questions, people asking us, can I remove coverage here? What language is needed? And the answer is yes, based on the Supreme Court ruling. So definitely worth being aware of that one here. Another federal court decision I want to mention this briefly here because you went into depth earlier this morning on the price transparency rule, just knowing that it was challenged in court like most of these rules have been, and it was upheld. And so what we're seeing now is the rule is scheduled to take effect here on January 1st. You have a number of hospitals who are saying that, COVID's impacting their ability to comply with this price transparency rule. The truth is we'll have to wait and see how the rollout plays out. I think there'll be a lot of confusion. I think there'll be a lot of attempts by providers to sort of be not as transparent as they should be when posting information online. I think you might find that there's a ton of lawyer-like language or contract language that's posted, and the actual prices themselves may be hard to find. We'll see. We also expect that there's going to be an appeal of this case. Again, if it needs to go as high as the Supreme Court, it might. But for now, again, I mentioned before, this price transparency rule could be a game changer because it could provide for your employees a very, very transparent and reliable source of information on pricing. So if you're trying to make decisions or help inform your employees of which providers to choose and looking at price and quality metrics, I think what you'll see is the ability to use the hospitals themselves and look at their websites to find pricing will be a game changer. It'll be absolutely a game changer where the information will be provided or should be provided at the fingertips of employees at home, surfing the web. One other thing I want to mention here in terms of regulatory updates that you should know about if you're a self-funded plan now is these slew of executive orders on drug pricing. So July 24th, the president signed 4 executive orders on prescription drug costs. It's really an area that we hope we'd see a lot of action from Congress on. We haven't really seen any at all. And so we're seeing the action in the form of executive orders. And note that all 4 of them will require the agencies to act before anything actually happens. But a couple of them are very, very pertinent to the self-funded industry here. The first one is probably one of the biggest ones, drug importation, which again is an area that has been discussed really at length. And really there's disagreement on whether or not it's actually allowed or not, or it's really a policy of non-enforcement by the federal government. But this first executive order on importation would allow, in certain cases, for states and wholesalers and pharmacies to import drugs from Canada and sell them in the US. And so that would provide a way potentially for self-funded plans to obtain drugs at a cheaper cost, because if these pharmacies are now legally allowed to import drugs from Canada, then the risk of non-compliance, the risk of fines is essentially down to zero. Again, we'll have to wait and see what this rule eventually looks like, but this is one of the most popular methods, and a lot of municipalities already across the nation are doing this, but the savings you can realize in some cases are as high as 70%, depending on the drug that you're talking about. So this first executive order is very important in that regard because it could provide some much needed relief for self-funded plans in this very expensive area. The second one here, limited to Medicare Part D drug rebates, where essentially the administration saying that rebates offered by manufacturers that are for drugs that are bought by Medicare can only go to the consumer, not to the PBM. Again, it doesn't really affect self-funded plans, but I think this could be a model for eventually what becomes the law or a rule that applies to all drug rebates, right? If not just in the public market, if for private insurance, if this becomes a practice, if they model this off of the Medicare drug rebate reform, that could be a big deal, because I think it would mean that rebates themselves, which in many cases, not all cases, but in many cases, drive the price of drugs up. If they are essentially banned, then the goal of the administration of removing the middleman in many ways will have worked, and you'll, I think, see a lot of pressure, a lot of downward pressure on prices. Number 3 here, related mostly to federally qualified health centers, but again, addressing the cost of insulin, which in particular is very expensive. Number 4 is another one here that's very, very potentially game-changing. This is one of the orders that no one has seen the text of yet. In fact, there was a story about how a reporter took a picture of the president holding up this executive order and tried to read what it said, because it hasn't been released. But this is the, quote, most favored nation proposal that you hear a lot about from the administration, where essentially the idea would be to use an international reference price to purchase drugs at that index. No one knows what the index is, but it would require manufacturers to sell drugs at essentially 126% of what other countries pay, down from 180%. That's what the best guesses of this could be, and that's a lot of money we're talking about here. So this idea that, and the president, by the way, said that he wanted to see drug manufacturers take their own action so that he wouldn't have to do this, but so far they haven't. And so we'll see. Again, this is an area where I think there'll be a lot of challenges, legally speaking. But if you're a plan, you're saying, well, man, I really need some relief. I'm really having trouble with my drug pricing strategy. It's not working. Drug importation is too risky right now, or what should we do? Well, the answer is, again, wait for the first of the year and see how this election plays out. Although in this case, both parties are really in favor of many of these proposals. So I think what we're finally going to see, with an optimistic view, is executive action on this area, because we're not seeing congressional action. But whether it comes in the form of drug importation or it comes in the form of price controls, I think the result will be that regulatory action will provide some relief here for self-funded plans with respect to the cost of specialty drugs. And while we're on the topic of specialty drugs, again, an easy one, and something that the entrepreneurial plans are doing, is they are reviewing their contracts, reviewing their service contracts periodically. Make sure your PBM contract, make sure you know what it says. Make sure you know who owns the rebates we've been talking about here. In many cases, the plan doesn't own them. In some cases, a stop-loss carrier will actually deny reimbursement to the plan if any rebates were issued, even if those rebates are not received by the plan. So if the rebates go back to the PBM, right, some carriers, if they are aware of those rebates, will deny them. So you want to make sure that you know as a plan who owns these rebates, how are they treated, how does my stop-loss carrier treat them? And we've seen cases where we're talking, almost close to $250,000 or more rebates denied under a stop-loss policy. So make sure you know what that language says. Do you have the ability to amend the formulary? If you don't want to cover, the newest gene therapy drug, right, the Zolgensmas of the world that cost, $2.3 million, do you have the ability to change the formulary? Probably don't. And sometimes we've seen some contract language that's rather cute, that it says, yeah, you can change the formulary, but if you do that, then you can't use us as a PBM. And by the way, you also can't use anybody else because there's an exclusivity clause. So you're effectively locked in, right? They make you, it looks like you can change the formulary, but you actually can't. So read the contract language or have an expert read it for you, because oftentimes they're going to be on purpose convoluted in terms of what they say. How is the MAC pricing? Is it transparent? Is it arbitrary? Do you know how the pricing is calculated? Do you have the ability to go to alternative sources to source drugs in other ways, right? Will using a carve-out for drugs, will that violate your PBM contract? Are they using spread pricing, a tactic which usually drives the cost up, which you don't want to see? These are convoluted contracts in general, but they're worth reviewing every now and then. I think you'll find that in the industry, a lot of the PBMs, a lot of the large ones have very similar provisions, but not always, right? And there's some regional PBMs that are really great, that have a lot more flexibility that is desirable by self-funded plans. And so again, looking at those contracts, looking at your stop-loss contract, reviewing your employee policies, all important things that you want to do that a really good entrepreneurial self-funded plan will do. Okay, let's change now in the final stretch here and talk about three opportunities that I think are the biggest ones, or some of the biggest ones, that have really come up because of COVID-19, but also in general, I think the trend was going this way really anyway. And that's here first about mental and behavioral health management. A lot of this you'll hear about in the news lately. This is an area where if you as a self-funded plan are not paying attention to your mental health claims or the mental health of your employees, you're going to face a lot higher costs later on down the road. And so the plans today that are being innovative, that are foreseeing the future, they can tell that a lot of these claims are going to be coming in. They can tell, but if they don't act now, then the employees that they have, which are of course their most important asset, will struggle, and potentially there'll be an impact not just on the health plan, but on employee absenteeism. And if you look at some of the concerns here, that's what we see. We see employees may not show up to work if they have mental health issues that are not being addressed. They may end up on disability. They may get injured at work. And there are tools you can utilize as an employer to deal with this. One of the most important and easy ones is to just have an employee assistance program, an EAP. There are plenty of vendors out there that have these programs. They provide services to employees, the counseling, and sometimes that's all that's needed. Utilization management review to deal with particular cases that employees may have where they have mental health issues or behavioral health problems. And then, of course, pharmacy claims. And we'll go into a little bit more depth of these in a second. But it comes down to plan design, right? You need to use the plan, create a gateway in the plan that guides members, give them information about who they can call to deal with a mental or behavioral health issue, no matter how severe the problem may be. Have a hands-on assessment with licensed clinicians in private practice. You can use telehealth for many of this. And if, again, looking at the stats on this, resolving a problem using an EAP program will cost you a lot more. And in many cases, they are resolved using these resources. And if they aren't resolved in these resources, then you'll see a much more extreme case that will probably cost the plan more down the road. And so review your mental health prescriptions and targeted outreach to increase EAP management and close gaps in care. Again, this can all be done through plan design and working with an EAP vendor who will have the expertise to tell you what they should do. Some other tactics of how you can deal with what we know will be, and we've already seen to be, an increase in mental health claims. Narrow networks for mental or behavioral health treatments with direct provider contracting when you can, because that'll remove the ability for these providers to engage in balanced billing if there's a contract. Aggressive care management under the plan for appropriate levels of treatment at each level of care. Review and audit all the mental health plans you see under the plan. Again, look at some providers out there, not all, and maybe not most, but some may take advantage of the fact that there are mental health claims going up, and they want to see, they might engage in excessive billing, or you might see problems with auto adjudication. Be more careful about that, and another reason to utilize a claim review incentive program. And again, like I said before, employees are your most important asset, and if you want them operating at a high level, you've got to pay attention to mental health treatment and claims, and set up a program through your plan that can help provide relief to your employees. Telehealth and beyond, a huge area here. The use of telehealth has nearly tripled during the pandemic. Here's a study here from Fierce Healthcare about the number of people who view their doctor as their most trusted source of information regarding COVID-19, but only about a third actually felt comfortable going to the doctor's office. We talked about before the number of patients that are skipping the certain services they may need, or they're not having screenings done. Telehealth's a way to fix some of that problem. And about a third of people report using some form of telehealth last 3 months. Most were satisfied, and we're seeing this is on the rise, and this is not really going anywhere. In fact, a study done by McKinsey shows $250 billion in spending could shift to virtual care models because of the pandemic. And it'll be hard to pull that back, frankly. Many people have said that this pandemic has accelerated trends in other areas, such as automation. I think in terms of healthcare, the trends that we've seen moving will be accelerated again, and telehealth is certainly one of those trends. There is a House bill that would permanently boost the reimbursement for telemedicine providers because temporarily, because of the CARES Act, the amount that they receive has been boosted, but that's going to expire at some point. And so there's a concern that providers, they need to be paid a fair amount for their services. And so there is an act out there that would really make it permanent to have payment boosted for these health centers, and that would support and bolster the use of telemedicine, both for the provider and for the patient. And again, on a note that's similar here, related technology trends are gaining ground. We've seen, the number of obviously urgent care centers as an example of this, but also these contactless experiences where maybe you go and you are not even engaged in any kind of physical interaction with a provider, but yet you're performing a screening or you're having a screening performed on you. There's all kind of technology that's beyond the scope of this presentation here, but I encourage you to check it out, to look and see what new things are just around the corner. Things like remote monitoring and automated communication. We're seeing a lot more of that. Hopefully one day we'll see the death of the fax machine. We're not there yet, but I do think you'll see a lot more of the trends in this direction continue as we go on. I want to finish up here by talking about direct primary care a bit, because again, along with telemedicine, it's a trend that we're seeing really accelerate tremendously. Effectively, right? DPC is telemedicine and more, because your direct primary care can offer you telemedicine solutions, and home visits as needed, which again, reducing exposure in this time of COVID that we all live in. Performing virtual examinations can be done easily, and customizing care more easily and more readily than your non-DPC models. And so I think what you'll see, again, we'll have to wait on this because there are some hiccups still with with how widespread DPC practices and arrangements can be made. There was a rule released by the IRS in June in which, as directed by the president as part of his price transparency rule, where the IRS is now allowing those with HRAs to consider DPC arrangements to be a qualified medical expense. And so employers could pay their employees DPC costs or also for health sharing ministries through HRAs. The problem, though, is that regulation does nothing to address the issue of HSAs and high deductible health plans, because currently the IRS takes the position that direct primary care is a form of insurance, a form of extra insurance, which along with your DPC, with your HSA and your high deductible health plan, you can't have. And so integrating direct primary care with an HSA, with an HDHP, is going to be a big deal to get done. And in fact, there was a draft provision in the CARES Act that contained language which would have allowed HSAs to be used to fund DPC arrangements, but it was dropped out of the bill, and I'm not sure why. But that would be the kind of language that we need to see that would both allow direct primary care to be used with HRAs and with HSAs, because I mentioned before at the beginning that we're seeing the future of healthcare is the future of high deductible health plans, for better or worse, right? These HSAs pair with HDHPs, and if you can now use those monies to pay for direct primary care, you're really going to help direct primary care take off, which we know is one of the cost-effective models to use in the future. And we've seen already a number of innovative plans take advantage of opportunities related to direct primary care. All right, there's a lot there, but with that, I want to take any questions people may have. Happy to answer them. There was a lot that we covered, but hopefully that was a useful and exciting presentation. And I want to thank FMMA again for inviting me to speak. It's been an honor.
Yes, thanks so much. There was definitely a lot of information there. It's a presentation I think I'm going to have to go back and watch a few times because it was so packed with data and information. And I don't work specifically on the employer side, but I just want people to understand why we take self-funded employers so seriously in terms of a free market solution to the healthcare problem that we have, because a lot of times people associate employer plans as just part of the problem with third-party payment. And that certainly has been the case historically, but I think we feel like a self-funded employer represents at this point in history really the largest cash, proxy buyer out there that might be one of the last defenses against us moving to a completely single payer type system. I think a lot of people don't realize that most of the Medicare for All programs that are being proposed out there include making employer health plans illegal. And I think if more people realize that, they probably would not even remotely want to consider a Medicare for All system, because most people are relatively happy with their employer health plans. Of course, we know and people are realizing that they could be a lot better, and their cost. I think most employees don't realize how much of their paycheck is being consumed by the healthcare plan of their employer. But certainly, an employer offers a valuable service as a like you say, as an entrepreneur, to provide this type of service for their employees, to attract good employees to their health plan. I think a lot of employees choose their employer based on the quality of the health plan.
Yeah. Yeah, I would just add to that, James, that it's something we've seen. You mentioned, the threat of single payer and Medicare for all. These plans would end private insurance as we know it, and that's why it's incumbent on self-funded plans to really make sure that they are acting like entrepreneurs and keeping themselves agile and flexible and keeping costs as low as they can. Because as I said at the beginning, the knock on self-funded plans in some of these studies is that, they're not saving any more money than a fully insured plan. And why is that? Well, we went over some of the reasons why now, but there are things you could do as a self-funded plan, partners you can work with, programs you can implement, plan language changes you can make that will result in savings, and that I think will prove to the industry to show that this could be the way to go to lower costs and provide robust benefits for employees.
Yeah, and I think it shows that there's definitely a need for people like yourself with the Phia group and the transparent TPAs, the few of them that exist, like the Kempton Group and others that are FMMA members, and then the growing number of transparent consultant brokers that are out there. And we'll have John Harvey speak next. So maybe you could sort of be an intro to that and talk about the importance of working with quality TPAs and broker consultants that understand this type of model that you're working toward.
Yeah, it's absolutely critical. I mean, if you have the TPA is essentially, in most cases, employers are not experts in any of these areas, right? They are relying almost entirely on their TPA and other service vendors to run their plan for them. And so it's really important to have a level of trust with the TPA, to have the TPA to be knowledgeable and, as you mentioned, transparent with what are the options available to the plan to help the plan make the best decision that it can make. And again, oftentimes the plan has no clue what providers or vendors are out there in the industry that are good and that are bad. And so the TPA, if it's a good one, has these relationships, has experience with these other carriers, and can, working with their own partners and consultants, sit down with their group and say, hey, here's what we recommend, here's what your data shows, and really steer them in the right direction. Because really, in many ways, a plan is only as good as its TPA.
Right. Well, we have a few questions here for you as we wrap up. I want to make sure we get to these. The first one is, I think it was related to something you said early on in your presentation. You said the question is for the 20, wait a second, let's see here. For the 20% of savings for claims audit, is that taxable income, and is there a maximum you will give them?
Yeah, great question. And I did mention a few times that the tax implications here, and I could talk for 30 minutes about this. The short answer is yes, it is taxable to the employee, but then it's actually doable to make that work. And in our case, I don't actually think we have a cap on our plan, at least for Phia, but I've heard of some plans capping this at $10,000. But really, I mean, if you think about it, why would you want to have a cap at all? But in terms of dealing with the tax issue, again, I don't want to pretend to give expert advice here in this setting, but the answer is yes, it's taxable, but you can implement a strategy with your employee to have them pay over time to deal with the tax liability. And of course, they're getting a chunk of change as part of the savings itself, right? So it'll be expected. The same, by the way, when I mentioned the diapers and wipes, if you're providing the incentive to the employee in the form of cash or cash in kind benefits, that'll also be taxable. So if you're providing, wipes directly to an employee, they're going to have to pay taxes on the value of those wipes. But again, you can do it. You can spread it out over a number of paychecks. You can make sure that they're not facing a massive tax bill all at one time if you do the legwork up front to prepare for that.
Great. Someone asked, will your presentation be posted on Phia's website? I'm sure you guys can do that or plan on doing that, we will certainly have this recording posted on the FMMA website.
Yep, we can post it on Phia's site as well. You'll find it there as well.
Well, excellent. I think, do you have any closing thoughts just to kind of recap? I think what I took away sort of foundationally from an entrepreneurship standpoint is that self-funding is really the starting point, but it's not, it's like saying I'm going to go in business for myself, but if you don't do anything or use it, but it allows you to be innovative in your plan as opposed to a fully insured plan. It kind of is just the starting point, and there's so much information and it's constantly changing that you have to be aware of and run your health plan like it's a business. Yeah,
I think I would say, to add to that in closing, that I mentioned before this phrase where set it and forget it. And I think what's happened, I'm not quite sure why, it could be because of just the extraordinary times that we're living in right now, but that's really, a lot of self-funded plans are being accused of that lately. I mentioned these studies that are saying, hey, is self-funding really much better? I think there's been a number of employers out there who are just so bogged down with other things that they have set it and forget it. They have not paid attention as they should, or not enough attention to their plan. And I mentioned these qualities here of a good entrepreneur, staying informed, anticipating market shifts. Those are things that you've got to keep doing to be able to move quickly to keep your plan viable and to stay relevant in the marketplace. And I think that's the one thing to take away from this presentation would be to know, don't bury your head in the sand. And if you're a TPA whose job it is to do that for your clients, make sure you're doing that as well. Make sure you know what's coming down the pipe. Make sure you're putting your creative thinking hat on and talking with other people in the industry who do the same. Because at the end of the day, we're all in this together and we're all working toward the same goal. Right.
A couple of last minute questions. What progressive TPAs or broker consultants would you recommend? Do you have a source? Obviously, we would say that members of the FMMA, the TPAs that we have joined as members of the Free Market Medical Association, we would highly recommend. And then, the broker consultants out there that are members of the FMMA, as well as the, Health Rosetta is a very good group of transparent consultants out there. What would you add to that?
Yeah, I mean, I definitely agree with everything you said. Kempton obviously being a very important partner for Phia and any groups associated with FMMA. Definitely Health Rosetta. I'm hesitant to give any more particular names. I don't want to get in trouble by leaving somebody out.
Well, of course, yeah.
Take a look at some of the large industry associations in SIA, HCA. See who the leaders are in those areas, and I think you'll find they represent companies that are thought leaders. There are. I'll drop one name. Maybe Dave Conterno is one people have heard of on LinkedIn. He's very, very active and on top of sort of the newest innovative changes we're seeing in the market, and he has his own ideas that are popular in the industry as well. But I would say the best bet is to go to these associations and look at who sits on the board of them and what member TPAs are part of those associations. And those are the good ones, I would say. Some of the good ones.
Yeah, and that's a big reason why we have our annual conference, is so people can network and meet face to face with good guys in this industry. And the last question I'll give you, it says, in your savings example, you use charges. Do you adjust the savings to actual reduction in payments to provider? For example, if the provider was paid a per diem, the extra room charge may not have increased provider payments.
Right. Good question. The answer to that is yes, you should do that. Unless you want to be very generous to your employee, right? The charge amount obviously is not, at the end of the day, not the paid amount. But it's better to make the point looking at the large numbers here. And oftentimes the paid amount is extremely high still as well. But yeah, in terms of operating a model for these, for the percentage of savings, you would typically want to use the amount at the end of the day that the plan would have paid. And that's the safest way to do this. And by the way, I didn't mention this, but again, it's safer for the plan to use employer assets, not plan assets, to pay employees for these kinds of programs. So that's the safest way to do this. And at the end of the day, while it's not in the same bucket, it's really, in some way, it's all the same money, but it's a safer way to do this, to use the employer assets.
Excellent. Well, thanks, Brady. We really enjoyed your presentation. We look forward to having the recording available so we can go and take more detailed notes on everything you said, and appreciate all that you and Adam and the team does at the Phia group. So thanks for joining us today, and we look forward to talking to you again in the future.
Thanks, James. Yeah, it's been a pleasure, and thanks to everyone listening in, and thanks to FMA.
Thanks. Okay, well, we're going to transition right into our next speaker for the day that I think will be a good follow-up to that discussion. From an employer standpoint, we have John Harvey joining us next. Do we have John online? Yes, great. We have John Harvey. He's the CEO of Wincline, which is a fee-only benefits advisory firm that makes employer group health plans understandable to executives and employees alike. John works with self-funded employers to dramatically reduce their healthcare costs. With over 15 years of experience, he is second to none at cutting through nonsense and uncovering waste, fraud, and mismanagement in company health plans. As you might expect, he's a big fan of simple, direct relationships between healthcare providers, the patients they treat, and the employers who pay for care. And if you follow John on LinkedIn or go to his YouTube channel, you'll understand that his big thing is right and wrong is wrong, which ties into a lot of things that Dr. Keith Smith says is just doing the right, and Jay Kempton, our founders, talk about is just doing the right thing is really the starting point of making a lot of this work. So welcome, John. How are you today?
Hey, great. Thanks for having me. I appreciate FMMA for having me as well.
Great. We look forward to hearing what you have to say today. Then we'll have some time for some question and answer after.
Great. Well, I'll dive right in. Today, I'm going to be talking about removing roadblocks between buyers and sellers of healthcare. Personally, I find a lot of fulfillment nowadays when physicians, providers, and employers exchange money direct. It's been a challenge, and we're seeing more and more of that every single day, and it fires me up. Pretty excited about that. So I'm going to dive right in, and we can have some questions and answers afterwards. Little background about myself. No fancy story how I got into the traditional insurance broker industry. I worked at Xerox where I met my wife, and I was selling copiers door to door. Not sure if anyone's been to Phoenix, Arizona in the summer, and it was August, shirt and tie, and I sold a copier to an insurance agency, and they asked if I wanted to come work there. And of course I said, if you have air conditioning in an office I'm in, and they said, here's your cube. So that's how I got into the insurance brokerage industry. That's about 15 years ago. And what I call would be your traditional broker. About our industry has said, you can come make as much money as you want, stay in this box and don't ask questions. And that last one, actually all three of them, doesn't really align with who I am as a person. So I got the opportunity to open an office here in Arizona for a large privately held firm. And that's where I really got exposed to a lot of the greed and inefficiencies in the employer group health plans. For example, when I became a principal of that organization, I got privy to the financials, and I started asking questions. You know, what is that big bonus that we're getting from the pharmacy benefit manager? And it was, why are you asking? And it was with the intentions, don't we have to report this to our clients who are the employers? And I couldn't get a straight answer. And I ended up calling up the CFO of TrueScripts, the PBM, and said, Kevin, you know, help me understand here, this bonus here, hundreds of thousands of dollars, why don't we have to report this? And when people get to know me good, they call me my last name, and he goes, Harvey, you know why? And I said, I absolutely don't. He goes, it's because we're not insurance. So at that time, we would get a 60 cents override for every single script that our clients, their employees, the patients would fill. And so that adds up really quick, and that didn't settle good with me. It didn't seem right. And so I had the opportunity to say, hey, if I could do what I just did now, grow an office and change the way we get compensated, and truly be an advisor, I'm going to do it. And so went all in, and we launched Wincline a little bit over 4 years ago on the notion to make group health care plans understandable. And the biggest thing is that we're fee only. And we're not fee based, we're fee only, meaning we get paid by the employers. Those days of $100,000 slush funds are no more. In 1 year, I got invited from Cigna, I went to the Final Four, Super Bowl, and Pebble Beach. And needless to say, I haven't been on a trip in 4 years and won't be going anytime soon. So, we're changing the way that we get compensated, which allows us to truly advise for employers. So thanks for letting me share that, and excited what we've learned and where we're at and where we're going. Right is right, wrong is wrong is something that we talk about a lot around here. And when you don't have that vested conflict of interest, you're truly able to advise with employers' best interest and lower healthcare costs. And I'll dive into some more details here in a little bit. The biggest thing, and which I really appreciate Jay Kempton and Dr. Keith Smith in establishing the FMMA, is bringing buyers and sellers of healthcare and having them work together. I thought it would be pretty easy to do so, and it's been an absolute challenge. And I'll share with you some of the challenges that we've faced and some of the challenges that we've overcome. Fixing healthcare, people on the right side of change working together. I would like to really take our industry and eliminate it. There is a lot of low value, low investment, a lot of people in the middle that are not contributing to the employers, the health plan's best interest. And some of them are making a lot of money for doing very little. So when we bring providers, physicians, and owners of self-funded plans together, good things happen. And we really need people on the right side of change. And what it means is, making less money and more work. It's not easy. And there's a lot of individuals that are associated with the FMMA that are doing that and are really gaining a lot of momentum. How we got here, won't spend tons of time here. I think everyone's familiar. Someone asked the other day said, hey, John, the healthcare system is really broken. And I don't think it's broken. I think it works exactly how it's set up to do. We buy off a % discount and we render services and get our bill later. There's not another industry that we do that. I used the example the other day, and it's like going to Foot Locker. I didn't know Foot Lockers were still in the mall, so I had to double check on that. So, going to Foot Locker and buying a pair of shoes that are 50% off, and then you leave the store and you look down and they're $2,000. You didn't get a good deal. And so to get transparent, agreed upon prices between the buyer and seller before services are rendered is the goal. Good friend of mine, mentor, employer, and buyer, Tim Spooner, always asks this question, always challenges me is, what problems are we trying to solve, or what problems do we need to be solved? And to me, it needs to be price is one of them. And our archaic billing system right now, in my opinion, is not repairable. It needs to be thrown out and it needs to be redone. We've used reference-based pricing as a safety net, so that's really helped. The other problem that we need to solve is member experience. It's brutal today with fully insured, self-funded, your typical plans. We really need to change that member experience. Patients dread going to talk to insurance companies and doctor's office and billing. And then the third thing is, once you fix those first two, is the right healthcare. Is now you get to address healthcare. and I'll dive in a little bit deeper here in a moment. One of the main things is connecting employers and providers, and I'm going to share some stories. It's just amazing when you get individuals that are like-minded that can pay each other direct for services that are rendered, and it is absolutely vital. Tim Spooner and Dr. Kendrick Johnson started the Arizona chapter here, and it's just so neat to see the momentum taking off. But we have to continue to get employers, physicians, and providers in the same room that are like-minded. Roadblocks today is what we're trying to remove. And some of those roadblocks, one of the biggest thing is networks, insurance carriers networks, insurance carriers alone, the billing system. There's so much greed. The admin burden that are put on physicians. I saw the other day a 16-page pre-cert, prior auth, whatever you want to call it, because there's 14 different names for the same thing, for an MRI on a Friday for a kid that had a concussion from a football game. And it wasn't going to get approved till the following Monday. And so to me, some of those things, a lot of that is just an absolute burden, a waste, and it's taken away from physicians being able to spend time with patients. Employers, roadblocks include fraud, inefficiencies in healthcare plans, TPAs selling you everything you don't need, saying they know how to do, they have all the problems solved, and they don't. Narrow networks, all we're doing is buying down access to care. We have the consolidation of hospitals with physician groups. One of the biggest barriers is physicians just not knowing their worth. The biggest thing I've learned in the last couple of years is in Arizona, Maricopa County, primary care doctors make less, they make 92% of Medicare. And Banner Hospital makes 350% of Medicare after an awesome Blue Cross Blue Shield United Healthcare discount. And to me, everything that has to do with lowering healthcare costs and improving healthcare, the insurance carriers and networks reimburse at a subpar level. So removing those barriers and letting physicians and employers meet each other and do business together is a goal that we're all trying to accomplish. Another barrier is your traditional broker, and I did this for 10 years. Slush funds, when $100,000 slush funds to move a client from Blue Cross to Cigna. That's on top of a bonus. That's on top of another bonus. That's on top of another bonus. It's one of the only industries that the broker represents the buyer and seller. In this case, the buyer being the insurance company, and in this case, the buyer being the employer and the seller being the insurance company. The days where, hey, John, can here's an 18% renewal. Do you think you can sell a 12%? And going to the employer and saying, hey, I think I could negotiate them down and come back to be a hero and maybe get it down to a 9%, and everyone does cartwheels and flips. And at the end of the day, we just got a pay raise for doing that. So a massive conflict of interest. We are fans of you work for who pays you, and getting paid only from employers and not insurance companies allows you to remove a lot of the waste and inefficiencies. There's a lot of, Brady talked about it, and there is an opportunity right now to make a lot of money in a short period of time with some of these vendor bolt-on solutions. For example, bundled surgeries. They won't tell you where it's at. They won't, you can't go onto a website like Dr. Smith where you can see exactly what you're buying ahead of time. and we're creating a less bad network. And what we've done is designed a healthcare plan for employers where it's very simple. We've gotten rid of all those solutions in the middle that don't add value. So this quote right here resonates with us. The highest level of mastery is simplicity. Most information is irrelevant and most effort is wasted, but only the expert knows what to ignore. And so it was really neat. The latest plan that we rolled out has a pharmacy benefit manager. It has a repricer because it doesn't have a network for claims, and it has a medical management, kind of a hybrid medical management, and that's it, and a TPA. So there's no of these shiny solutions that are going to solve everything, and getting rid of all that low value, low return solutions out there has been really key for us, and employers are saving from 20 to 50% off their healthcare spend and improving benefits. And the best thing is they're improving lives in healthcare. Commitment. It is a huge commitment from physicians and providers and employers. The way we've always done it, it's not working. I remember when first started, I wanted to feel and the tone to make sure that we were like Mike Mercer and Willis, that we were the biggest and best. And, you know, how's that worked for the last 30, 40 years? It hasn't. So changing the way employers purchase healthcare and physicians, changing the way they get paid is a huge commitment in time. And it's inspiring every day to see more and more employers and more physicians getting together and working to change the way healthcare is purchased. One thing that I think is vital is getting everyone out of the middle and allowing physicians and employers to get together. And even if you're facilitating a conversation, speaking the same language. Health insurance is horrible when it comes to language. I mean, you know, the PPO about the EPO, about the TPA, about the PBM, I could go on. And I remember calling a physician practice one day and tell them, I was sharing with them, we have 10,000 members that we can steer your way. And the lady asked me, what is members? And it was an aha moment. And so making sure that we understand each other's language and talking very simple language. So now it's not members, it's patients. And that little term like that, it has made a big difference when we have a employee that is a patient that needs to render services. And so just talking patient and understanding the same language is vital. Another one, reimbursement. Often could mean a million things versus, here's your payment. How much is the price? Very simple, straightforward. So the buzzwords of members, reimbursement, out of network, pre-cert, prior auth, those terms need to be universally thrown out and just accepting some common language. Another, payers. We work with mid to large size clients that are all self-funded. And even if they're fully insured, the employer's the payer. And so we call insurance companies processors. They're not payers. The employers are the payers. The patients and the employees are as well. So that has been, I think, very vital when we bring providers, physicians, and owners, executives of self-funded employer group health plans together. Ensuring both parties on the right side of change. And this has been key for us is how do we know that they're in it for the right reasons? Well, from a physician provider perspective, do they understand what the employer is trying to accomplish? Does the employer understand the challenges that physicians, getting underpaid, getting paid, through a network, being dependent on that? So at the end of the day, measuring really how are we measuring that all parties on the right side of change. And from physician standpoint, providers are they going to lower healthcare costs for the employer? Are they going to improve lives, make employees more productive? One of our clients has a MSD solution on site. They're a manufacturer company. Going to see an independent physical therapist instead of going straight to an orthopedic surgeon that's owned by a hospital is a game changer. So incentive alignment is absolutely vital. I just spoke to this a little bit. How are physicians, providers lowering employers' healthcare spend? Very easy. When you put an MSD, MSK solution on site for an employer, how you measure it is a year later, is their spend lower? Is it, if it's not working. So just making a very simple quantitative measurement on that. Oops. How do providers perceive adding value? The hardest thing to get is, what is the price? I was talking to an orthopedic surgeon yesterday. We think reference-based pricing using 8% of Medicare is a means to an end. It's a safety net right now. And I said, he asked, can you name in-year prices? I asked him. He said, absolutely not. I don't even know how it works. I said, what if we just, 300% of Medicare? He goes, what does that mean? So just making sure that we're talking that same language. And what the greatest thing about some of our employers that have adopted that reference-based pricing is we're paying physicians, if they can't name their price, we have to default to 150% of Medicare. And what's great is we tell employees that become patients, go tell your doctor that they're getting a well-deserved pay raise. And I think from the bottom of my heart that everything that has to do with lowering healthcare, insurance companies reimburse at a subpar level. It's wrong. It's not right. It's unfortunate. You can look at everything that has to do with lowering healthcare. 40% of healthcare spend is from hospital facility charges. Specialty drugs is the other one. Getting specialty drugs done in a doctor's office. The more expensive the drug is, the more money they make. That's not adding value right there. Huge here. It's the word that it's hard for me to say is transparent because it's used so much in our industry. I heard it the other day, a pharmacy benefit manager, PBM, say, we are hyper transparent. And I thought that was pretty interesting to hear, as if transparent wasn't good enough. And so just knowing the price on the front side that the employer and the physician provider can agree upon before services are rendered. It's, you would think, fairly simple, and it's one of the hardest things to get physicians and providers to do. And we're making a lot of progress. Physicians are now knowing they don't need a network. They're understanding their worth. They're understanding, we don't have to get paid below Medicare to get individuals steered to us. So transparent providers, physicians is absolutely vital. I'll disagree a little bit with Brady on, I don't know how we determine quality without price. Once we get two specialists or two doctors in an area that will publish their prices, and let the employer, let the patients determine the quality after that. So I think there's a lot of talk about quality ratings and steering them. We have some nurses on site. We ask who not to go to. Ask some anesthesiologists who not to go to is the way that we can determine a little bit of quality on that. But I think we're getting ahead of ourselves and trying to define quality without price being transparent. this is a big thing. Getting physicians and providers together has been really neat to see physicians understand what employers, specifically some large employers, are dealing with. The rise in healthcare costs are eroding wages. They're losing competitive edge. So understanding the problems that they're trying to solve, if it's a manufacturer, maybe something they're doing on the line is not allowing to produce the widgets at the speed they need to. So really having physicians go in, even on site to the employers, and walk around and look at the working conditions. So just making sure that there's alignment between employers and physicians is absolutely vital. I'm not going to hold back here on some roadblocks. I'm going to show some actual examples here. So I apologize in advance if Cigna's on the line here, if United Healthcare is on the line. Nothing personal, it's just actual examples here. So maybe you guys, if anyone is on the line with those organizations, can earmuffs it for me. That'd be great. So I'm going to dive into some roadblocks right now. Jay Kempton, one of the few mission-aligned TPAs out there. Most TPAs, historically, TPAs of third-party administrators, we look at it, there's 4 main components of every single healthcare plan. No matter what, if you're fully insured or self-funded, you have your third-party administrator that processes claims, that administers the plan. You have your pharmacy benefit manager, your PBM. You have a stop-loss carrier that drives all your risk. And the last one, PBM stop-loss, we don't have any clients with the network anymore. So almost forgot about the 4th one, is a network, where you rent or lease a network to get access to care and to be able to purchase healthcare off a discount. Basically, in other words, you pay to get ripped off. And I'm going to show you, this is an actual example. We've taken off the employer name and employee names as well. UMR is owned by United Healthcare, and they're the largest TPA in the nation. They're larger than 2 through 10. They refer to themselves as an independent TPA. We know they're not. And what they do with out-of-network claims, they call it their cost reduction savings. And what they do for out-of-network claims is they take this billed amount right here and they negotiate it down. There's nothing easier to do to negotiate when you don't have a network, because you're not obligated to pay and get ripped off. So here, a billed amount of I'll use this one, $51,000. They negotiated it down to $1,083. So they saved $44,000. The question is, why are they billing $51,000? But it's billed charges. It's an arbitrary made-up number. So UMR, self-funded, TPA, self-funded employer, they made on this claim right here. You can see this provider right here. They made $14,340 on I would think, a very simple negotiation. And they pay themselves with employer's checking account. And they, want to thank you at the end of the day, by the way. So we have eliminated these in our plans that have UMR and that have a network. And what they did is they increased their admin fee to make up for this lost revenue. You can see here's a handful of claims. They made $31,000 just on this report for June. And I would suspect, if I recall, this is probably 4 or 5 pages long, but this was June, and they paid themselves, they made $31,000 for out-of-network claims. And so we went to them, can we have, no out-of-network, which is called an EPO. They significantly increased the admin to make up for this revenue. And by the way, when they negotiate this, a lot of times, they'll use another network. They'll use an Aetna network to get a discount to pay themselves. I don't know if I've ever seen money be made in such a easy, I think, unethical fashion here. And it's very complicated to get in the details. But if there's any employers on the line that is with UMR, ask your advisor, your broker about the cost reduction savings. Get rid of this. It's not a good deal. Just blew it up here just to see a little more. Again, they save you money, and then they take 30% of that savings that they pay themselves with your money. The employers commingle dollars. So, there's a lot that you can get into that legally as well. So we've seen this as high as several $100,000 for one employer. Just needs to be eliminated. Payment integrity is a huge, not different than going to visit with Dr. Keith Smith and being able to pay in advance and know exactly what you're paying. For self-funded employers, really need to understand and do a audit and understand the payment integrity. There's hidden fees everywhere. Through your claims, here we had a client we picked them up. They were with Cigna and self-funded, and we noticed their fixed costs were relatively low. So of employer group health plan, you have soft variable costs and you have fixed costs that pay for your TPA and stop loss. Well, the administrative fee was so low, all these fees right here were getting put through the claims. I mean, these are quite a few different fees. This shared savings program was actually, if they were able to negotiate an in-network contract, Cigna with a physician that they already have in place, if they were to negotiate it down, they were able to pay themselves 3%. And so if you're with Cigna and you're self-funded, look for these fees in your claims. They're all in there today. So, this is the transparency that we need to get out of these group health plans to truly understand what's driving healthcare. So was another one by the same employer. They don't even have an out-of-network. And so they had an air ambulance, $60,000 that they paid, 2,000% of Medicare. So, you have to stay on top of it. I mean, that's an employee for this company. It's a high-level employee for this company. And so that's the opportunity to reinvest and end this greed and really take control of your healthcare spend. Same employer, same year, same self-funded with Cigna. Again, they don't have an out-of-network benefit. But what they do have is a thing called the Network Adequacy Program. A $50,000 charge came through. And at their discretion, they were able to reduce it to $1,810. And if they were such good negotiators, you'd think they could probably get them at a 50% discount and put them in network. But why would they? Look how much they make. 30% of that is $16,125. So that's why they're not in network. They make a lot of money on out-of-network programs like this that I think should be illegal. I mean, look at this, $50,000 claim. They negotiated it down to $1,800. Look how much they paid. I got fired up on this one. Right is right, wrong is wrong. They returned the money to the employer because the employer was not going to settle for anything less than a full refund or legal issues. So, just doing the right thing and fighting for the right thing at the end of the day and spending the time. The problem, a roadblock, is the traditional brokers in our industry. For 10 years, there was no reason I would have ever looked at this. There's just no incentive. There was no education on, you don't want to challenge the insurance companies because that is who pays massive overrides. I mean, when you have billions of dollars in premium and your override retention is 3%, to challenge them is not going to be, it's not welcomed by the management team. The best thing about the problems that need to be solved and the roadblocks that we move, the medical management, the network, the barriers of care, all the things that we spoke about, is now we get to talk about healthcare. And I'm not a healthcare physician. And what's neat is, now we get to work with like-minded, mission-aligned physicians and really solve healthcare. So on this one right here, this was a client that doesn't use a network. And the guy got a call the day before he was supposed to go in surgery. This is in Reno at Renown. And they said, we don't take your plan. And it was paying 150% of Medicare. Again, not a fan of naming the price of healthcare, but they wouldn't name it. But they said we're not going to take the plan. And then I spoke to this individual, and they were going to take out his entire rectum. And I'm, again, not a doctor, it just didn't seem right. And so called up Dr. Smith and saying, hey, can you give a second opinion? Can we? And so got a second opinion and came back and said, relatively, Kevin just needs a small procedure, and I got permission to use his name. And the best thing, he went to Oklahoma, employer paid for it all, and all in, it cost $24,000. It's great that the employer saves a couple $100,000, but the best thing about it is they got the right care at the right time, the right place, at the right price. And so this was an actual email that went out, and all-in cost here. But really what it's all about is this, is the member fully recovered, life-changing, to the fact that he is now a capable, loyal, productive employee and is back to work, versus the care that he would have got that wasn't needed and that would not have been a productive employee, not have the quality of life. Yes, it saves, $200,000, but this is what it's all about right here. Employers have the opportunity to really take their group healthcare plan, get rid of the barriers, the roadblocks, and really improve lives. Another one, and I'll wrap up here so we get some questions, is we have employers that saved from $10 million spend down to $6 million, but what kept failing is the member experience. They would call into a TPA, not Kempton TPA, they'd call into several other TPAs, and the member experience wouldn't get handled correctly. So we went to employers and said, hey, would you hire a $50,000 to $75,000 employee nurse maybe to manage this line item of $4 million that you're saving? And they said yes right away. And so we developed a member champion. And since we're fee only, it's a Wincline employee, but the employer pays for it 100%. And why it works, there's nothing in between that employer's member champion and their patients and their employees. So we have a member that Brazo Hospital is a big one here in Arizona, and they called the day before and said, we don't take your plan. And they didn't even recognize it as healthcare, as a health insurance at all. And they wanted to right then sign a $38,000 letter of agreement. And at the end of the day, they didn't recognize it. And the cash price was $7,000. And so, no $38,000 cash price. And the employer said, great, awesome. Well, can we wire them the money? And Brazo Hospital, it's a big hospital, said, wire? We've never been asked to take a wire. And I think that sums it up. Those barriers of care, exchanging between employers and providers. I mean, they don't take a wire. There's 15 different ways I can pay for my truck payment, but a Brazo Hospital has never been paid direct by an employer. So unfortunately, the employer had to do the good old paper check to them. Dr. Vela, hand surgery. This was one of the most fulfilling stories that I've seen lately, is getting a like-minded physician and be able to name the price up front. We had a member that needed carpal tunnel and 2 surgeries, and he named his price, and the member champion helped him. And we're removing all the people in the middle, and the member champion for this was able to get the physician's price, to get the anesthesiologist's price, the surgery center's price, and we paid them in advance. And it's really neat that we're seeing more and more of that. You see the price right here, below Medicare. And Dr. Balat said it was a fair and reasonable price. And so needless to say, he's you know, we steer a lot of patients that way. So really neat to see there. I'm going to wrap up here just so we have some time for some questions. Here's a hospital here in Arizona, and we had a TPA. This is a reference-based pricing program and no network. And they came to us and said, you know, the hospital all of a sudden, they want to sign a direct agreement. We don't need direct agreements. If there's a direct agreement, it's going to be between the employer and the physician. You know, there's no TPAs, advisors, brokers are finding value in creating a less bad network. And the TPA said, you know, they're willing to do 20% discount off of bill charges. And we don't speak that language. We don't purchase healthcare off 20%. They don't have a network. And then they came back, oh, great news. They're going to do 25% off discount. And we asked the question, well, do you know what bill charges are for that hospital? The average bill charges here for physicians at this hospital was about 1,800%. Excuse me, for facility. Facility's 1,800% bill charges. So 20% off that's not a good deal. Look at the physician bill charges. Big difference here between hospital and physician. If I was those physicians, I don't know if they know, I would be angered about that. So the point here is we can't buy off a percent a discount. We need to buy off actual price. Won't go into this, run a little bit out of time. Employers, you know, if you're fully insured, you don't need to go to reference-based pricing. You know, take a step, get with an advisor broker that's one fee only that gets paid by you, the employer, and just take the steps. You know, you don't need to go from 1 to 4, no network, or 1 to 3. Just move from fully insured to self-funded. Design the program. You don't need shiny solutions. Less is more. And just so you can have it, you know, understandable, so you can lower your healthcare spend. If you're not lowering your healthcare spend every year, you don't have the right advisor, broker, or program. This is a program that we have for an employer that the member, at the end of the day, we removed all the barriers of care. If anything other than red lines, there's no pre-cert, no prior authorization, nothing. If a member goes to this employer hired Spooner Physical Therapy for MSD prior to going to the ortho, they go, no cost share, no pre-cert, prior auth. And so if they go to Banner Hospital and try to get a knee surgery, it's going to be a mandatory second opinion where there's published prices. A couple of our clients, this is just, they went fully insured to self-funded, and you can see their per employee per month cost. Over 7 years later, it's lower than it was in fully insured. That's the opportunity, because that's where we get to reinvest in wages in our community. Fixing healthcare isn't about relying on anything new or flashy. There's a lot of money being thrown at technology and shiny solutions. You don't need it. You need it all out. It's about working with the resources we already have, which includes each other. It's about the FMMA, getting physicians and getting employers in a room, let them exchange money direct. Think Apple Pay at the doctor's office. Physicians are getting to know what their worth is. They don't need a network. And so it's really neat to see. Better care at lower cost. Brady did a great job talking about the misperception of more expensive a procedure is, better the quality. Not necessarily the case, but really getting the best quality at the right care at the right price. almost always involves removing roadblocks between buyers and sellers. That said, you have to have a TPA that's aligned. You have to have a broker advisor that's aligned. I mean, everything that's in the middle between physicians and employer, self-funded employers, that's the roadblock. Get them out, eliminate my industry. Hopefully someday that will happen, because that means buyers and sellers will be working together. And, you know, this is, and with this slide here, you'll recognize the roadblocks are being removed when you start making progress, meaning when your healthcare is getting reduced and the benefits are richer, or you don't have deductibles, you don't have those copays, that means you're making progress. So I appreciate it. Thanks for everyone's time, and hopefully you found the time well spent.
Excellent. All right. I appreciate that. And, you know, when I watch, hold on. Can you see me?
Yeah.
Okay. Yeah, when you share stories like that, it just gives me even more respect for people like yourself and TPAs like Jay Kempton, the David Contornos, and all the other great brokers that are out there that are doing the right thing. It just shows that the kind of character that you guys have, that you were able to leave a system that, you know, you could have played the game and made a whole lot of money ripping people off, and you chose to do the right thing. And you say that brokers are one of the big roadblocks, and we certainly agree with that. But the flip side of that is that for an organization like us, like the FMMA, to grow and do well and grow our local chapters, you guys are very vital, I think, in helping us bring together the employers and the physicians and get them in the room. So do you have any thoughts on that, and how our local chapters could do a better job maybe of finding the good brokers that are out there to help facilitate that?
Yeah, absolutely. Well, James, thanks for the comments. I appreciate the kind words there. And, you know, I'm inspired because, you know, I get more calls from brokers now than insurance carriers for sure. And I'm inspired because there are a lot of brokers that are the tipping point. It's changing, right? I mean, we can all feel it in the momentum, and what they want to do, they can't within maybe a more corporate structure. So it's inspiring that there's more and more brokers every day that are going out either on their own or joining a firm that aligns with them as a person. So I think it's simply asking, how do you get compensated? You know, I'm a huge believer is you work for who pays you. And if you're getting paid by Blue Cross, you're getting paid by insurance companies, it's not going to align with reducing healthcare spend.
Excellent. Well, we certainly hope that you guys can grow the Arizona chapter, and look forward to working with you guys to help you do that. I have a couple of questions here. One is that, are you integrating occupational health with traditional health plans?
Yeah, absolutely. I think I briefly mentioned here in Arizona, one of the two individuals that's leading up the Arizona chapter, Tim Spooner Physical Therapy. He has a on-site MSD solution with Solve Global, and they're on site with one of our employers, and the whole work comp. I'm a benefits guy, right? But it's definitely impacting both of that, and it's been a great ROI from every perspective, from health to cost.
And related to that, the follow-up question is, will the physicians accept the same reimbursement for the same service, such as an ACL, regardless of whether it is a work injury or happened at home?
Do they mean payment versus reimbursement? Just kidding.
Right.
So the question is, will they the same pay? I don't know. I mean, that's what we're trying to accomplish here, is they should know on the front side. I don't know specifically to, some physicians, if they publish their pricing, yes. If not, who knows? Most likely the physicians there and the providers that are doing that are mission aligned. And I would think it would tend to be transparent and consistent with their pricing.
Okay, great. How do you recommend small businesses implement DPCs into their health plans?
I don't know. I don't know the answer to that one. DPC to me is really the quarterback to patients and employees on complex care in their healthcare. It's absolutely vital. Equal to physical therapy is the quarterback to MSD, MSK for a small group plan. I mean, you just got to find someone in your local market that will work with you. I assume the reason I'm hesitant on that one is that's probably a fully insured group. So, I don't know quantitative there, but I could put someone in touch with that individual. I don't have the answer for that.
Yeah, are you working with many employers that are starting to implement DPC into their plan? Or are there a lot of DPCs in Arizona right now?
Yeah, more and more. The other co-founder of the Arizona chapter is Dr. Kendrick Johnson, and he's trailblazing. So we introduced him to a few of our clients, and it's amazing. I called them up last Friday and said, I was nervous because there's not many claims being processed. The voiding of care, of non-needed care. So yeah, more and more here in Arizona, it's taken off on that.
Excellent. Well, I don't have any more questions from the group, but do you have any final thoughts on maybe some more optimism as to how we can spread this message to more and more people?
Yeah, James, I don't think there's ever been a more exciting time to be in healthcare. I mean, the tone has changed. When I first got into the industry 15 years ago, I wasn't allowed to mention reducing costs, lowering cost. And, today I get to mention the insurance carriers' names and what they're doing for the right reasons, right, on that. And it's because of who we get paid by. And so it's an exciting time. I think the tipping point, the momentum is not going to stop. And I would really get involved in FMMA, understand what Dr. Keith Smith, Jay Kempton, I don't like any TPAs. I get asked that a lot, the PBMs, but it's exciting. Be a student, ask questions, and just ask why 5 times every time you go to the doctor's office.
Yeah, someone did just post a question asking what PBMs would you recommend as a progressive PBM to work with. That's kind of limited on your choices, but we do have a transparent PBM or 2 in the FMMA membership. Do you have any that you work with?
Are they hyper transparent?
Oh, yeah.
I didn't think I would ever be able to recommend a PBM, and I still struggle when I say it, but they're great individuals over there. And we sought out to do a couple things. One, Brady hit on it. You have to be able to do a custom formulary, right? Preferred and non-preferred tiers. Does anyone know what that means? It's not meant for the consumer. And generic should always be lower than GoodRx. GoodRx is a free app, right? So you'll know there's no spread pricing. So yeah, I mean, the only one we recommend, and they still haven't even, they haven't even bought us lunch. We don't take fees, but it's Drexy. Drexy, Bill, and Dave over there, their technology platform. It's feels good to even say that we align with them. They do a good job.
Here's one last really good question I want to ask. Is there any common trigger that should alert an employer that they've been lied to by their broker consultant?
That's a great question.
Yeah, I mean, just as you were saying that, as a broker, there's slush funds where you went to the Masters or the Super Bowl or whatever. Yeah. Well, the brokers are obviously passing a lot of these benefits along to the whining and dining the CEOs and telling them lots of great things. So taking them playing golf. So it's really hard to break that relationship and convince someone that, maybe their close friend that they play golf with on a regular basis is ripping them off.
Yeah. And, I use I mean, it's appropriate ripping them off is, it's things, just simple questions on, we make part of our fee agreement a comp disclosure, right? Like I appreciate Cigna, at least they tell you they're ripping you off. I mean, meaning you can see all the fees there. I appreciate that, right? It doesn't, it angers, it doesn't make me happy, but I would simply ask the broker is how they get compensated. Are they willing to sign a form that just discloses all their compensation? And if they're not willing to do that, are they willing to switch from a percent commissions to fee that month right away? If they're not, and also if your healthcare spend's not going down every month, that would probably be every year. That'd probably be a pretty good reason, because if they're getting paid on a percent of premium, James, that means when they lower healthcare spend, they're getting a decrease. So those are just some probably basic incentive alignment questions.
Yeah, someone asked if you could spell the name of the PBM you mentioned. I'm not sure on that one.
Drexy, DR, I'm a math person. Everyone knows me that I'm a numbers, DREXI. And it was founded by a couple individuals from American Express, and their technology interface is good. But more importantly, you'll never have a drug where it's more expensive than GoodRx, and we have a 3 simple tier formulary. We don't include the gene therapy drugs, and so that means that it's the only ones we've recommended unfortunately to date. I could tell you a lot not to go to, but Drexy does a good job. Give Bill and Dave a call.
Excellent. Well, again, thanks for coming. I think we had some great conversation, great questions as usual from our audience here, and look forward to seeing you in person hopefully soon.
Right on. Thanks, James. I appreciate it. Thank you, everyone.
Thank you.
Bye-bye.
All right, folks, we're going to take a short 30-minute break just to kind of get up and walk around, use the restroom, I guess, come back in about 30 minutes. So we'll start at 4 p.m. Central. We're going to have David Balat join us from the Texas Public Policy Foundation, talk about some state and federal policy initiatives that are going on, as well as we're going to bring Dr. Keith Smith, the Surgery Center of Oklahoma, back to have some discussion with David, which I think most of you will really enjoy. So we'll be right back. Thanks. Welcome back to our final presentation of the day. We appreciate you guys staying with us today. It can be difficult to be part of a virtual conference. This is the first time that I've done this myself, and it's this type of event. So we appreciate you being here. I think you're really going to enjoy the last presenter and the discussion that we're going to have with David Balat of the Texas Public Policy Foundation. As you know, we are very strong supporters of all things free market economics. So sometimes the whole thought of public policy might make people like myself and Dr. Smith cringe a little bit, but we very much respect David and the work that he does. I think we've seen through this COVID-19 situation how important state and local governments are, for sure, because we've seen the response be different all across the country to this, and look forward to hearing what David has to say. And then after his opening thoughts, we'll bring Dr. Smith back and have some conversation. David is the director of Right On Healthcare, the Right On Healthcare initiative at the Texas Public Policy Foundation. He has a broad experience across the healthcare spectrum with special expertise in healthcare finance. We especially respect him even more because he is a recovering hospital administrator, a former hospital administrator, so he offers a very unique perspective on all things healthcare. He has more than 20 years of healthcare industry leadership and executive management experience. He earned the privilege of being invited to testify before the U.S. House Committee on Oversight and Reform in Washington, D.C., and before various House committees. He's very well published in major publications like The Hill, Real Clear Politics, and he's recently started an online Facebook group that's become really popular as well. He can tell you more about that, but I think you have like 1,000 people in that group now, so you're getting a lot of good information out to the masses. So welcome, David. How are you today?
Yeah, I'm well. I just have to say that for those that have stayed on, you really have to question who would stay on at 4 o'clock on a Friday to listen to policy. But I'm glad you're here, and this is a great organization, and I'm truly privileged to be invited to be here to speak and be a part of this conversation. And James, I wanted to thank you for talking about the Facebook page. That growth has been remarkable. In just 3 months, we've grown to over 1,000 members, and we don't talk about just policy. We talk about the stories of the day, and probably the proudest thing, the thing that I'm most proud of, is we have people that are coming to us with their issues, their healthcare issues, and we're providing them with resources. So, having been an executive, I could get 20 things done before lunch, but in policy, that the amount of time where you actually see something happening is measured in years and sometimes decades. So that's been difficult. So seeing how we can advocate for individuals to get the help that they need it feels good, and it's a great part of what I get to do, and I know that the folks that have already been on get to do that on a daily basis, and I appreciate many of the presentations that I've gotten to hear. Thank you for your work. Thank you for the integrity with which you apply your work and caring for the patient. That's why I do what I do. I got into healthcare because of the concern for patients. I believe deeply in the doctor-patient relationship. That's the essence of healthcare. And when we lose that, and we have quite clearly, and everybody has seen it over the years. It used to be that doctors would look you in the eye, they'd sit on that little chair, and they'd put their hands on you. Nowadays, they're in the corner, relegated to being a highly paid data entry clerk for the insurance companies, punching information into the electronic billing record. It's not a medical record; it's a billing record. It's a way to optimize the way that insurance companies pay or don't pay. So we want to get it back to the way that we believe is going to create a more accessible, more affordable, and more efficient form of the practice of medicine. And there's a distinction there too. And I think this group has been providing a lot of distinctions, and I appreciate that. We heard about reimbursement versus payment. That's a valid point. And it's important to see that there's the distinction between the practice of medicine and the business of healthcare. And also, probably most importantly, I don't know if you all can see this in the proper way. I say it so much they made me a mug. Coverage is not equal to care. Insurance, and when we hear politicians in D.C. talk about healthcare, I implore you to let that trigger something in your mind. They are not talking about healthcare. They are talking about health insurance. And that's part of my job, is to educate them and to influence them to start thinking about healthcare, not having insurance be the center of that healthcare universe in their mind, because for many of them, that's exactly what it is. But so in terms of policy, what do we try to do? Really, it's two things. We're trying to fix the existing system, and we're trying to build a system alongside in parallel to try to get that existing system to compete and demonstrate those market forces. Because it is, if we only tried to fix what is there today, it would be very, very difficult, because you're working against people with massive amounts of resources. So we need to do the things like Keith Smith is doing, and many other people that have followed suit, in the DPC community, and all these other models, green imagings, quick MRI. There are a lot of different organizations that are popping up because they see the opportunity. And so we want to make sure that the policy is getting out of the way or supporting what they do, depending on what it is. So let me talk just a little bit about the COVID response. I know James had mentioned that. It's actually quite funny. Let's talk about the lunacy of how elected officials think about healthcare. We had a lot of deregulation in the very beginning. Why is that the case? There was just a great deal of deregulation. It was positive for the industry. There was a great deal of deregulation, and many of them said, again and again, they use the same language. It was to eliminate obstacles that would allow doctors to be closer to their patients so that they could take care of them better during the pandemic. Why on earth were they there in the first place? That's really the question that should be asked. So we are fighting to make many of those permanent. Any of those regulations that were temporarily suspended during the course of the pandemic, and even now during these states of emergencies that are being extended, we are looking in Texas. Our session starts in January. We are looking to make those suspended regulations permanent through having them codified in legislation. Trying to do the same thing at the federal level, but we're working at both state and at the federal level with regards to all of it, because we're just moving at full force at all levels, because we don't want any stoppages and we don't want any obstacles to maintain. Let me talk about a few executive orders, a few bills that we're working on. I'll give you some numbers. There are just, we could go on for hours and hours, but I'm sure that many of you, if there are bars open where you live, you'd probably rather be there on a Friday afternoon. So we're just going to talk about a few of them, and we'll open it up for my conversation with Keith, and then we'll take any questions and really expand upon any other questions you might have, and we can discuss those if I haven't covered it here. But the president had middle of last year, and there was an executive order that really addressed transparency. It was an important order, really focused on the negotiated rates, price transparency between insurers and hospitals. There's a lot that's gone on. There's a lot that's happened. We're going to talk about each of the elements of that order and get to the price transparency. I'll leave that for the very end. But something else that order talked about was direct primary care and qualifying it as a medical expense for the use of health savings account dollars. The Treasury and the IRS, which is the Treasury Department, has long held the position that DPC, direct primary care, is a plan. They want to consider it a second insurance plan, which it's not. They don't take risk. But that's just their position. They've held on to it. And as they've been developing the rules, even after the comment period, they're still maintaining that position. So although there's been a lot there's been a step in the right direction as pertains to many of the rules and the order itself, they're still getting that wrong. So I've been reaching out to the administration and various agencies to say, look, it's not a plan. It's not a form of insurance. It needs to be a qualified medical expense. This is going to bring down the cost. It'll be affordable, and it's good quality care. So let's just get it done. But many of the special interests are opposed to it, and they just don't want to see that happen. The same thing for the sharing ministries and the medical cost sharing groups like Sedera, for one. They'll be talking here tomorrow, I see. I'm also a member, so I'm a little biased. But they want to consider those groups, or they want to include them as a plan or form of insurance. Well, they're not. It's a co-op. And the best example, and maybe they'll correct me if I'm wrong, but the one that I use that helps people understand the difference between insurance and these cost-sharing co-ops is think in terms of the distinction between banks and credit unions. A bank is to a credit union what an insurance company is to a cost-sharing model. And that helps people understand. Usually those that are participating as members are also the ones that are the equivalent of the shareholders. They're bought into the program. It is important for them to be judicious with how they spend their money because they're contributing to the needs of others. It's a community environment. And with regards to both of those, direct primary care and insurance, or the sharing ministries. They're not insurance, but you see that the government is wanting to put them in that box. They're trying to draw those lines around. Why? Because insurance in their minds is healthcare. And like my mug says, coverage is not care. The only card in your wallet that's worth a damn is your credit card, because you get to spend your money the way that you think is best, and you're more judicious with how you spend your money, as opposed to having a copay here or a deductible here. And knowing, I had a CFO I was speaking with recently, and he says, "Well, David, I just prefer insurance to all these things you're talking about because I know what those costs are going to be." I said, "No, you don't. You have no clue. What if there's an out-of-network provider? What if we went through a scenario where there were so many unknown costs and liabilities there that really puts who at risk? The patient. So you really don't have the assurance that you think you may have by having a pretty insurance card. That's something that we need to get past, and that we need to understand that there are other valid coverage options, and ultimately healthcare needs to be about having that direct relationship between the patient and the doctor, and having the doctor help navigate you and being your partner, your quarterback, for how to get the care that you need. I want to share a couple of, or some, we talked about the order, but I want to talk about, I didn't talk about the price transparency. So like many of the other executive orders put out by the president, the price transparency one was immediately sued by the American Hospital Association. They did not want to disclose their rates for a number of reasons. They, as long as you get to hide it, you can make it whatever you want. We saw in the previous presentation about the benefit to both hospitals and insurance companies when the charges are so high. Well, that would go away if you had to post your rates, because if you post your rates, then competitive forces come into play, and that's going to bring down the cost of healthcare. So they absolutely, they have fought tooth and nail, and in their lawsuit, many of you will get a kick out of this. Their arguments were this: the two main ones, really. There were others, but the two big ones were these. One was patients don't really want to see the real prices; they just want to know what the benefits are going to be. So this is a meaningless piece of meaningless order, which that's silly, because most people are cash buyers because of how big our deductibles are. And then even if you're meeting your deductible, you have a coinsurance, and it would certainly help you if you knew what the negotiated rate was, because if you have one system here that's leveraged their market power and negotiated great rates, that's going to give you a bigger coinsurance rate. So it absolutely impacts the patient's out of pocket. The other was that it's proprietary data, and they don't have a right to expose that. It's going to increase the cost of healthcare. They don't think that it should be out there because it's confidential. It's contractual information. Typically, that's false, and let me tell you why. Proprietary data is never put out in public if it's truly proprietary. But aren't those negotiated rates in the EOB after the case, after the fact? They are, because that's how you've seen what each code's negotiated rate is for that insurance company. So they're saying, yeah, we can share that information, but it's not a matter of if you'll get it, it's when you'll get it. Well, we want to see it up front. And they're saying no. So the fact that they put that data on the EOB has eliminated that proprietary data argument that they have. So their arguments were so weak, they lost but in summary judgment. They immediately appealed, and now it's going to the appellate court. We filed with some other partners an amicus brief to just state our position again, that patients need to know the prices up front. It's important, and it's to their benefit, because again, with deductibles where they are, people are cash buyers. As it relates to the price transparency, there are some legislators who have put the language of that order into a bill. Why would they do that? Well, even if it becomes the case, and so the price transparency according to the order is supposed to take effect January 1st, 2021, and the hospitals are in a frenzy right now. But there's also an effort in the Senate and in the House to codify, to make that order a matter of law, because the next president could, by way of executive order, just shut it down that easily. So we want something that is a matter of law. And so Senate Bill 4106 and House Resolution 7676 are companion bills that basically they say the same thing. And they've adopted the language of the executive order, and they're a bill that we're trying to get more co-sponsors. So feel free to call your lawmaker and encourage them to do that if you'd like. But we think it's that important. And there's a group that I'm part of called Free to Care, and they've worked with some other groups to put together something called the Patient Protection Pledge, and it's on their website. But we're asking that lawmakers sign this, saying we want you to be in favor and a proponent for healthcare price transparency. Another very important bill, or two bills, again, these are companion bills. They're identical. One in the Senate by Senator Cruz, Senate Bill 3112, and House Representative Chip Roy, HR 5596. And these really, what it does is it changes how HSA, the HSA laws read and how it would function. A very important aspect is it decouples HSAs from high deductible health plans. It increases the limits for contribution, which that's been needing to be done for a very long time. It increases the limits for contribution. I've said that. Expands the list of qualified medical expenses, which only makes sense. It does include direct primary care. Allows for payments to premiums and to sharing for the sharing ministries and the cost sharing groups. Well, actually, it doesn't include the sharing groups yet, but we're working on that. It also allows for payments to over-the-counter drugs. So an important piece of legislation, something that we want to have move through. It's very difficult at this point in time because in a divided Congress, in an election year, there's not much that's going to get done. So we're really at this point preparing for next year and making contingency plans based on all of these different iterations. So who's going to have House, who's going to have the Senate, who's going to have the presidency, who will be in the majority of each of those chambers will be a substantial indicator of how things will go. But I'll leave it there, Keith, and if you want to open it up for discussion and talk about some things and maybe open it up for questions, I'm open for it.
Okay, I think we're all here. Yeah, Dr. Smith, do you have any comments on what David is talking about there, and then I can follow up on some things, maybe? Can't hear you.
Good to see you, though.
There we go. Is that better?
Right. Yeah.
Yeah, we're in I think it's an interesting conversation as a anti-statist libertarian. I'm against all mandates, including mandating price transparency. I don't think anybody should be forced to do anything. I think the market is powerful enough. However, having said that, the industry is so dysfunctional and so diseased. I think it's a worthy conversation to have whether a mandate of some type bridges a gap and gets us to the next place. Years ago, Adam Russo told me that he thought that reference-based pricing was a gateway drug to the real thing, which is providers, facilities, physicians posting their prices. And I'm wondering if the mandate of some type is kind of a gateway drug, that the ends don't justify the means. but I think it's a worthy conversation to have. I will say this, the one thing that I think is interesting about the mandate, and I emailed Larry Van Horn this morning, the narrative has done a 180. 12 years ago, when I put prices online, I had a tinfoil hat put on my head. Everybody thought I was completely out of my mind. And now those who don't post prices have explaining to do. They're the ones that kind of have the hat on their head. So one thing I will say that the executive order and all these other mandates have accomplished is they have changed the narrative. And maybe that's bridge enough. But David, what's your response to that? I mean, the only policy I think that's good policy is policy which repeals prior policy, or policy after which government is smaller. But how do you respond?
I'm completely in agreement with you. The lack of will on the part of many other think tanks and politicians and bureaucracies to unwind all of the oppressive regulations that have been put in place over the past 70 years, it compels me to have this position, because now we live in a black box. We can't see what's going on, and the only reason, and look, it gives me heartburn to be in support of a mandate. Trust me, but. How do we have a free market? How can I say that I'm in favor of a free market if we can't see what the prices are? They are absolutely needed. They function like the nervous system of this thing called the free market system. And unless we have something to respond to, we're basically dead. So that's why I feel so strongly about it.
Yeah, and I think some of my biggest fears of a mandate was that it would just provide an opportunity for the unscrupulous legislator, which is basically all of them, to redefine what is price transparency, or to sell exemptions or indulgences. And we've not seen the latter, but people in the White House have told me that the former is viral in the White House. There's an attempt, and Jay predicted this. There's an attempt to equate price transparency with the patient's out of pocket.
That's what the hospitals want.
That completely defeats the whole idea. But these people in the industry, none of us should grant the folks who are in charge of the big carriers the gift of ignorance. They are all very bright, but they're all very nefarious and grossly self-interested, and not the least bit interested in any kind of mutually beneficial exchange. So they'll do whatever they have to do to preserve the status quo.
If I may, I'm sorry to interrupt. I just wanted to share something with you, just to dovetail that. So we're talking about policy, and that's the world that I live in right now. Do I think that this is the best way and the most efficient and fastest way to get us to a more market-based economy in this industry? No, I think what the folks that are doing the presenting earlier on are doing is going to get us there faster. Getting the employers, because we have so much of healthcare that's associated with employers, the faster that they can catch that vision and change, that's what's going to change the minds of the legislators and the general populace. The train I'm on rides a lot slower.
When I was talking to Lee Gross about this executive order, the day that it came out, the part that I was most excited about was its focus not on forcing hospitals to post prices, but the part that actually forced them to reveal their contracted rates with the carriers, which both sides had claimed up to that point were proprietary. I had asked John Harvey a question, which James was kind enough to pass on. How does an employer know? What are any common triggers where an employer knows that they've been lied to by their broker consultant? And I would think that a revelation of contracted rates between big hospital systems and the carriers would be a start. In that way, all of the skimming that John and others have shown members of this organization that go on as a part of the exchange is visible then to the buyer. So if these negotiated rates are public, where the sticker shock self-funded buyer can see that, maybe that does provide a lot of fuel for the market to bring discipline that the policy then won't have to bear the burden of.
That's the way that I view it as well. I'm right there with you. It's we cannot live, we cannot continue to live in this opaque environment in healthcare. It's not right. It's just simply not right for the patient, but nor is it for the medical professionals either, because they're taking the brunt of it.
David, are you surprised that my former mortal enemies, some of which are here in Oklahoma City, are now accepting cash referrals that come to me that are really inpatient cases we can't perform at our surgery center? I mean, are you surprised that hospital administrators really are stepping up to the plate and providing pricing to cash buyers that they're outside of the area? These are referrals they would never obviously have any access to otherwise. Does that surprise you?
In large part, it does. I know people refer to me as a reformed hospital administrator, but I always thought I was a good guy. I did that on a regular basis. I had cash prices for CAT scans and MRIs, but it especially doesn't surprise me now, Keith, in the days of COVID, because with all of the shutdowns on their elective procedures, any inpatient business they can get, even at a cash rate, they're going to take. So it's surprising me less and less. I think that they recognize that their stance or their position as the center of that healthcare universe, or much like the insurance companies think that of themselves, is changing.
So you think they're just seeing it as revenue that is coming through the transom they'd otherwise never see?
It flows to the bottom line. You really don't have. It doesn't. There's no overhead that's associated with it. There's no billing, coding, collections. So it just goes to the bottom line and it helps the financials. So there's no downside to the administrator for doing it. They're probably not going to advertise it, but if they have a relationship with you, they'll take it.
Do you think there is any thought amongst the hospital administrators and executives that this kind of provision of bundled pricing, fair pricing is inevitable, that it's coming, they can't stop it. At some point, they're going to have to get on board, and they're just trying to string out the status quo as long as they can? Do you think there's any sort of sense of inevitability at this point?
Not yet. It hasn't hit them yet.
Okay.
Because one of the things that we're trying to change in the executive order is the penalty. And right now the penalty is only $300 a day, not per incident, just per day. So the AHA is actually proposing to many of the hospitals, just pay the penalty. Right. Don't disclose the rates, just pay the penalty. It's cheaper because they know that they'll be losing out on lucrative business. But no, they're so many of them are just so pious and egotistical that they do not see this making an impact. Now, those that do, that see that this is the way of the future, they're going to be the first to market. look at what look at the position that you're in. You did this, you were way ahead of the curve. And I think that there's an opportunity for the hospitals to go that direction.
Okay. That it's always interesting to have your perspective on things. I'm proud to say that Oklahoma is way ahead of Texas on this. So you all need to catch up.
Say that publicly. You know how we are in Texas. There's Texas and the rest of the country.
That's right. Yeah, we see a lot of patients from North Texas. Dallas is known as one of the most expensive venues in the country. Yeah, we see a lot of people coming to Oklahoma to have their procedures. Self-funded companies contract with us from Texas, and I've actually been pretty surprised by this because Texas has been historically no income tax, more conservative state, and I mean, is that changing?
No, it's still where it is, but we have the special interests in Texas are huge, and they exert their power. They throw a lot of money around, and it's been difficult. We, in preparation for our session that starts in January, we've had to develop all of our bills, and we're going to spend the next remaining part of the year on messaging, just educating people and getting them prepared to be engaged. Because when you don't have money, you've got to go get the grassroots. You've got to get people to be involved, to understand and to fight for what is needed to make healthcare more affordable, accessible, and efficient.
There was a law that was proposed. I don't believe it was passed here in Oklahoma. That was an alternative to mandating prices. The idea was to just defang the price gougers by basically saying if you balance bill a patient for a procedure to which was not attached an obvious price on the front end, then none of that information can be turned over to a credit agency. So it basically defanged any facility that would balance bill a patient for a ridiculous amount after a procedure. It did mandate that the hospital or surgery center or imaging center show their prices. It just took away their ability to harm the patient through credit bureaus afterwards for failure to pay the bill. What do you think about that?
I'm not sure that would do any good, even if it did pass, because the credit bureau is the least of the patient's problems. Across the country, we're seeing hospitals, particularly not not-for-profit, tax-exempt hospitals, taking those patients to court.
Yeah, and that's where Cynthia Fisher
and the patients not knowing about those court dates, because many of them don't.
Right.
They end up with a warrant and get arrested.
Yeah, and there's the government, helping us out by incarcerating all these people, riding shotgun for the price gougers. That's the great work that Cynthia Fisher and Marty McCary have been involved with. And there was some town in, I don't remember what state it was, where they actually sued more people there that live there. It was ridiculous.
Either Virginia or New Mexico.
Yeah.
And many of them were their own employees.
Oh my gosh. One of my favorite stories, there was a hospital that employed an ultrasound tech in California, and she had an implanted defibrillator, the battery for which had expired. And when this one expired, it made this kind of beeping noise. So she knew she needed a new battery for her automatic defibrillator. And so she went to the hospital, and they said, well, you're an employee, so let us sharpen our pencil and give you a good price. And they quoted her $180,000. So she told me She found us, long story short, and she told me she had decided she was going to rob a bank. And if she was successful and got away with it, she would have enough money to buy the procedure at my facility. We charged $2,500 plus the cost of the battery, which I think was $11,000. And her family came to her aid and paid the whole bill. She told me if she were caught robbing the bank, she would be incarcerated, and then the prison system would be required to pay for her defibrillator battery change. So she was win-win, with her bank robbery scheme. And she was an employee of this hospital.
Well, that brings up a couple of things.
There's a woman with a plan.
I guess that sort of brings up a couple of things we could talk about is what we can do at a state level, and that leads to one of the first questions that we have from our audience. But we've often talked about what states can do as a buyer because of all the government employees. So that sort of ties in with your state prison question and how they pay for the health care of their inmates probably better than some other things. So yeah, where do we go from there on a state level? Because I feel like ultimately our idea or concept of federalism and decentralization should be that we should be able to look to Oklahoma or Texas and see like who's doing it better and relocate. I mean, obviously, the more the federal government has gotten involved in anything, especially healthcare, the worse things have become. So anything we can do to circumvent the current system at a state level or deregulate as much as possible at a state level, like certificate of need laws, we've talked quite a bit about. Someone asked a question, how would you suggest FMMA chapters to work against certificate of need regulations or laws? So where do we want to go? Can we go from there?
Sure, let's start there. Certificate of need, for those that don't know what that is, it's you basically have to go to the state government and say, Mother, may I open an imaging center? And they will go to a committee made up of your potential competitors and ask them if there's a need for it. And of course, they're going to say no. So it's very difficult to have any new business, new innovation, new competition, which we all understand is the driver for making healthcare more affordable. Getting involved in your state FMMA, getting to know your state legislators, get to know your state senator, get to know your state representative. And better than you knowing them, have them know who you are. When they call you, when you call them up, have them pick up the phone and say, hey, James, what can I do for you? Go to their office, talk to their staff, use the leverage of your organization to go visit with them en masse, and also be a resource for them. But it's important that you get as many people as you possibly can to go out and talk to them and explain, because I'll tell you this, lawmakers don't understand healthcare. They will use the words that we understand. They probably don't understand it. I can assure you they don't understand it to the depth that you do. So regardless of whether they say that they understand or not, explain it to them. And that's the best advice I can give you. We're working with some of our sister organizations that still have CON to test. I go and testify in other states to explain, because I have to. The advantage I bring is that I'm able to counter many of the arguments that the state hospital association is bringing, saying, well, this is a bad policy, and I can usually undercut those arguments based on my experience and where I've come from.
When we first opened Surgery Center of Oklahoma, I was looking forward to never having to deal with government at all, ever, at any level, only to find out that much of what you've said, David, is absolutely true. We were attacked at the State House, and it was important that we establish some kind of a relationship with fair-minded, ethical lawmakers. I've told this before, but it may surprise some in the group, in the audience, to know that the Surgery Center of Oklahoma would not be open. Would it not have been for a Democrat named Fred Stanley? Fred was a very ethical guy from Southeast Oklahoma, and he saw us as the underdog. He saw us as the friend of the little guy. The Republicans, by and large at that time, in the late 90s, were riding shotgun for big corporate healthcare, the big carriers and the big hospitals. And so they were not our friends. Fred was in a powerful position, and so he was able to fend off much of what was coming our way. My message was clear. I said, I don't want anything from you. I will never ask anything from you. All we want is to be left alone. Let the market work. Let us do what we do, and we will show you that prices can come down and quality will go up with no help from the government other than just not be hamstrung to the benefit of the big players. That was very smart, I think, on our part. They all know that now, looking back, they all know that we meant that. The Republicans changed their tune and began to see the benefits of a more free market approach. And now, with almost no exceptions on both sides of the aisle at the State House, what we do is supported. In response to James' question, the state of Oklahoma has 178,000 lives in their self-funded plan, and Jonathan Small and Oklahoma Council of Public Affairs was largely responsible for pushing through legislation that enabled the state of Oklahoma to waive all patient out-of-pocket if a facility that posted their prices like mine was patronized by the member. It lasted a few months, but the political pressure was so great by the carriers that I was made an offer they knew that I would refuse. So they used my pricing and inflicted it on everyone in the state, which I believe is grossly unfair because we are lean and we have real advantages our competitors don't have. Nevertheless, they told me that they needed a 40% haircut off all of my website fees or they couldn't do business with me anymore. Knowing that was an offer I would refuse. And so we hit the ejector seat and got out of doing business with the state of Oklahoma. The fellow who largely was behind that, I understand, has been given his pink slip, which is potentially very good news for the employees here in Oklahoma, because that means that there's an opportunity for this program to return. But when government asks what can we do to help, as long as we have government, government can be a smart buyer. They can step up to the plate and they can buy. Oklahoma County, the largest county in the state, is a client of Surgery Center of Oklahoma. They buy from us. I don't think Tulsa County is a direct buyer. They should be. That's the second biggest county. But the state of Oklahoma should be a buyer. They're not. And the state of Texas, for the benefit of the state employees, should be a buyer from those facilities that will post their prices at all of the various great high quality facilities in Texas.
I was talking to someone here recently who has a surgery center much like yours, and they went to the state of Texas, and the lawyers there were saying, well, we want you to take the risk for so many months after if something were to go wrong. We're not an insurance company. This is a surgery center. So they're going to find all kinds of ways to not make this happen because, look, special interests play a big part.
Yeah, the hospitals don't take that risk. Why should the ASCs? The hospitals make more money if something goes wrong.
That's exactly right.
They do.
That's exactly right. I remember back in the day, never mind. but secondary infections represented a lot of cash, and so you didn't see a lot of effort in keeping infection rates down.
James, were there other questions that came through?
Maybe so. I wanted to ask you guys what your thoughts were on the various states that have moved to kind of a reference-based pricing model to incentivize their state employees to shop. That seems to be a growing trend right now, right?
I think it's important. I think that more states need to do it. It's something that we'll be really encouraging the state of Texas to be doing as well. We have hundreds of thousands of state employees, and we need to be able to provide incentives, just like the employers do. If you want to go use your insurance, great. But if you go use these organizations that post their prices, then you're going to get, a no deductible option for having your procedure done. Create good incentives to promote, the responses that you get that are in line with human nature.
Right. David Contorno and I have argued about this because he knows, I believe, as many do, that Medicare is an illegitimate benchmark.
Yes.
True prices emerge from a competitive market. Prices that are imposed on a market are always wrong. They're either too high or too low. So if I were offered 180% of Medicare, I don't even know what that means. And who's Medicare? There are multiple fee schedules for the different facilities just in Oklahoma City.
Based on the region.
Yeah, hospitals have a Medicare fee schedule and ASCs have a completely different Medicare fee schedule. Shame on Medicare for overpaying the hospitals for the same service provided at an ASC. So
surgery centers are paid based on something called a grouper, and they're it's not, there's no rhyme or reason to it. It's just Medicare is throwing a dart at a dollar amount. I agree with you. I don't think Medicare should be the baseline. It should be based on, what are your costs and what is your markup for what you want to do for your organization that allows you to compete with the market. That's the most important thing. Something I've been said for years, because the last part of my career as a hospital administrator was in turnarounds of hospitals. And the goal, and oftentimes I was laughed at for saying this, but we were able to do it well over 80% of the time. The goal was to make sure that we could operate and cover our cost with our lowest paying payer, which more times than not is Medicaid. We were successful in doing it. There's no reason that Medicaid and Medicare don't cover your costs. For many of these hospitals that say that it's a loss leader, they're either lying or they don't know how to run their business.
Yeah, or they're buying Super Bowl ads, or they're buying out physician practices, or they're buying competitors. I was at a meeting that I was mistakenly invited to. They made a mistake of inviting me, and then they also made a mistake, I guess, of thinking I wouldn't show up. But it was put on by a law firm talking to their healthcare clients, all of whom were associated with hospitals. And one of the speakers that was brought in from Tennessee was emphasizing how important it was to include all compensation received by the CEO, CFO in all forms, benefits, compensation, bonuses in their Medicare cost reports. So there was this concentrated effort to make the hospital's costs look like they were actually higher than they were for reasons that David, only somebody like you can explain to the audience. But I like to quote Jay frequently when people talk about their costs and complaining, their costs are higher than mine at the surgery center. And so, it's hard for them to compete. And Jay makes the very insightful remark and comment that, since when is it the problem of the buyer that the seller has cost issues? It's never the problem. It's never the problem of the buyer. That shouldn't even hit the radar.
He's exactly right. Jay is spot on. It's, you know, the Medicare cost reports. Let me just tell you a little something. We hired consultants to help us design or strategize to optimize how much we could get back from the federal government. And what they would say is, because your cost associated, what you get back from the government has to do with the costs that are associated with the delivery of clinical care. So typically, everything that falls under your chief nursing officer is associated with clinical care. And they said, within reason, throw everything under that C spot. So CNO is over maintenance, housekeeping, because you got to have a clean hospital and you got to have a hospital that's working. But you're throwing all of those costs under that bracket so that you could include it in the Medicare cost report. So yeah, they're out of sight needlessly.
I know of a hospital that has formed a purchasing intermediary that buys all of the supplies that the hospital needs, the hospital system needs, and then marks it up and then sells it to the various hospitals. And so they use these inflated numbers that the intermediary they created for the purpose of marking up the cost of the supplies. They use those inflated numbers to help their Medicare cost reports. I just think, oh my gosh, it's just so bad. It's a cesspool of an industry.
Yeah.
Don't get me started on the middlemen, because the GPOs and the PBMs, and again, from other speakers that have spoken today, and as my good friend Carl Schuessler likes to say, how do you fix healthcare? You get rid of the middle. You bring the patient and the doctor together. As much as you can do that, as much as you can make that happen, you're going to see good things.
And if we didn't already understand or believe that central planning didn't work, what is this, COVID response and how Medicare has responded, and, the payments? I mean, what central planner came up with the amount of money Medicare was going to pay for a ventilator? I mean, just off the, what backroom deal went on to come up with that price just shows that the prices are just totally off. Kristen Dickerson commented that, and the reference-based pricing plans frequently charge as much as 12% of billed charges to administer it. We have one question for Dr. Smith too. How does this Oklahoma Surgery Center coordinate with workplace injuries?
I've offered our website pricing to multiple workers' comp administrators, and no one wants any part of it. And they pay us more than what we have listed online. So I don't completely understand that. I do know that to the extent that medical services rendered are very expensive, that some multiple formula of that is frequently used to make sure that all of the players involved, the lawyer and the patient, receive some kind of a settlement. So there are some incentives that are completely upside down and wrong in workplace injury, workers' comp, where the more it costs, the more money the lawyers make, I think, and the bigger the settlement for the patient. So I don't know to what extent that is at work, but I've offered our services at our website fees to different workers' comp carriers, and no one's interested. Of course, associated with that offer on my part is that it feels like a cash transaction. And a lot of workers' comp is very heavy in paperwork and administration. And that could be the other reason that no one wants any part of it.
Yeah, I have a question from Dr. Cordenway in Southwest Florida, chapter leader down there. He says, any thoughts on a payment scheme whereby the physicians rent the hospital services in order to provide a bed for a pneumonia patient, as an example, or B, provide a surgical or bed for recovery? In other words, open their market to include physicians as well as patients?
I don't know, Glenn. I think you have to be very careful if I'm hearing, and David, I'll make this quick so you can respond. I think you have to be very careful, if I understand the question correctly, that the physician has financial skin in the game. That's a very dangerous and slippery slope where when physicians historically had been paid handsomely to deny or chisel on care, many of them have taken the bait. And so I, for one, would not want to be a patient where I knew the physician's rent profitability was not going to be to their satisfaction if I remained ill. I would probably be discharged prematurely if that, it got to the end of the month and things were not looking good. So I think you have to just very honestly acknowledge the incentives involved and be careful.
I would be very interested if a hospital would even allow that, because you're basically renting your license. That's not going to keep a patient or their family, if something were to go terribly wrong, from suing me, the hospital, if I'm the hospital. So I don't know that there's true risk mitigation in that model, and if they were to do that, I'd be surprised. But I'd be happy to talk with anybody if that's something that's occurring.
All right, well, let's wrap it up with just some final thoughts. Try to give us at least one or two optimistic things to take home to say, hey, with this public policy thing, we might be going in the right direction. I'm skeptical of anything at the federal government, especially with Congress involved and the Senate, because of all of the lobbying that's done at that level. I guess my own personal thought is that, Trump's sort of a populist renegade that doesn't really care about that. And so maybe, he could just be an outlier and they're just going to wait out, his term and however long that lasts and move on.
Again, I appreciate the time to be here. I appreciate the both of you. A great deal of admiration for what you've done and the stance that you've taken over the years. A lot of people look up to you, and it's very difficult in this country to not know who the Surgery Center of Oklahoma is and Free Market Medical Association. I started a coalition of physician and patient advocacy groups called Free to Care before I started at the foundation, and over the time, it's grown to some numbers. Keith, I think you're aware. We're over 30 organizations representing over 8 million people nationally and over 70,000 physicians. And we're getting calls from lawmakers, from the administration, from various agencies. And I'm not saying that to pat ourselves on the back. I'm just saying that it can be done at the local level as well. You're going to get more done at the state level than you are at the federal level. No denying that at all. So within your local chapters, bring together the folks that are willing to go and talk to the lawmakers. Again, it's infinitely more important that they know who you are than you know who they are. So spend time with them, go to their offices. There is the ability to change, just like with the example I think Representative Stanley you mentioned, Keith. Having that relationship, having the ability for that conversation to occur, created a flashpoint that has us sitting here today. Those are available, and those happen all the time. But you got to be present. You've got to be involved. And so not necessarily words of hope as much as admonition. We can't sit on our hands. And as much as we don't like to be involved in government and policy, whether we're advocating for something or defending our position, we've got to be involved and we've got to be a presence. So I'll leave it at that, but that's something that I feel very strongly about.
Yeah, I think I am as optimistic, if not more so, than I've ever been. And I think for me, in the context of policy, it's the extent to which the narrative has changed. And I've made this point enough times, I think, but I'll make it again. It is very interesting from my vantage point, having worn the tinfoil hat with some of these ideas, to now see a situation where those who are not going to abide by price transparency minimal mandates are going to be fined. I mean, that is such a 180, I would say, in a relatively short timeline. I mean, David made the point earlier that sometimes it's years or even decades before you will see a policy initiative see the light of day. And in the 12 years since we put our prices online, we are now seeing those who won't do that subject to fines. So the narrative has changed. The market is powerful. I would say on the policy side, as long as we remain aware of the extent to which lawmakers can say one thing and do another, say one thing and use it as cover to line their own pockets. I think as long as we acknowledge that and let them know we're watching, I think that there's reason to be optimistic in what I would claim is the first in my lifetime deregulatory environment in this industry.
Excellent. This has been a great discussion. Thanks, David, for joining us. Dr. Smith, as usual, want to remind everyone that won't be able to attend our live event tomorrow in Oklahoma City to go and follow our YouTube page, Free Market Medical Association, and you will be able to follow and see, not live tomorrow, but within the next couple of weeks probably, we will have those interviews and presentations online and available. Thanks for joining us today, and feel free to read more about the FMMA at fmma.org. Thanks, and thanks for joining.